a seat. Come over here. So, good morning, everyone. My name is Francesco Montorsi. I'm the Chief of Urology here at San Raffaele. We are delighted and honored to have you here with us to celebrate the management of patients with cancer from a multidisciplinary team, urology and oncology. First thing I would like to say is thank you to all the esteemed speakers who came all the way from very distant areas of the earth. We are delighted to have you here, and thank you so much. Several years ago, we did fight as urologists to have a medical oncologist here with us, experienced in the treatment of patients with geocancers. And we were very lucky to have Professor Cascinu as Chief of Medical Oncology at our university, who did understand our needs and did help us a lot to identify altogether. Andrea Necchi finally got the position and came here to San Raffaele and established the team, and we are all grateful to all of them, Daniele, Laura, Greta, all the others working together in the area with us. So since then, our life has certainly changed, and I can say that the quality of management of our patients has improved significantly. So today we are here to celebrate in a way what we have been doing over the last several years. And once again, thank you so much. I'm honored to have you here with us. This being said, Stefano, you may want to say a few words. Professor Cascinu, Chief of Medical Oncology.
And good morning, everybody. I'm Stefano Cascinu, of course, and I am Director of the Department of Medical Oncology. Just a few words to thank Professor Montorsi. When I joined this hospital 3 years ago, we discussed about the strange situation because there is a strong urology, but there is not the same in terms of medical oncology. And this is strange because of the collaboration. I think that the multidisciplinary team need a different, I think, aspect, including radiologists, pathologists. And thanks to Professor Montorsi, we could have the possibility to enroll Andrea. And Andrea joined us 2 years ago. Now, 2 years ago. And thanks to her job, because in reality, we didn't have investment. We can say that in terms of financement and personnel, Andrea could expand really greatly the possibility of collaboration with Professor Montorsi group, and above all, with expanded the clinical research in urology in the Department of Medical Oncology. I think that I would like very thankful to Andrea for this. And I would like only to highlight that after 2 years, and after 2 years of the arrival of Andrea, now GU and the liver are the two most relevant areas of clinical research in our department. And both of them were not present 3 years ago. So I think they were very thankful for this, because I think that it opens really new rooms for the research and the collaboration. And for this, I'm very grateful to Professor Montorsi for this opportunity to us to expand. And probably we need much more investment. I think that this is a need. Otherwise, I think that Professor Necchi will be very tired at the end of the day, because you have to visit, to check, to patient, to do everything. Even sometimes the secretary part of the clinical research. I know this aspect, but I think that the results in these 2 years, I think really are so relevant that probably we could ask to have something more in order to have a more efficient group in this research setting, in this specific issue of our activity. So thanks very much, and thanks for this collaboration to all the group of Professor Montorsi, and thanks again to Andrea for the opportunity given us to all the group of medical oncologists.
Thank you, Stefano. For the guests coming from far away, San Raffaele is a large institution composed of two areas. The clinical side with patients. We do have 1,300 beds, and I think I can say that every single state-of-the-art facility is here. And in addition to this, the second area is the research department, which groups together several hundreds of researchers. And the two souls of the institution work together. We are all in the same place. And that is relevant because over the last 40 years, we have been able to really bring research to the bed of patients. And this has been improving over the years significantly. So today we have Professor Guidotti, who is a world-renowned basic scientist in the area of hepatitis and infections, who is the Deputy Scientific Director of the hospital, to address you with a welcome also on his side. And Luca has been a close friend over the years. So Luca, thank you for being here.
Thank you, Kiko. Well, welcome, especially to the international guests. It's our honor to have you here. And I should say hello also from Gianvito Martino, who's my partner in the scientific direction. Unfortunately, he couldn't make it, so I'll keep it very short so that you have a busy schedule. So as Kiko said, the San Raffaele University Hospital is a big entity. Actually, the scientists are 2,000. There are more than 6,000 employees overall. And since its foundation, science and the clinic were thought to be two entities that to work together. And urology, including obviously the oncology part, is a big asset of the institute. The institute is organized in departments, divisions, but when there is a specific area of interest, we over the years created internal institute. We have different internal institutes, one on diabetes, one in gene therapy, one in experimental neurology, and then we have the Urologic Research Institute, the URI, as it's said in Italian. And so URI has dedicated space, dedicated lab space, and where Professor Montorsi and colleagues is directed by Andrea Salogna, who is in the back of the audience, and co-directed by Alberto Briganti. And so the Institute has a strong belief on urology, and that was a sort of a challenge that we faced years ago, and I think we're all very pleased of what the Institute has done in these years, and is continually growing as scientific output, as money that the Institute is able to raise, and eventually, obviously, we do hope that there will be direct benefits to the patients. And so, thank you very much for organizing, and thank you, Andrea, for also your input in organizing this event. And welcome.
I think that we are all here, and many will come. And also, if we are a few minutes in advance, I would start, because so we can have more minutes for the discussion. And so the first session for this morning is key advances in geotumors. What have we learned in the last 10 years? And the first speaker is Alberto Briganti, discussing prostate cancer. For the international guests, Alberto has been with us forever, for all his entire career. We met when he was a young medical student and I was a young teacher at this university. Today, he is professor of urology in our unit, and indeed the leader of many research projects, including prostate cancer. And he will discuss with you what we have been doing lately in the area. So, Alberto, the floor is yours.
So thank you very much, and again, welcome you all. again, a big thank to our colleagues coming from abroad and to all of you coming here today to listen to this day dedicated to treatment and advances in genital urinary malignancies. And it's also a big honor for me to be introduced by my mentor, actually, who trained me over the last 15 years or so. So I have been asked to review what have been the main advances in prostate cancer research over the last 10 years, which is a main topic or a huge task, because this is one of the fields where we have the major advancements over the last 15 years, I would say. So I will focus my presentation on three main topics. One is diagnostic advances, the second one, intensification therapies, and the third one is the treatment of metastatic prostate cancer. And mainly what we have assisting is novel, new, and strong data based on randomized control trials, but still many questions still remain unanswered. So what about imaging? We have assisted over the last 10 years to imaging revolution, and imaging actually came in different diagnostic processes of prostate cancer, not only diagnosis, but also staging. I'm mainly referring to MRI and PSMA PET. So if we look at the guidelines, which is our backbone when we do actually treat patients with prostate cancer, we always refer to EU guidelines, which are those based on the highest level of evidence, based on systematic reviews, meta-analysis, and using the correct grade of recommendations. And we see over the last 10 years that we changed significantly in terms of recommendation for MRI. MRI as being included in the guidelines in 2014, suggested for patients with initial negative biopsies and candidate for repeat biopsy. Now MRI is recommended as triage test for all patients coming in with elevated PSA with a suspicion of prostate cancer. So what we know about MRI, there are certainties. So when we introduce MRI in our clinical decision-making process, we certainly decrease the number of unnecessary biopsies. We decrease the rates of insignificant prostate cancer detected. This examination in experienced hands, it has high negative predictive value, which is maintained over time. And of course, when we do biopsy, we should always combine targeted versus systematic biopsy upfront. However, there are gray zones. So the gray zones of MRI are huge and are mainly referred to experience, variability of readers, and quality of images, which makes this imaging approach quite heterogeneous in terms of diagnostic properties. And more importantly, as this step towards MRI changed outcomes of patients with prostate cancer, this is still a big question mark. So when we talk about negative predictive value and positive predictive value, we know that MRI has a high negative predictive value, but what about positive predictive value, which is extremely low, actually. So we have many examinations which are still false positives, and we are doing too many biopsies because of indications for biopsy given the PIRAT score. But if you look at the PIRAT score 4, you have positive predictive value as low as 40%. And this is overall including patients receiving MRI by different centers with different expertises. So what we do now every day in Raffaele Hospital is that we review each single MRI that is coming in with patients with a diagnosis or with a suspicion of prostate cancer. We ask our radiologists to re-review all images. And we found something which is interesting. In more than 2/3 of the patients who are coming in with a PIRATS 4, they are downgraded to PIRATS 1 to 2, which means no biopsy at all. So basically, in 1/3 of these patients, we change our indication for biopsies. And if you look at those guys receiving MRI revision versus not receiving MRI revision, there is a significant difference in terms of clinically significant prostate cancer. So quality matters, and the experience of radiologists is key to give the proper indication for prostate biopsy. However, there are some issues with MRI-guided biopsy, and this issue is mainly due to overgrading. Indeed, when we look at a certain lesion seen at MRI, like PIRATS 4 or PIRATS 5, we actually stick the needle into the lesion, which is what we do every day. The problem is that we might overgrade that specific prostate cancer lesion because actually we pick the lesion very well, but we undersample what is outside the index lesion sometimes. And actually, we sometimes give overgrading because we oversample the index lesion and we undersample what is outside the index lesion. And so we are trying to understand which is the best systematic biopsy schemes to couple targeted biopsy. And this is being reported in this very provocative editorial or brief correspondence that has been published by Dr. Vickers. As you know, he's a worldwide famous biostatistician involved in prostate cancer. And it is some statistical modeling, kind of complex ones, but actually it coupled two different cohorts of patients, one receiving MRI-targeted biopsies, the other one receiving prostate cancer screening, and doing a sort of simulations. Actually, he was able to demonstrate that even if we put the best case scenarios for MRI, like MRI able to pick up all significant cancer, those lethal ones, we do have a number needed to diagnose of 89 to prevent one prostate cancer death. So in a way, we are also over-diagnosing prostate cancer even by using MRI and even by using MRI-targeted biopsies. So what about PET? PET has changed the way we are managing prostate cancer, but we need to be very careful because things seem to be easier, but they are way more complicated because the main question is what to do when we have a positive test. And these questions are mainly unanswered nowadays, but still, there is a trend of prescribing PET, PSMA PET for all patients coming in for prostate cancer staging. And even though this is not included in the guidelines, a recent consensus meeting showed that 80% of experts involved in a panel consultation, they do prescribe PSMA PET upfront as primary staging, even though this is not highly recommended or truly recommended by the current guidelines. So the real question is what to do with a positive PET, because all the studies have been based on conventional imaging, and now we have patients coming in with a positive PSMA PET, which is not detected by conventional imaging. So what to do? And the risk here is to base our decisions too much on positive PET, and then maybe to undertreat the primary in patients with disseminated diseases. And we now have the evidence, even based on conventional imaging, the treatment of the primary matters in prostate cancer if we are dealing with oligometastatic disease. And then PSMA PET has also false positives. And this is also very true in patients receiving, for example, fluorinate agents. I've seen here Professor Fanti coming in, and he will talk about these differences between gallium and fluorinate PET and PSMA PET. And we now are moving, or have moved towards fluoride PET, which actually is not good because it has a lot of false positive findings, especially in the ribs. So we are now changing our indications based on something which we consider being state-of-the-art for prostate cancer staging, but it's not. And we still need to do some secondary confirmation for these lesions with increased costs and reduce and minimization of somewhat resources that we have nowadays. What about in the recurrent setting? Well, PSMA PET has indeed a big role in the recurrent setting. And the guidelines are very clear in saying when you have patients with recurrent disease after either radical prostatectomy or radiation therapy, you need to give PSMA PET. In all patients, very clear, no other things, just do imaging, and then you decide upon what you see imaging. And here comes the problem, because sometimes you see something at PET in the oligorecurrent disease, maybe or mainly in the early recurrent setting, you see some spots and you say what to do. The natural consequences of these is to give metastasis-directed therapy, so to irradiate the mets or to remove the metastases. And we explored these. We were actually the first to explore these in the so-called salvage lymph node dissection setting. Then we go back to the evidence. Are we doing the right thing? Well, yes or no. I mean, all this story of metastasis-directed therapy for recurrent disease detected by PSMA PET is based on 150 patients, not even those. These are 3 phase 2 and not even phase 3 prospective randomized trials that actually showed that if you go for metastasis-directed therapy in a prospective randomized manner, you actually may decrease the initiation of ADT, and you may increase the rates of cancer control early after therapy. But what about long term? No data about that. So we are actually changing our attitude based on 100 patients randomized in 3 phase 2 studies. So we need to be very careful. And the guidelines are also very careful and say that if you go for metastasis-directed therapy, you need to do it in a proper study, which must be in a way at least approved by your local ethical committee. Despite this, the train has left the station, because then we go back to the experts, and the experts say, well, why not? In 80% of the cases, they do prescribe metastasis-directed therapy, even without strong evidence. And these are the so-called major experts in prostate cancer that every year meet in Lugano for the APCC meeting. So something to think about for the future. So once we have PET and we have MRI and we detect prostate cancer, in many cases we do actually have the diagnosis of high-risk disease. And one of the main topics of the last years have been what do we do with high-risk prostate cancer? How do we manage that? And of course, we have two options. One is surgery, and the other one radiation therapy. I'm not going into the debates, which is useless to do either surgery or radiation therapy. What is best? That's not the issue. The issue is that whenever you do something, you have to do that in the right and proper way. And over the last 10 years, we have seen that radiation therapies have been way better than us in producing high level of evidence. They did prospective randomized trials and actually have been able to show that if you go for radiation therapy, that should be a combination therapy with long-term ADT, that's we all know. But recently, for patients with very high-risk disease by the Stampede group, and we are honored to have here Dr. Clark as one of the main actors of these great collaborations, of great group study. They show that if you add abiraterone 2 years together with long-term ADT, together with radiation therapy, in patients with either CN1 disease or very high-risk prostate cancer, you actually have better outcomes. What about surgery? Surgery has been different. So over the last years, we tested everything together with surgery, neoadjuvant chemo, adjuvant ADT, neoadjuvant ADT, neoadjuvant novel agents, but all failed. It's not that it was a real failure, to make a long story short, but actually there were disappointing results. So nowadays, guidelines do not recommend any systemic therapy coupled with surgery, except for patients with node-positive disease. And the same might apply to radiation therapy. So when I started to deal with prostate cancer, we overtreated many patients with locally advanced prostate cancer with adjuvant radiation therapy. And then we realized that many of these patients were overtreated because many of these patients would have never occurred even without adjuvant radiation therapy. And eventually, we did have the trials. And these big 3 trials, phase 3, prospective, randomized, they clearly showed that if you compare adjuvant versus early salvage radiation therapy, there is pretty much no difference. The clinical endpoint in this case was progression. We are not talking about survival, but still their curves completely overlap. So the urological community has moved over the last 10 years from adjuvant radiation to early salvage radiation therapy, going in the direction of de-intensification of therapies when patients are treated with radical prostatectomy. However, a word of caution, because all the 3 trials I showed you with the overlapping curves, actually they included very favorable patients. So those patients with seminal vesicle invasion, only 20%. Patients with node-positive disease, pretty much 0. Patients with high Lesion score, 8 to 10, 20%. So this is not actually applicable, strictly speaking, to what we see nowadays, at least in this hospital, when we treat many patients with the locally advanced prostate cancer. So the third big chapter is metastatic disease, and we have a big revolution in this setting, okay? So when we started 10 years ago, 2012, there was mainly ADT. Then we played a bit with androgen deprivation therapy together with bicalutamide, and we did some form of combination therapies. But it was mainly ADT alone or together with bicalutamide, and things changed significantly. And this is one of the biggest change that we've assisted over the last 10 years, because now when we're dealing with de novo metastatic disease, we do have a lot of options. And this is not only ADT alone, it's not any longer ADT alone, it's ADT plus chemotherapy, which is docetaxel, or abiraterone, or apalutamide, or enzalutamide. Now we are trying to understand which is the most appropriate therapy for which patients, but still we have these options, which are anyway not the only ones, because now we even entered in the triplet therapy era. So it's not ADT plus something else, it's ADT plus a couple of something else in terms of docetaxel plus abiraterone, or docetaxel plus darolutamide, or docetaxel plus enzalutamide. So this is what we have nowadays available, which is a huge step forward as compared to 10 years ago. So see different options, we need to select the proper patients for the proper treatment. And so some of us, like Dr. Stinney, I borrowed this slide from him, and I would like to thank him for this great summary. We try to understand which would be the best patient for the best option. We actually divide patients according to volume of the disease, according to the status of the disease, de novo versus recurrent, of course, performance status, and of course, patient preferences. But still, we are trying to modulate these different therapies according to each patient profile. But more importantly, and this is another epochal change, we actually understood that if we treat the primary, even in the setting of metastatic disease, actually we improve patient survival. And this is, again, another great contribution by the Stampede group, which revolutionized the way we are treating prostate cancer. We are talking here about oligometastatic disease, so patients with few mets, of course, but still treating the primary, in this case with radiation therapy, was able to improve patient outcomes in a significant manner. And this now has been included in the guidelines. If you have a patient with oligometastatic disease upfront, based on conventional imaging in this case, we should go for radiation therapy to the primary together with long-term ADT, strength of recommendation strong. So what about surgery? Well, actually, I have the honor to be here in 2006. And this is our mentor, our surgical mentor. Actually, I don't know who knew this man, but actually was the most outstanding surgeon I have ever seen in my life. And actually, in 2006, he had this idea of doing surgery for oligometastatic prostate cancer. And since then, we have been doing that. So that was like 15 years ago. And we actually treated the first one. And actually, we say, well, are we ready for this? Is really supported? No data, only lab data. No Stampede out there, nothing. Just an intuition from a great clinician. And we ask him, so people will kill us. Yes, but remember, if someone criticizes what you do, that means that you're doing a good job. So actually, we kept on doing this. Everything was approved by our local ethical committee, but we are doing now surgery. There is now actually a small phase 2 study, which I had the honor to publish in European Urologic Oncology. Ashish is here with us. Randomized patient to ADT versus surgery. Not Stampede one, but like the Stampede, it was a phase 3, but this is a phase 2. So surgery is anyway getting out of the tunnel. Let's put it like that way. And this another trial arm from the Stampede, I think that Noel Clark will talk about this, that is trying to assess the main question whether surgery is as good as radiation therapy, whether we should irradiate the metastases that we see at conventional or functional imaging. So there are still many unanswered questions. Last is metastatic castration-resistant prostate cancer, or actually no metastatic as well, because in the last years we also seen a new, maybe artificial space of disease status, which is no metastatic castration-resistant disease. And we do actually available therapies in this disease setting, which is apalutamide, darolutamide, and enzalutamide. So we do actually have improved also the way we treat castration-resistant disease, even in the no-metastatic setting. Well, one might argue that no metastatic castration-resistant disease does not exist. It's not only a matter. It's only a matter of imaging. If we don't see something, it's because the imaging is not sensitive enough. And this has been explored also, and we are doing more and more PSMA PET in this specific space, and we are sometimes trying to give indications for metastasis-directed therapy, even in a castration-resistant disease. But this is outside of any guidelines. There is no specific evidence. So we are doing some treatments which are based on what we feel is correct, but without any evidence. So we should be very careful. Despite this, another consensus meeting, and I had the honor to participate to this as well, showed that all the experts agreed in use PSMA PET, even in patients with CRPC. Which is scary because the train, again, has left the station also in this specific disease setting. And when we talk about metastatic CRPC, what we have seen over the last years, a big revolution in this setting as well. 10 years ago, we talk about mainly ADT plus bicalutamide, then you can remove bicalutamide, you do some anti-angiogenic withdrawal, which we don't do any longer. And then if they progress on ADT, or docetaxel, actually you could give abiraterone or cabazitaxel. So it was mainly chemotherapy for patients with CRPC 10 years ago. And now the revolution is here because look at how many drugs we have available for patients with CRPC. It's not only chemotherapy, it's chemotherapy plus several other agents which have been shown all in phase 3 prospective randomized trials to improve patient outcomes, and we're talking about patient survival. Of course, the big issue is which drug for which patient or which treatment sequence. This is mainly an answer in many aspects. We have understood over the last years, for example, that we should not give 2 consecutive anti-androgen targeted agents, for example, that we should give chemotherapy instead of these in patients progressing after docetaxel. So we have some new ideas on what to do, but still there are many data that we need to provide regarding the optimal treatment sequencing. In conclusion, so there has been a huge revolution in prostate cancer over the last 10 years. It's really difficult to summarize all these in few slides, but the main revolution was introduced by imaging. But imaging can lead to wrong decisions based on feelings rather than strong data based on prospective randomized trials. And we have changed the way we are treating metastatic disease. The answer is clearly yes. We have many options available both in the castration-sensitive and in the castration-resistant disease phase, but we still need to address many additional questions, and we hope this could be the basis of further collaboration for future studies. Thank you very much for your attention.
Thank you, Albi. This was a wonderful talk, and I think that we will have the 3 talks all together, and then we will discuss all the issues on the table. Please mark your questions. And so next speaker is Andrea Necchi, discussing for us bladder cancer. Andrea and ourselves started working together many years ago. And when he was still at the National Cancer Institute here in Milan. And I think that the collaboration peaked when he came to us proposing the PURE study, the PURE 1, that is the use of neoadjuvant pembrolizumab in the area of invasive bladder cancer. And quite fast, we pulled together more or less 150 patients, I think, that probably 90% of them were operated upon here. And then that was a paper published in the JCO that became part of the recent history of treatment of those patients. And since then, Andrea finally got a position of Associate Professor of Medical Oncology here. He's now the leading individual in the area of GU cancers. We work together all day, himself and his team that has been developing over the years. So life for us has changed in better since Andrea was here with us. So the floor is yours. And I'm happy to introduce you today.
Thank you, Professor, for this very nice presentation. I'm so proud to be here and to have such kind of estimated colleagues and so many colleagues here and so many friends here. So welcome in Milan. And please don't forget the fact that we have a live streaming on YouTube today. Many patients are still following us by YouTube. And this meeting is primarily dedicated to them. And when focusing on clinical trials and when focusing on the advances in clinical research in disease such bladder cancer, you will see how the life changes and the patient life has changed substantially in these last 10 years. When thinking about how to deal with in my presentation, I think that the best way to summarize the recent past in the development of bladder cancer therapy was by focusing on people that dedicated their career and made a huge advances in the bladder cancer, and then focusing on clinical trials that have been conducted by these people. There's my disclosure. Of course, we as oncologists are putting the roots back to the old times of BCG therapy in bladder cancer. So we are focusing on the last 10 years, and we will focus on the last 10 years of clinical research, but as a matter of fact, we should don't forget the fact that we are still very much close to the standard of care that was introduced quite before in urology, and we are still revitalizing this issue and this opportunity, in particular for non-muscle invasive disease. We'll see in the next few slides. The occasion is good when dealing with the first advances on immunotherapy, on systemic immunotherapy in metastatic bladder cancer, to remember a giant in genitourinary oncology, Nick Fogelsang, who passed away recently. So please make an applause to him for this outstanding contribution and together with Tom Post, we had the pleasure to have him a few weeks ago in San Raffaele. They presented for the first time the results, the primary results of the phase 1 study that included patients with bladder cancer, providing the first hint, the first evidence that we may provide substantial changes in tumor dimension, in tumor metastasis, by looking at the PD-L1 or PD-1 targeting in this patient. This was the first major step in the story, in the recent story of immunotherapy in bladder cancer. Following this phase 1 study, another phase 2 study with atezolizumab monotherapy in patients with advanced urothelial cancer, later line, chemotherapy treated, many lines of therapy. And these two guys, John Rosenberg from Memorial Sloan Kettering and Robert Dreiser, were the first and senior author of a pivotal study that was called the InVigor 210, which was the first phase 2 study to provide evidence of activity of a single agent atezolizumab in far advanced bladder cancer. And based on this, atezolizumab was granted accelerated approval in bladder cancer by the FDA. More mature data followed this phase 2 study. And the third pillar in the story of the immunotherapy development was the first phase 3 study to provide a significant advantage compared to standard chemotherapy in patients in second line, third line bladder cancer. Joachim Bellemont and Dean Bajoran were the first and last author of this pillar, published in the New England Journal of Medicine, the Keynote 45, which was a randomized phase 3 study comparing Pembro with standard of care chemotherapy and providing a new standard of care in Europe as well as in the United States and worldwide. Following these first two pillars, of course, a myriad of other trials provided evidence of new drugs, a lot of new immunotherapies, new compounds, targeted therapy, ADC. We will go through the major steps in the next few slides, but just to summarize the fact that there has been an explosion since 2016 onwards in registration of new studies, in registration of new drugs, both from the European side and from the United States side. And you can realize very easily that since 2016, life has changed substantially and opportunity have changed substantially for bladder cancer patients throughout the clinical stages. What is the most significant advantage, improvement in my view, is may come from when looking at the long-term data from these studies. And these are long-term studies from pivotal study with the nivolumab and with the Keynote 45, looking at the long-term maintained remission of this patient, meaning that also when dealing with patients with far advanced disease, we could provide a cure for a proportion of this patient. Metastatic disease, this is not something new in GU oncology, because you should go back to the initial experience with the high-dose IL-2 with Steve Rosenberg, United States, providing evidence that we could cure some patient diagnosed with advanced renal cell cancer. Here is the same with checkpoint inhibitors. We can cure a small proportion of patients at long term. So that was something that was incredibly unexpected until quite recently. At the same time, we struggled against the first issues, against the first limitation of the drug development in this disease, because when we tried to combine immunotherapy with chemotherapy, we did not realize that we may be successful the same way. And these are the 3 phase 3 studies that provided results so far, trying to combine immunotherapy, checkpoint inhibitors with standard chemotherapy and comparing the combination with standard chemotherapy. And these trials failed to meet the primary endpoint of improving PFS, improving overall survival. Things have changed when we dealt with another different strategy, which was not to combine drugs, but to use them as sequence, to use chemotherapy first, and then immunotherapy as a booster for responders. And this strategy changed substantially the situation. The other struggle was against the biomarker. we are still waiting for the ideal biomarker. We will hear from Jeff Ross and the huge amount of work that has been done in terms of biomarkers by pharma and by colleagues, by academia. But we are still far from the identification of a suitable biomarker to use in real-world practice to select patients who may be the right candidate for checkpoint inhibition, in particular when dealing with combination therapies. Again, long-term data, in this case from phase 2 and 3 studies in first line, long-term follow-up data. Again, you can see here that we are dealing with metastatic bladder cancer, and you see the survival curves provided the long-term from these studies, meaning that also in these cases, also in these studies, a few patients could be cured with checkpoint inhibition as monotherapy. We have the pleasure to have today one guy at under 40, was the senior author of another pillar in bladder cancer story, published in New England Journal of Medicine, the Javelin 100, which was the maintenance strategy, as I mentioned, chemotherapy followed by maintenance avelumab in responders, randomized phase 3 study, avelumab compared to best supportive care, providing statistically significant, clinically meaningful advances, improvement in PFS, in OS, response rate, quality of life, a lot of other endpoints. So another major step was in first line with sequential therapy rather than combination therapy. And these are the data long term, providing a substantial rise in Kaplan-Meier curves for survival, for PFS and overall survival. Then we also focus, and we also have a huge advance in a different approach in this patient, which is a biomarker approach. And we have today the pleasure to have another first author of another pillar in this disease. Johan Loyor was the first author of the erdafitinib phase 2 study. Erdafitinib is a targeted therapy against the FGF receptor genomic alteration in bladder cancer that are found in about 15%, 20% of advanced bladder cancers. And this is the first targeted therapy to be recognized as standard of care in the United States at least, in bladder cancer patients. So another major pillar that was provided by academia industry partnership. And these are the PFS and overall survival curves from this patient already treated with chemotherapy, some with immunotherapy, failing immunotherapy, and then receiving and benefiting from targeted therapy at this time. The other point, the following point was how to best combine immunotherapy with the partner, because we mentioned the fact that we failed to combine chemotherapy, at least based on the data so far. But is there a better partner compared to chemotherapy to combine with immunotherapy? The answer is likely yes. These two guys, John Rosenberg from Memorial Sloan Kettering and Dan Petrilak, were the first and senior author of other important studies, phase 2 and phase 3 studies, the EV201, EV2301, which tested enfortumab vedotin, an antibody-drug conjugate targeting a protein which is called Nectin-4 in patients with advanced disease, providing again another standard of care in patients already treated with chemotherapy and immunotherapy. So another option for this patient that is a standard of care today in the United States, in Europe, and in many other geographical areas. And this is the data, the fresh data presented at ESMO, with a combination of EV and immunotherapy, and we realized that by combining EV and Pembro, for example, in first line, patients who were naive of chemotherapy, of any treatment, we provided overall a response rate that was outstanding, 65%. It was unbelievable until quite recently, unbelievable. And we will see if the data will be confirmed long term with further studies. And then we go to early stages, because as Professor Montosi has mentioned, we started in 2018 testing immunotherapy as as a way of treating patients before radical cystectomy, with just a few courses of immunotherapy. This was, I would say, primarily an educational journey, an educational opportunity for young people to invest their career on this type of model, on this type of approach of treatment, and I think, here there are many young guys, many young investigators, and I deeply suggest them to invest their career in disease model like this one, that are very well suited for doing clinical research, translational research, because you may have a lot of biomarker to enrich the clinical outcome data. And following the pure one, a lot of bubbles, a lot of other studies have been published with immunotherapy or similar strategies in the same clinical setting, providing evidence that we are still at the beginning of the journey. We are still far from a standard of care because the data are still jeopardized. We are in a good shape, we are on the right way, but we are still far from setting a standard of care because there have been people that were smarter than us treating patients adjuvantly rather than neoadjuvantly. And in fact, the first checkpoint inhibitor to be set as an additional standard of care in early stage disease was nivolumab, thanks to the work led by Dean Bajoran and Megalski, another major pillar in this disease. Nivolumab as adjuvant therapy in high-risk disease after radical cystectomy or radical nephroenterectomy, another tool in the therapeutic arena of patients with bladder cancer. And these are the survival, disease-free survival curves for these patients. Another way of looking at the same thing is to look at biomarker. And Tom Pauls, from the atezolizumab study, adjuvant study, quite similar to the nivolumab study, provided the data that ctDNA could be a very strong candidate for biomarker, for a very strong candidate biomarker to use in this patient. And because the ctDNA was prognostic, was predictive of immunotherapy benefit, the clearance of ctDNA during immunotherapy adjuvantly was prognostic in this patient. So a lot of major pillars collected from a phase 3 study with adjuvant atezolizumab, and we will see if the ctDNA will become a new biomarker to use, and we will have a lecture on this later today. We shall move also even earlier in this disease, in non-muscle invasive disease. And this is actually the full revolution, the completion and the closure of the circle of the revolution in bladder cancer, because thanks to people like the guy that is seated in front in this room, Ashish Kamath, John Ballard, Professor DeWitt, they were the leaders of the Keynote 57 study, pembrolizumab monotherapy in patients with non-muscle invasive, high-risk carcinoma in situ after failure of BCG. For the first time, medical oncology entered into the urology department, the surgical urology department, meaning that we should reshape the entire way we treat patients, even within hospital, and we should set things quite differently, also in logistical terms, when treating patients with non-muscle invasive disease, with systemic therapy and potentially with intravesical therapy combined. I would like to close the door with the point that is a very huge point, that is the natural consequence of such kind of revolution, quick revolution, major steps conducted and achieved in such a short time, because we are forgetting too many things far behind of us. And in particular, we have set and we have mentioned a lot of new therapies approved by FDA, approved by EMA, but as a matter of fact, these therapies are unavailable for the majority of people living worldwide. And these are, the colored area are the area in which these new drugs are approved. And approved that does not necessarily mean available, because there are further issues of payment issues, reimbursement issues. Availability is something that is not the same of approval. So you can see here that the majority, the far majority of the geographical areas are still behind of us in clinical research, in development, so we should take care of this when dealing with the next developments. So I would like to close with this point. The first one is the point of safety. I have not mentioned anything regarding safety, but safety is of primary importance when dealing with new drugs, and we are struggling against new issues of safety, new safety signals that for the managing which we are still a bit unprepared, so in particular when dealing with new drugs in early disease stage. The sequential and how to best integrate all these therapeutic options together in sequence or in combination is still an issue. Most people are still far behind of us, as I mentioned. So when looking at the next decade, I would focus on the fact that we are still to fill the gap that we have created in the therapeutic development in these past 10 years, looking how to best integrate the advances that we did by providing these advances to all people worldwide, and by improving the use and integration of all these drugs altogether. Let's say I would like to thank you and highlighting the fact that all these achievements are usually a team effort, a huge team effort. You cannot be successful in clinical research without a team, without a successful team. And I would like to thank, first of all, my clinical research team, the surgical team led by Professor Montorsi, the lab team, and the Urological Research Institute. All together, we could make, and we will make a success as a team, and everything made as a team effort. Thank you.
Andrea, thank you very much. Wonderful talk. And we continue with the kidney cancer. And Dr. Umberto Capitani is going to deliver the talk. Umberto has been also with us since he was a medical student. He's now one of the top players in the area of renal cell carcinoma, part of the EAU guidelines, wonderful surgeon, wonderful researcher, and really one of the pillars of our unit. So Umberto, the floor is yours. Thanks for being here.
Thank you very much, Professor Montorsi. Good morning, everybody. Actually, I'm very excited to be here this morning. I'm going to show you in a few minutes what we have learned in the last 10 years in terms of kidney cancer research. I would like also to thank Professor Necchi, because I think that he put together something very, very special. The program is amazing. And again, I'm very honored to be part of this fantastic program. Actually, I also want to highlight, I think, a very pretty cool thing. When I was preparing these slides, I just realized that the logo of the hospital, so the Raffaele logo, is actually a graphical representation of a kidney, with the renal artery, the renal vein, the renal pelvis. So probably this means that kidney cancer research is and will be very key in the future of the Raffaele Hospital. Anyway, so what we have learned in the last 10 years. 10 years ago, 2012, at the time, the world was ending. You remember the Mayan prophecy? So probably according to the eschatological beliefs that some events would occur on December 2012, the world was actually ending. So what I'm saying that if you take a look to 2012, we had some recommendations that are completely now different in kidney cancer from a clinical point of view, surgical, and also in terms of medical oncology. So have a look to all the stages of patients with kidney cancer. First of all, according to the international guidelines, 2012, surgical therapy was the only curative therapeutic option for the treatment of RCC. And take a look, radical nephrectomy, partial nephrectomy was accepted in selected cases, and only open and laparoscopic surgery were in the field, no robotic. However, now, 10 years later, we have so many options in T1 and T2 kidney cancers that are accepted in all the international guidelines. First of all, active surveillance. We have so many prospective studies that now have been published. One of the most important one comes from the US, the the registry, Piero Orazio is one of the PI of the study, and now we have also the long-term follow-up of patients observed in active surveillance programs, and we know that if the patient is well selected, we can expect a very low growth rate over the year. We know that less than 20% of patients will have a very fast growth rate, and we also know that after the first or 2 years of observation, the growth kinetics rate stabilized thereafter. So those are patients that can be safely followed, and the cancer-specific mortality with very stringent selection criteria is virtually zero. Another therapeutic options in case of stage 1 and stage 2 kidney cancer patients are all the focal therapies that we can use. We have several energies, and again, we don't have randomized clinical trials, but all the retrospective studies confirm that at least when the tumor size is smaller than 3 centimeters, we can safely use all these options. And then, unfortunately, for urologists, also new treatments are coming. For example, the stereotactic ablative body radiotherapy. This is the last publication in Lancet Oncology just a few days ago. And now we can treat with this kind of external radiotherapy also organ-confined disease. And what I think is very exciting is that the authors took a look to many outcomes. These are almost 200 patients. But if we take a look to the cancer-specific survival, and the follow-up was longer than 5 years, we got, especially in patients receiving a single radiation therapy, a very similar cancer-specific survival relative to patients treated with, for example, surgery. And also related to the fact that this kind of external radiotherapy has virtually no grade 3 or 4 toxic effects, and also no effects in terms of chronic kidney disease or detrimental renal function. So again, it's not a good news for the urological department, but probably this is something that will be very important in the next future. Take a look now to the stage 3, so locally advanced disease. Again, we can come back 10 years ago, and in the guidelines, there is no indication for adjuvant therapy following surgery. And actually, also in the years later, we thought that probably there was no field for adjuvant therapy because all the randomized clinical trials that were published using, in comparison to placebo, all the TKIs were completely negative. So probably we were thinking, okay, probably it's true, adjuvant therapy is not useful in kidney cancer patients. However, last year, 2 years ago actually, was published the Keynote 564, that was this very important randomized clinical trial using pembrolizumab, so not a TKI but immunotherapy in the adjuvant setting, and for the first time we could see a significant benefit, at least in terms of progression-free survival, because the overall survival is not mature, but we'll see in the next future. But we see a significant benefit for progression-free survival for patients receiving pembrolizumab after nephrectomy. Obviously, not in all the patients, but those patients with characteristics for higher recurrence rate in the month later, after the surgery. This is the last update that was published in Lancet Oncology. Now the follow-up is longer than 3 years, and again the hazard ratio of 0.63 was confirmed. So probably we hope at least that we will see also an overall survival effect in the next years, and will become the standard for our patients with a locally advanced disease, or also patients with the metastatic disease that are without metastasis after metastasectomy. That was another criteria of inclusion of this trial. The last part is stage 4, so we are talking about metastatic disease. Again, let's have a look to the recommendation in 2012. At the time, cytoreductive nephrectomy was recommended even in metastatic RCC because there were 2 randomized clinical trials confirming that nephrectomy was important even in presence of metastasis, and the trials were from Mikish and Flanagan, both demonstrating a statistically significant benefit for patients receiving also a nephrectomy. And the medical therapy was based mainly on sunitinib, bevacizumab, and pazopanib. Now everything again, after 1 decade, has changed because nephrectomy is not anymore the standard. Was published an important paper that was the Carmena trial comparing patients receiving sunitinib alone or sunitinib plus cytoreductive nephrectomy. And again, unfortunately for the urologists, but the trial was negative. This means that sunitinib alone was not inferior to in comparison with sunitinib plus nephrectomy. However, as you know, this was based on sunitinib, so a TKI inhibitor that is not anymore the standard. Now we use immunotherapy, and also we have very frequently in clinics symptomatic patients. So my point is that probably also in the field of immunotherapy, cytoreductive nephrectomy has still a role, but not in all the patients as it was 10 years ago. And finally, also the drugs completely changed. Sunitinib is not anymore the standard. Now we have combination therapy. These are the 4 combinations that are approved at least in the European EAU guidelines. So the combination are immunotherapy plus immunotherapy or immunotherapy plus TKI inhibitors. The second part of my presentation is related to what changed in terms of research and clinical and surgical point of view in the last 10 years. First of all, functional outcomes. 10 years ago, all the urological research was focused on many surgical aspects, so ischemia time, bleeding, complications, and so on. What we understand now is that probably patients' outcomes are even more influenced by other things, especially from comorbidities, frailty, cardiovascular events, renal function, so many other things that should be considered in the urological research as well as in the medical oncology research, because probably are going to affect even more significantly all the outcomes. For example, chronic kidney disease, so a functional outcomes, is probably difficult to see the correlation, but a patient that is going to develop CKD is also an effect in terms of cancer-specific mortality, because CKD can lead to a loop in which the immune system is both activated and suppressed, and finally leading to an uremia-related immunodeficiency with a loss of function of lymphoid cells, attrition of telomeres, a lot of things that leads to a premature immunological aging. And also the CKD may decrease the physical and mental health status of the patient. So you can see that the preservation of the renal function may also have an effect at the end of the day to the cancer control in that specific patient. The second point is frailty. So especially in the medical oncology literature, but now also in the surgical research, we understood that besides age and comorbidities, the so-called frailty that is related to age and comorbidities, but is not the same concept, is a very, very important predictor of all our outcomes. And to be able to understand which patient is frail means also to target this frailty and maybe to improve all the outcomes. I'm talking about also complications, transfusions, length of stay, and also the economical burden to cure our kidney cancer patients. So this topic that 10 years ago was completely neglected nowadays is one of the most important things also in all the trials that are ongoing. The third thing is related to the fact that centralization of the cure is a key to improve patients' outcomes. This was one of the most important publications in European Urology in 2018, showing that the quality of what we do in terms of surgery, for example, is going to affect not only functional outcomes, quality of life, and so on, but also in an independent way, also the overall mortality of the patients. And this means that how we centralize the care, how we interact with the medical oncologist and all the doctors and that are involved in the care. This is going to change the long-term history of our patients. And final, genomics. Now we have so many papers showing that if we can understand within the tumor, but also in the germline of the patient, which is the chromosomal complexity, the diversity, and so on, we can at least predict and hopefully in the next future also to choose the best treatment according to the fact the patient will have a low risk of progression or a very slow progression or a very rapid progression. We are starting to analyze this. Probably is not still a standard of care, but will be the next future. And indeed, what I show you in these few slides is that in the last decade, everything changed for patients with kidney cancer, but probably in the next decade will be even more changes because still we don't have any biomarker in screening, detection, prognosis, prediction, and follow-up. I mean, there are several papers, there are several ongoing trials, but no biomarker is nowadays the standard, in clinical decision at least. Radiomics, because still we are using standard imaging to characterize our patients. Professor Briganti showed you regarding PSA, PSMA, PET, a lot of things that unfortunately in kidney cancer are not still the standard. We will have a more tailored clinical decision. Drugs are coming, new drugs. And finally, as I told you, probably SBRT, especially in combination with immunotherapy, will become the standard in the oligomet population and probably also in patients with organ-confined disease and also disseminated metastatic kidney cancer. So I hope in these very few minutes to giving you a summary of what happened in the last decade. It was a very exciting decade, and hopefully in the next years we will see even more changing, very important for our patients, for all we do for the research. Thank you very much for this honor.
Umberto, excellent. Take a seat. Andrea, please, yourself. We have 10 minutes for questions, and I have the first for the speakers, but I would like to engage our distinguished guests here. Umberto, you mentioned the issue of the expanding role of genomics. Then I think that all over the world we have the same problem. There are not enough geneticians or experts in the area. So I would like to ask our guests coming from different areas, Noel from the UK, the American friends, what is going on at your own place? Because here in this country, the residency programs for genetics are just a limited number. Historically, those coming out of from those programs would be directed to pediatrics, young children. Interest in genetical oncology has been limited. So I always tell my residents, you should become a genetician today. But then they tell me, how can I do that? And it is difficult also to give them the official profile of being an expert. So, Noel, do you want to start? What is the situation in the UK? Yes, we have a microphone there. I'm curious to understand what's going on at your own places.
Well, thank you, Francesco. And you raise a very important point. We've looked at this in some detail, actually, because clearly there aren't enough genomic experts to go around. And when one multiplies that across the different oncological specialties, GI cancer, lung cancer, and so on, then we have to get skilled up. So our view is that we need to have an educational process for uro-oncologists, by which I mean surgeons and non-surgeons. And we don't need detailed knowledge of genomics to actually understand our disease area. We need to have a working knowledge. So in prostate, this is becoming increasingly apparent that it's important in renal, as Umberto has eloquently described. So we have been pushing back on this with the genetics people. The genetics people have a view, which is, it's our province, you're not experts. We have a view, and that is that you're genetics people, you are experts, but you really can't cover the breadth of oncology. So we have to get skilled up. And there's no question that it's got to become part of the curriculum, not only for junior trainees, but also for the seniors like you and me, because that is a directional thing. And it's important that we engage with it.
What is the American experience?
Mille grazie, great point. Great talks, by the way, by all of you. Wonderful, amazing presentations. Wonderful point, Professor Montorsi. We have similar challenges in the United States. I was actually on the phone 2 days ago with our director of genetics at the Fred Hudson Cancer Center. We're discussing about the need to expand our genetics program, hire more genetic counselors, and have also a pedigree, right, to train the new generation. And there is an unmet need on that. So we're trying hard to hire more genetic counselors, hire geneticists as well, that they can work with them, and expand access to genetic testing. A big trouble we have, and Andrea, you mentioned that in your great talk, that access to genetic testing is a problem worldwide. In Greece, where I come from, there are no genetic counselors, at almost, at most places. So there's a huge unmet need. And of course, to your point, not only the access, but the interpretation. We have like a huge lack. We're lucky at University of Washington Fred Hutch. We have this precision tumor board that we do once a month. And we have people like Colin Pritchard, Heather Chang, and others who help us interpret the results of molecular testing for somatic mutation testing and germline testing, and send genetics accordingly. But this is not a resource for all the centers, so there's a huge opportunity, and we're working closely with the community to provide them access to this precision tumor board, but we need, of course, more resources. We have a way to go.
These are very excellent points and a very good question you raised. At MD Anderson, we are fortunate in that we do have a genetic department, a genetic cancer department with counselors, with researchers, both on the basic all the way to the clinical side of things. We sort of face a slightly different perspective, and it could be a reflection of geography within the United States and the US versus the other places. But we have a resistance sometimes from the patient side about getting genetic testing, whether it's for cancer or germline or others. And for the young folks in the room, I would strongly recommend the book, The Gene by Siddhartha Mukherjee. If anyone hasn't read that, it's a really good read, and it also goes through the whole history of genes and how it's relevant. He writes great books. He's got, the Cancer, The Emperor of All Maladies, The Gene, and The Cell. Very good books to read for any young folks in the room. But we sort of have a different problem. So oftentimes when we, from the oncology side, recommend the patient gets genetic testing and sees our genetic counselor, they don't show up for the appointments. And that's why the patient advocacy groups, such as Beacon for bladder cancer and PCF, have been very important in improving the penetrance of the recognition of genetic counseling and testing from my perspective.
It's interesting, Phil.
Yeah, I think we've sort of had similar challenges at Moffitt. Is we integrate our geneticists heavily in our practice, particularly as mentioned in prostate, kidney, upper tract disease, and I do applaud also the achievements that you've had in kidney cancer in developing a VHL Alliance accreditation. I think it says a lot related to your institution, but I think what we've noticed is what we've noticed across the healthcare field is there's been a retention issue of geneticists at our institution. And as such, I think it has sort of suffered from having them heavily engage in the practice of our patients. And so despite the fact we are always thinking in these younger patient populations to integrate geneticists, I think the challenge now is we can't get them to see the patient in a timely fashion at our institution or even potentially outside. So I think it has been very challenging because we are seeing, for example, in kidney cancer at our institution, younger and younger patients, we're thinking about integrating them, or like in upper tract disease, doing so, but it's just the challenge is we physically don't have the people to see these patients.
Yeah, from the therapeutic standpoint, there is that issue related to the fact that you may identify such a certain mutation or gene alteration, but from this identification to the availability of targeted therapy for one specific disease, there is a huge gap again. I wonder to hear from Jeff Ross. Who is your point?
It's a challenge, of course, and sure. Hi, everyone. It's a great challenge when one is a provider of genomic and genetic information for a patient who's recently been diagnosed with cancer or recently experienced progression of their cancer. When a somatic sample, the tumor cells itself, are submitted, in theory, this is not a germline test and there's no genetic component, it's only genomics. But with sophisticated algorithms that evaluate the DNA extracted, you can call the germline status virtually all the time or nearly all the time. And then you have the problem that the patient is not given permission for germline testing. They're not expecting to have any family implications for their disease. There's no genetic counselor that's ready to get the information and help the patient understand it and decide whether they want other members of the family to be tested. So it becomes a dilemma. You want to report that this particular alteration is both somatic and germline and communicate that, but you can't put it in the report because that was not requested and formally signed and permission given. And what we try to do is inform clinicians that this is germline and somatic in other ways, either deep in the report, in comments, by calling, or other ways. And at that point, either a genetic counselor will be summoned and the patient will get a formal counseling or not, based on the local site and the doctor who's caring for the patient.
I'd just like to stress the role of society like ESMO that provide education booklet and also the ESCAT scale that could help clinicians to identify the target that are very important in daily practice. So I think it's important, there is an important role of this society like ESMO, EU, ASCO for doing that.
You are completely right. We have a question from Professor Ciceri, who is the director of our cancer center. Thanks for being here, Fabio.
So good morning and congratulations for the quality of presentations. I have a question on the accuracy of MRI. So you mentioned that the gray zones are in the positive value assessment. So I'm wondering whether there are projects of artificial intelligence matching, integrating data from biopsies and then the morphology to help in this setting.
Yes, absolutely, and you raised a very important point of the additional role of artificial intelligence for standardizing reports and imaging interpretations. We have Professor De Covelli here as well, who is the chairman of our radiology department. So we have been working on artificial intelligence projects, trying to understand whether we can overcome, in a way, interpretation of imaging and standardizing reports. The thing is, but Francesco may give us further details, is that quality of images we are dealing with sometimes is very, very poor for different reasons and different machines, different expertises. So artificial intelligence is a step forward, provided that the quality of the imaging is good enough to get reliable answers. And I believe that one of the major efforts we are doing indeed is that in that direction. The other thing is, which is still missing in prostate cancer, for example, to improve the PELSD predictive value of this examination, is accurate biomarkers. So we are not there yet to incorporate biomarkers into that specific clinical decision-making process. We deliver biomarkers every day in prostate cancer, but not yet the one which is making a huge step forward.
Very last comment, and then we proceed. Please, Ashish.
I just wanted to comment again upon the, hi, everyone. Just wanted to comment on what you just said. At MD Anderson, we've had a lot of successes, but one of our biggest failures was incorporating AI using the IBM Watson platform. Hundreds of millions of dollars spent, and it did not improve upon the radiologist's read because there were a few parts of the AI that could not be quantified well enough for IBM Watson. And if you can't put in the appropriate algorithm, you don't get out the result you expect. So, very good point.
You made the day for our radiologist. So thank you for being with us. We have a full program and we must proceed, and I will leave the chair here to the next speakers.
So thank you very much. I hope you enjoyed the first session of this meeting. So I will kindly ask Professor De Covelli to come to the stage. And it's a pleasure now to chair the session with our chairman of our radiology department, as I was briefly mentioning earlier. And Francesco, I don't want if you want to introduce our first speaker, who is a worldwide well-known nuclear medicine expert in prostate cancer. We have the honor to have you with us.
For the kind invitation, for the level of and the quality of this Uro-Oncological retreat. Thank you to Andrea, to Francesco, and to Professor Briganti. So we can start with the keynote lecture. So the role of PET imaging in genitourinary cancers. And the speaker is Professor Fanti from Bologna.
Good morning, everybody. It's a great honor to be here. Thank you, Professor Montosi, for the invitation, and I'm really delighted and happy. Well, these are my disclosure, a collection, but the most important one is that I'm proudly a nuclear medicine physician. So be ready, me trying to convince you that the skepticism of Alberto regarding the use of PSMA is absolutely out of place, because I'm a really strong PSMA believer. Be aware of this bias, because it's the most important. My talk will rapidly go regarding the use of PET imaging in genitourinary cancer. Will be rapid, because mostly I will concentrate on prostate and PSMA, because it's really our daily bread and butter. So no doubt that I will spend much more time there. And the reason is super easy. I mean, there is an unbalance regarding the number of scans that I'm doing every day for prostate cancer and for the remaining part of genitourinary cancer, which is clearly in favor of prostate nowadays. So that's the reason why I'll keep very short, and I will just refer to the guidelines of EAU regarding the use of PET imaging within adult genitourinary malignancy, and in particular, what's about the upper urinary tract urothelial carcinoma? Well, it's just mentioned very briefly in the guideline that you may try using FDG for nodal evaluation. And that's essentially all we can offer to you. The literature is honestly very, very small, and I'm really happy that one of the largest series that we published jointly by San Raffaele, Bologna, and our institution a few years ago, reporting some hundreds cases. But again, the data are not really impressive, and there's just a sort of little application. And quite similar for penile cancer. The point is the same. With FDG, you can see some more nodes, so you can make a better nodal staging. It's not really something every day done, but it's something that you may use, like in this case, you see, if you have a hot lymph node, you're very much reassured that it's pathological, even if a good radiologist would always make the right diagnosis in this case. And testicular cancer. Testicular cancer, I mean, in seminoma, honestly, FDG has a little more value and indication as compared to the other that I just showed to you. It's not about real staging. It's mostly about evaluation of residual mass after therapy. So what we can do is to discriminate if there is active, viable tumor, or if it's only fibrosis, or at least if the therapy has been effective. We published a few years ago papers, and that's a clear example. You know, you have a residual mass here, which is almost impossible to evaluate with conventional radiology. You have hotspot uptake here, but after treatment, there is still some residual area in the CT with no counterpart. So you can consider the patient as cured, and that's the contribution that we have. And finally, bladder cancer, again. There are several potential indications of FDG for the evaluation of bladder cancer, are not really something that is done so frequently. And again, this is an example for staging, especially, these are again from the paper that we published together with the friends of San Raffaele. Identification of distant MET is clearly much easier if you have the hotspot on FDG. But also, ruling out the presence of metastasis could be helped by the use. So it's essentially about the restaging, which is the overall impression that I have. It's that it works. It honestly, FDG PET has not been designed, like an SUV, has not been designed to run among bison. It's just an occasional opportunity that you have with your system to use it in indications which are not really so fundamental, so important, but nonetheless could be useful. And let's make, a jump in the past, because now I'm moving to prostate, to PSMA, but I will start with really a little bit step back. Because we are talking on something really old. Nuclear medicine, indeed, is more than 50 years old in the game of prostate cancer. With bone scanning, all of you knows very well the good old imaging system for the bone, which is bone scanning. It's been introduced really 50 years ago, and it's really Stone Age to us. It's something that belongs to the past, but it's still around. And it's not only Stone Age because it's, 50 years for imaging is really a long period. To me, it's also Stone Age because of the quality of the images, because they look like cave paintings, honestly. The quality, the spatial resolution and the information are really, really obsolete. So it's something that we keep on doing, but it's not really so interesting to me. And it's very interesting to notice that it's still mentioned in every guideline. If you see the high-risk patient at presentation, they are supposed to have a bone scanning. In any guidelines, either EAU or NNCC or the other guidelines, it's mentioned, do a bone scan to the patients. Why? Do we have a good randomized trial demonstrating that bone scan has a role? Absolutely not. It's just because of tradition, habit. You use something that you have always been doing. So it's something that I'm telling everybody, hey, stop doing that, because we don't have that much of literature. Okay, it has been incorporated in every trial, but that's not a good reason. There were therapeutical trial, not trial demonstrating that bone scan has real an impact on patient management. But nonetheless, it's still done. Next step, little advance, we are moving to something like 25 years ago, choline PET has been introduced. Choline PET, a little bit better, not a real revolution. What I used to say that the images were not really so impressive, but rather impressionist, because they look better, but not the way that we would have liked it. So sometimes I say, okay, it's a glass, which is half empty or half full. The point is very clear, the low sensitivity. Everybody knows, a lot of papers demonstrating we have been using choline. It was much better than the other methods, but at the same time was not good enough to really gain widespread use. But what it comes, 10 years ago, and that's one of the very first patients that had imaging in Heidelberg. It was a gallium PSMA introduction. Same patient, choline, almost negative, just a node here, and a number of nodes seen by PSMA. So that was really a revolution for us, and it's been a revolution for all the field of urology. The data demonstrated a much, much better sensitivity as compared to choline, so it was rapidly incorporated into daily practice. But very correctly, as Alberto said, we didn't have any great phase 3 randomized multicentric trial with major measurable clinical outcomes demonstrating the impact. That's the limit. We may further discuss the reason of this limit. Nonetheless, it was incorporated into the guideline. It happened in 2019, and PSMA PET was suggested by EAU guideline for biochemical recurrence, either after radiation therapy or after surgery, and suggested to be performed if available, because another point is that the degree of approval and availability is very scattered around the world. It happened that there's been a lot, really an impressive amount of literature, which again is not outstanding literature. It's good literature coming from different centers, frequently monocentric, frequently not randomized, essentially because there was no sponsoring issue behind it. Gallium PSMA 11 is not a patentable molecule, so it's not easy to run a trial without someone supporting you. Which are the indications? So how can we, in practice, use PSMA PET to be honest and regarding what is available? Is that about diagnosis? Is that about finding prostate cancer? Absolutely not. Forget about that. It's not even mentioned in the guidelines, and it's right to not mention that, because we have no role, absolutely no role. If you want to find the cancer, you have to use multiparametric MRI. And that's absolutely clear. There is no sufficient data to even debate the point right now, in my impression. Is that about staging? We have seen some images and some doubt, very properly raised by Alberto. In staging, again, if you refer to the guideline, you will see that there is multiparametric MRI for local staging, as absolutely clear, and then again, the old bone scan, which is still there for some traditional reason. Nonetheless, since some 5 years and more, the German colleagues have tried to use PSMA PET for staging, and essentially for staging the high-risk patient. And here is a case that I've been stalling from Alberto that probably was a little bit a believer long ago, or I may pretend that, and it was presented at EAU. You know, a young patient, family history of prostate cancer, with a Gleason score of 8, so clearly a high-risk patient that is undergoing conventional staging, so bone scintigraphy negative, CT negative. So it should have been treated radically with an ideally solution for the disease. But as part of a trial, we ran multiparametric MRI. It's clear, you see very well the lesion. You confirm the lesion with gallium PSMA, but you see nodal and bone disease. So it's clear that this patient cannot be cured by surgery alone. It should undergo something else. The data are not just anecdotal. Finally, a couple of prospective, randomized, multicentric trials have been run in Australia and in US. And the data are very consistent regarding the fact that there is a clear superiority over conventional imaging. There's no doubt. The only doubt is the impact on, for example, overall survival. We don't have that. And we don't have that for many reasons. Because it's very expensive, there's no sponsoring, it should be very long, and it should be almost impossible to run such a trial. Because if you propose nowadays this trial in Italy or in Germany or in many other places, the urologist will not really accept the patient going into the arm without having any PSMA scan. That's very clear. Recommendation for staging. It's now finally, 2022, been incorporated. PSMA PET and whole-body MRI to increase the sensitivity. But with a warning, be aware of the lack of outcome on treatment change. That's a very appropriate warning. That's to say, be careful. We don't have any proof that you're really making a benefit in survival. And we come back again. The point is that better detection rate, I agree, does not automatically and necessarily mean better clinical outcomes. But the rationale is very strong. The more you know, probably, the better you can plan how to treat the patient. So it comes back to your expertise. If you have just shown before a very faint uptake in one single rib, be careful. That could be a false positive. But if you have several areas of increased uptake, either in the lymph node and in the bone, you cannot pretend to not see them and not use such information. And that's a nice review recently done by the colleagues here in Milan, which confirmed the same and confirms, for example, that, again, the specificity is high. The sensitivity is not really very, very high. Don't forget that we have a spatial resolution of some millimeters, let's say 3 to 4 millimeters. So the micrometastasis will always be missed. So if a node is negative, you cannot really pretend that there is absolutely no disease there. You cannot spare lymphadenectomy just because the PSMA PET is negative. And now biochemical recurrence. Well, that's really our bread and butter. It's the main indication for PSMA PET, and the advantage is clear. You got all the information with one imaging only. So it's clearly easy to report, definitely much easier than an MRI. I'm sorry for my friend from radiology, but reporting PET usually it's almost trivial because you see the hotspot and you can identify that. And the data are very strong. The EAU guideline, but also ASCO and other guidelines have fully incorporated PSMA PET for biochemical recurrence with a number of data. We have demonstrated, that's very important, we have the higher detection rate, especially in early biochemical recurrence. So when the PSA is very low, that's when you can pretend to treat the patient. In this setting, you still have a curative window. It's not that late. So that's important to be very accurate in this setting. And in the last version of the guidelines is now recommended, even if there is a weak score, which is again related to the lack of good randomized trial with main clinical outcomes to measure the effectiveness. But no doubt that if PSMA PET is available, it should be done in biochemical recurrence. And of course, the same applies to PSA persistence. If you have a gentleman that after treatment has still a high PSMA, it clearly applies the same concept. That's an example that we performed. And again, you see choline almost negative and impressive images with gallium PSMA. And again, in the recommendation is mentioned, is not even mentioned, it is recommended clearly to perform PSMA PET. So in biochemical recurrence and PSA persistence, I guess we can conclude that as a clinical role, it's recommended, is widely adopted. and it's been a success. Are there other indications? Yes, Alberto showed to you, CRPC. What about, do we really see more with PSMA? We clearly see much, much more with PSMA. Even in patients with theoretically non-metastatic CRPC, those data are showing that 98% of patients scanned with PSMA will be positive. So almost every gentleman will be positive. But the most impressive is the fact that more than half of the patients will be M1. So they're not really an M CRPC. So it's even questionable that it really exists, the category of non-metastatic CRPC. It's only about what strategy you can use to study the patient. And in the APCC conference already 3 years ago, the majority of panelists voted for PSMA PET-CT in CRPC, even if we don't have any ultimate proof of the outcomes. SRT planning, it's another indication where, again, it's already been incorporated, for example, in the ASCO guideline, the use of PSMA PET. And so can we come rapidly to some conclusion after this sort of little ride in the nuclear medicine? I guess that for the indication in genitourinary cancer, we switched from useless nuclear medicine to somewhat useful nuclear medicine, but we still have a lot to do, and I will come with some good news for the renal cancer person like Umberto. But the indications are not comparable to the relevance that we have in prostate cancer. In prostate cancer, I guess that in the last decade, we can say that PSMA PET has been a game changer. It has really changed the way that we manage the patients, even if, again, we may discuss regarding the robustness of the existing trial. And some very short view in the future, just a couple of slides. Where are we going? What can we expect? Well, first is something that goes beyond imaging, and it's the possibility to use PSMA as a probe to drive your dissection. So essentially, you don't really use the imaging itself, but just like for the lymph node sentinel approach, you see during the operation where nodes should be in case removed, and I'm happy that the colleagues here in Milan are driving this together with the other group in Europe. And as said, we finally have some good tracer in kidney cancer. It's not PSMA, it's a different fragment. It's essentially based on carbon anhydrase, so it's labeled with zirconium, not so easy to produce, but there's just been communication regarding the phase 3 trial of the Zircon trial a couple of weeks ago, reporting very promising data on that. And as you can see, the quality of the image is quite good, and you can either see the primary tumor and the metastasis, and that can clearly have an impact in the future. So good news, Umberto, for you on coming. And with that, I thank you for your attention. Thank you.
Thank you, Stefano. Wonderful talk. Are there any questions from the floor? Please, Francesco.
I know that you know that, but Stefano is the best published individual in the area of PET scan and prostate cancer, at least. Years ago, myself, the CEO of this hospital, director, sent him chocolates, flowers, checks without the number on it, asking him to come over, but he did not want because he would prefer lovely Bologna. Congratulations on a wonderful talk. Quick question, fluorine versus gallium. We do see with fluorine lots of cases with bone lesions, which are at the end not bone lesions, but for us, it is then difficult to manage these patients who are killed with anxiety and so what are you doing now in Bologna?
We are doing gallium PSMA 11. I mean, probably it's boring for non-nuclear medicine people, but PSMA is a basket concept. You have more than 10 different PSMA ligand. And so we have gallium labeled and fluorinated labeled, but even the fluorinated are more than one. So it's not only one. In Europe, the most popular is gallium PSMA 11 and fluorinated 1007. Now we have to confirm to you, fluorinated 1007 is logistically favorable, maybe cheaper, but it suffers of bone non-specific uptake. And bone non-specific uptake, if you are not very skilled at reading, leads to false positive finding. So I'm fully with you. But on the other side, for example, the fluorinated PSMA available in North America, which is PYL, it has much less non-specific bone uptake, so it could be safe, but much more expensive.
Some 20 years ago, working with Cornell on PSMA external domain antibodies, conjugates, and therapeutics with lutetium-177, the concept of PSMA as a vascular stem cell marker came about because of the ability to image non-prostate cancers, because the neovasculature of the tumor expressed PSMA. Do you see this as someday there'll be, whether it's PSMA, LU-177 or something else, treating non-prostate cancers because of targeting PSMA?
Absolutely, it has already been reported. One of my most brilliant residents is over there, and this is the PI of a trial that we are running called PSMA More, which means beyond prostate. So we are enrolling thyroid cancer, bladder cancer, other form of malignancy, which clearly can be seen and in theory can be treated. Results are really very promising, I have to tell you. We are also doing immunohistochemistry, trying to see which is the overexpression, because for imaging it's easy. You see the scan. For treatment, it's much more complicated because you have to calculate the dose that you can really deliver. But absolutely, and there is a lot of efforts ongoing in this area.
Stefano, fantastic talk. Really learned a lot. And the question I have for you is regarding what you mentioned, the need to improve clinical outcomes in many of those implementations of the PSMA PET. The question I have for you is, with amazing experience in publication record, what will be your ideal design in a future trial, in any of the disease settings you can think about, or more than one disease settings, to prove that really improve outcomes, on meaningful hard outcomes in those patients? Thanks again for great work in the field.
Oh, thank you so much. That's the question. That's not a question. The problem is that, as said, the train has left the station. It's almost impossible now to design a trial where you do demonstrate that PET changed, for example, the survival of the patient if used or not. For many reasons, already said, it will not be possible to enroll patients in the majority of places and so on. But now the good news is that the use of bone scan was related to the fact that it was incorporated into the CHART-IT, STAMPEDE, and many other trials. That is the key reason. Most of the trials running now are incorporating PSMA to select patients or to get some ancillary information. And that will allow us in the next 5 years. So I'm thinking about the Prometheus study, the Proteus studies, and other studies who have incorporated PSMA either as a trigger to recruit the patient or as a parameter to evaluate the response. And that would completely change our approach. So the answer will come. Thanks. Great question.
So very briefly, Umberto, one quick question, that Noel, Francesco as well, and then we close because we need to move. Thank you.
Thank you, Stefano. Wonderful speech as usual. Very quick question. This ZIRCON study actually shows a very good performance. So I think it's a very important study, important findings for the future. How do you explain the fact that CA9 was targeted in the last decade several times with not so good performance, and this time with a different tracer, we now find this very good performance? Which are the key points?
Well, essentially it's the same that we have seen for PSMA. PSMA originally have been studied with antibody fragment in North America, Memorial in New York. Essentially the molecule was big. And for some reason, which is not 100% clear, the smaller we go, the better we image the patient. So when we are using, like for PSMA 11, a much smaller molecule, the quality of imaging, there has been a PSMA tracer approved in the late 90s, which ran out of business because the quality of the image was very poor, labeled with indium. It was, yeah, exactly, prostate. So it was not the ideal target, and at the same time, it was a fragment that was probably too big. So it was clearly derived from the blood. It is no longer persistent. It was in the internal domain, so much less accessible to that. So there's been some engineering regarding the reduction, but mainly reduction of the size of the ligand, which is a trick that apparently works very well.
Just a very short question. You said that there is no role in diagnosis of prostate cancer. However, don't you think that in the future it will be some role in specific setting of patients? We have seen many patients with PET-MR where there is a very interesting uptake in the prostate. So maybe I think it will be a field for the future.
I'm fully with you, and you already provided the answer, which is the correct. I mean, it was mentioned, the problem with the multiparametric MRI is sometimes the gray zone of the potential phase positive finding. So if you couple together two principles which are absolutely independent, so on top of multiparametric MRI, add PSMA PET and reinforce, you will reduce the false positive. If you just consider positive, for example, PIRA3 plus an intense uptake of PSMA. That's where to go. But that means that is sort of post-application after multiparametric MRI. So you leave the floor to multiparametric MRI, and if the finding is uncertain, and if you're lucky enough to have a PET-MR, as you are, you can really make the final diagnosis, but not going straight with PSMA and pretend that you see something, no.
Last question, Noel?
Well, I'd just like to add a note of caution, Stefano, to the statement that bone scan is dead and that a trial can't be done without PSMA. We have clear evidence from large-scale data, level 1 data, that the bone scan's predictive, and that enables dichotomization of treatment into high and low volume. So I think for anybody listening, you really mustn't take home that message that the bone scan is dead. The bone scan is definitely not dead. It tells you a lot about biology. I don't question that PSMA is more sensitive. The second is, can we do a trial without PSMA in it? Well, Stampede 2, which will start in January, February, is on standard imaging with PSMA as a sideline, and we will evaluate its true utility. So I think also I would question your statement about that.
No, I'm fully with you. I was a bit provocative regarding bone scanning. So for example, even in the evaluation of very advanced disease, it's clear that bone scanning is preferable because it's very cheap, it's available, no doubt. So honestly, I was a bit of provocative to state, okay, think not necessarily new, but think something which is more sensitive. And as said, regarding the incorporation of PSMA, I'm really happy because it's exactly what we need. I mean, using straight, as Alberto said, into clinical practice has been a jump into the dark, honestly. If it would have been done for choline, it would have been a problem. So it's good to be cautious, and it's great to incorporate into trials because it's the only way where we can demonstrate if it works, either for patient selection or for anticipating the demonstration of progression of the disease, which is another point. It's not only about selecting early recurrence, but for example, making a surrogate endpoint, the PSMA progression. That's very relevant to me.
Okay, thank you very much, Stefano, for being here, for your excellent talk. So now we move forward to the next session, which is a combination of or examples on how clinicians can work together with industrial partners with a final aim to improve patient care, diagnostic processes, and approaches to our patients with GU cancer. So this is a session where we're trying to extrapolate or to possibly expand the role of collaborations between industry partners and academia. So the first talk, as well as the second, will be pre-recorded, and so I will kindly ask our technician to broadcast the first presentation, which will be given by Dr. Gibb, Gene Expression and Molecular Subtyping in GU Cancer. Please.
So good morning. My name is Ewan Gibb. I'm a PhD scientist, the bladder cancer lead with Veracyte, and I'd like to thank Dr. Necki for the opportunity to present some of the work we've been doing at the company and go over some of the studies we've been doing. So the title of my talk is Gene Expression and Molecular Subtyping in GU Cancers. This is unfortunately a pre-recorded presentation as I was unable to attend in Milan this year. So the primary assay we have for the bladder cancer community is the Decipher bladder clinical test. This is a molecular subtyping assay we've spent about 5 years developing. So this is also known as a genomic subtyping classifier in the literature. It's really designed to do 3 different things, and that's to predict the risk of upstaging, the benefit from neoadjuvant chemotherapy, and finally to identify high-risk neuroendocrine-like disease. And the way we do this is we break a patient's tumor into one of 5 different subtypes. And so the model that we're using currently recognizes a luminal subtype, an infiltrated luminal subtype that has luminal characteristics, but it has some stromal infiltration, basal subtype, and then a basal claudin low subtype, which has a lot of immune infiltration, and finally this aggressive neuroendocrine-like tumor type subtype, which presents as conventional urothelial carcinoma, but however has a genomic profile and clinical behavior much more consistent with small cell or neuroendocrine-like disease. And so this on the right here is an example of one of the patient reports that an ordering physician would get. And so we lump it into 2 larger categories, luminal and non-luminal, with neuroendocrine being a smaller subset. And each of these reports would be different depending on the clinical stage of the patient in question. So here we have a classic clinical T2. So you get an indication of the level of risk of upstaging and the benefit from neoadjuvant chemotherapy. If this patient was a CT1, for example, we wouldn't offer the benefit of neoadjuvant chemotherapy block. And conversely, if it's T3 or higher, we wouldn't offer a risk of upstaging because we already know they're non-organ confined. And of course, given this is a whole transcriptome assay, any interested customer can actually order a new product that's coming out soon, which we call the Bladder Grid, which includes all the current subtyping models, including the consensus model, TCGA, and the LUNT models. So first, I think to go over each of these indications, the first being predicting risk of upstaging cystectomy. And this is an area where we're really heavily focused on as we start to gain some additional traction in non-muscle invasive bladder cancer as well. So this remains a large clinical problem, predicting non-organ confined disease at surgery. And so classically, this problem is at staging where we're doing a TUR or a CT scan, and then we're finding a patient is predicted to be a clinical T1 or T2. However, often this changes at pathology, and we're finding that 40 to 50% of the time, this patient can actually be upgraded to non-organ confined disease, which we're defining here as PT3 plus and or having nodal involvement. So to investigate this problem and perhaps offer a solution using genomics, we came up with a study which we call the MUL study, and MUL just is an abbreviation for molecular upstaging. This is work done with Dr. Yair Lotan at UTS Southwestern in Texas. And so this cohort is comprised of 206 patients, all clinical T1, T2, treated with direct radical cystectomy with no systemic therapy. And you can see with upstaging, the rates of mortality are quite high compared to no upstaging. And thinking more in the long term, but I think importantly, is if the patient was upstaged to non-organ confined disease and it was thought to be organ confined, we did actually miss an opportunity to treat patients with neoadjuvant chemotherapy. And so using the same cohort and actually applying a molecular subtyping assay of the GSC to this, we found that when we broke it down to luminal versus non-luminal, and so non-luminal here includes the basals, the claudin lows, the infiltrated luminals, and neuroendocrine tumors. We saw a significant difference in the rates of upstaging between the luminal tumors and the non-luminal tumors, where luminals had a rate of about 34% and non-luminals had 51%. And interestingly, when the patient was found to be luminal and consistent with the organ confined versus non-organ confined CSM in the previous plot, we see that luminal patients actually do significantly better than non-luminal patients, which is consistent with less aggressive biology we typically see for non-luminal patients, or for luminal patients, excuse me. And again, this was published with Dr. Lotan in European Urology in 2019. And so the second indication we're looking at is really predicting NAC benefit. And I do recognize there's some controversy around using subtyping to predict NAC. And so we have adjusted our approach since we initially came up with the assay in 2017 and look at this problem slightly differently. Regardless, the challenge point here really is what we're seeing with chemotherapy, about a 40% response rate and a 5% benefit, which isn't all that impressive, even though it was enough to move the needle and get it to guidelines in the US. So it still remains a major decision point whether or not you would actually want to give chemotherapy to a lot of patients. So this is where we come to the pivot point. Really, is over time, I think in the literature and in our own work, we've seen that the luminal molecular subtype does appear to have a much less aggressive clinical presentation in general, and this is reflected by good outcomes. And you can see here in the KM plot on the right that this is published in Seiler by Seiler in European Urology 2017, that the outcomes for luminal patients treated only with radical cystectomy is actually quite good compared to the other subtypes. When you combine this also with the data indicates that luminal tumors are more likely to be organ confined at surgery, and non-organ confined tumors have greater benefit from chemotherapy, we start to get this idea that perhaps patients with luminal tumors could be excluded from chemotherapy and have reasonable outcomes with cystectomy alone. So to get at this problem, since we really don't have the actual clinical trial that we need to properly address this, we developed a study we called NAC-META. And to date, to my knowledge, this is probably one of the largest NAC versus non-NAC cohorts assembled to date. And so to do this, we combined 4 different cohorts, some treated with NAC, some without. So NAC1, NAC2 or two in-house cohorts we have, both treated with neoadjuvant chemotherapy. SIR guidance was a clinical trial with Joost Bormans in the Netherlands. Some patients received NAC, but the majority did not. And MOL is an upstaging cohort we were working with, but we're only here using patients with actual pathological muscle invasive disease. And so once we exclude a number of patients for various features, including path stage, after they just received non-cisplatin-based NAC, etc., we ended up with a large cohort of 601 patients, 247 receiving NAC, 354 not. Using inverse probability weighting, we matched these cohorts as best we could, the two groups as best we could for clinical parameters. And so in the subsequent plots, you're going to see some data that are percentages as opposed to actual numbers, and that just reflects that the balancing that we needed to do to make this work. And so the first checkpoint was really a sanity check to see what the data looks like when we look at NAC versus no NAC exclusively. And importantly, in the study, we did exclude the neuroendocrine patients because they tend to have poor outcomes regardless of therapy. And we feel they represent an entirely different disease. And so when you look at the cohort as large, we see a net difference of about 7% at 3 years for NAC versus no NAC, which is very much in line with the clinical trial data, which reports about a 5% benefit at the same time. So knowing this, we looked then again at luminal versus non-luminal. This is our 2 groups. In this case, for the luminal patients, we see that there is actually a negative difference of 2% in overall survival at 3 years, representing really no benefit or no change for these patients upon receiving NAC. And this was consistent with UVA and MVA as well. And interestingly, we look at non-luminal patients. This is when we actually see like a much different plot. And in this case, we see a net difference of about 10% in overall survival at 3 years. And this was significant. And again, holds up on both UVA and MVA analysis. And this work was published by Dr. Lotan again in Journal of Urology in 2022. And so taken together, we start to see the clinics and biology actually starting to align. So when we're looking at non-organ confined disease, we see that they're more likely to be non-luminal in nature, have a much higher rate of upstaging, 10% benefit from neoadjuvant chemo at 3 years. Conversely, at the luminal tumors, we see a much lower rate of upstaging at 34%, really no benefit of chemotherapy, even less benefit of chemotherapy at 3 years using the current data, suggesting that these patients really could be cured with cystectomy alone, and this may be reflected in the data we're seeing now. The next bit that we have is identifying high-risk neuroendocrine-like disease. So again, these are the patients who present with conventional urothelial carcinoma, but really have a disease more consistent with small cell or neuroendocrine-like tumors. And so I'm not going to go over the whole model development. This has been published previously, but this is a validation study we did. And you can see that these neuroendocrine tumors really robustly express neuronal markers, but are depleted for both basal and luminal markers. And the outcomes for these patients is quite poor. In this study, we had about 8 events in a year, and this was with systemic chemotherapy. So that they're doing quite poorly, and we really think that they should be treated a little bit differently than with standard chemotherapy regimens. This presents a large problem because although they only appear about 6% of the time, they would not be identified for routine pathological screening. And so they really represent sort of the bad apple in the bladder, muscle-invasive bladder cancer space, or the worst of the bad apples in the muscle-invasive bladder cancer space, and should really be treated differently. And I think that NCCN current guidelines do recommend etoposide plus cisplatin for any tumors with neuroendocrine features. And I would make the argument that neuroendocrine-like is a neuroendocrine feature and should be considered as such. Finally, I think maybe this is the most exciting data and most recent data is predicting benefit from neoadjuvant pembrolizumab. In clinical cancer research, where we're starting to see a very interesting and a robust pattern emerging. So when we use the consensus classifier, TCGA classifier, we sort of get a nod of outcomes with not a lot of meaningful implication how we would use this data clinically, with the exception, of course, neuroendocrine or neuronal-like disease is doing quite poorly. But when we use the Decipher classifier, we see this very interesting pattern where the Claudin-low tumors actually have almost an exquisite benefit with only a single patient having an event in 3 years. And we found this to be significant after collecting the 3-year long-term outcome data. And we feel this is very exciting and speaks to the potential of actually stratifying patients correctly to neoadjuvant pembrolizumab when they present with muscle-invasive bladder cancer. To put it all together, really the question that remains, and there's a lot of work to be done still, but could 2020s be the decade of precision medicine for bladder cancer? And with further validation, of course, the suggested therapies based on the data we have so far could be luminal patients, having lower risk of upstaging, limited benefit of chemo, could be candidates for immediate cystectomy. Claudin lows, much higher risk of upstaging, maybe less benefit of neoadjuvant chemo, maybe great candidates for neoadjuvant pembro, given the data we have. Basal and luminal infiltrated, again, continue NAC until we can figure out what we should do with these patients. And neuroendocrine-like, again, should be treated as neuroendocrine disease. And with that, that's the end of my presentation, and I'm happy to answer questions via email if that's the appropriate platform.
Thank you. Thank you for the presentation. So we move to the next presentation, once again registered, and we will have a final discussion at the end of the session. So please, if you can show us the presentation of Adam El Nagar, monitoring response to treatment through ctDNA.
Thank you for the opportunity to present to you on the clinical utility of personalized molecular residual disease monitoring. My name is Adam El Nagar. I'm a medical director of oncology at Natera, and my focus is on Signatera, our molecular residual disease test. And so my disclosures, I work at Natera, and then our objectives is just to present Signatera, talk about some of the prognostic and predictive value of ctDNA. And then one of the asks was to talk about some of the pharmaceutical industrial partnerships that are used in clinical trial design. And so I'm going to talk about how ctDNA can be used for that purpose. And so what is Signatera? It's a personalized tumor-informed approach. And so what we mean by that is that it's based on that patient's tumor. So there's not a bladder panel or a colon panel or a lung panel. It's truly that patient's. And so to do that, we need the patient's tissue, and we do whole exome sequencing of that to identify those single nucleotide variants that we feel are going to be the clonal or passenger mutations that are going to persist throughout the life of the tumor and not susceptible to treatment pressure. And so we identify 16 variants there. We also run the patient's germline and do whole exome sequencing of that as well, because what we're trying to do is make sure that any SNPs that may be present in that patient's germline are not being included in the panel. And then once we have that completed, we then run that against the patient's plasma, identifying their circulating tumor DNA. And so there's tumor naive and there's tumor informed assays. We feel that the tumor informed assay is very important because you're tracking multiple variants specific to that patient, giving you more shots on goal to identify if there is residual disease. You're also ruling out any germline or chip mutations that may be present in the patient. You're also able to quantify response to therapy because you can identify how much ctDNA is still present while after surgery or undergoing treatment. And we're also tracking those clonal mutations, like I mentioned, ones that we don't think are going to be go away under treatment or as it recurs multiple times. And so has Signatera performed in muscle invasive bladder cancer? And so we've looked at Signatera at multiple points along a patient's journey within muscle invasive bladder cancer. So treatment response monitoring, post-surgery, looking at efficacy of adjuvant treatment, and then the idea of treatment response monitoring as well as in surveillance. So being able to identify it before there's clinical signs of progression. And so one of the first studies that we used to begin really looking at that role of ctDNA was by Christensen et al. And so it was 68 patients with muscle invasive bladder cancer with serial time points collected. So at the time of diagnosis, so after transurethral resection, during neoadjuvant, post-operative cystectomy, and then during surveillance. And so what we saw very early on was that there was a prognostic benefit of ctDNA. So just after diagnosis, if you were ctDNA negative, you can see that the recurrence-free survival for those patients is excellent. Only one patient in that negative cohort recurred, but that was over a year out. And then the positive cohort, you can see, was not as favorable an outcome. If we then look at different time points, so on the left there again is that pre-neoadjuvant, and then we look at testing on neoadjuvant or right up until surgery, before surgery, if you cleared. And again, we're seeing a very big separation of those curves. And then if we look after cystectomy and said, if you're negative after surgery and remain negative during surveillance, those patients have an excellent outcome, a very durable recurrence-free survival. Whereas if you go from negative to positive at some time post-cystectomy, 100% of the time those patients were going on to recur. And a similar finding was seen in the overall survival as well. And so if we're identifying a group that's at much higher risk of recurrence, can we start using that information to identify who would benefit from adjuvant therapy? So now we're trying to look at a predictive biomarker here. So InVigor-10 was a study looking at atezolizumab versus observation in muscle invasive urothelial cancer. And so patients were randomized to atezo versus observation, and an exploratory endpoint was to look at biomarkers. And so you can see in an 800 patient study of atezo versus obs, the intent to treat population is a negative study. And then if we looked at biomarker evaluable patients, so if you had PD-L1 or TMB, again, there was no separation of those curves with the addition of treatment. So then if we look at that observation arm and say, I want to look at that prognostic value of ctDNA again, you can see DFS and OS, the ctDNA negative group had a far superior outcome than the ctDNA positive group. So then let's look at this by treatment there, by those two different cohorts. And so you can see in the faded green and purple there, those are the ctDNA negative group, treatment and no treatment. And you see those lines, there's no separation, no significant difference in those curves. Whereas if you looked at the ctDNA positive, you had a significantly improved disease-free survival and overall survival with the addition of atezolizumab in the ctDNA positive arm. And so the updated overall survival was just presented at EAU this year. And so you can see here that the benefit of the addition of treatment to the ctDNA positive cohort persisted over several years. If you look at the ctDNA negative group, there starts to be this interesting trend towards decreased survival in the patients that received atezolizumab relative to those that underwent observation. And as we've done more immunotherapy, more targeted therapy trials in an all-comer population, this idea of a possible detriment in survival to patients that did not benefit from treatment is starting to be seen. And so how can we start to use ctDNA within clinical trial design? And so to that regard, the FDA recently issued some draft guidance on how to use ctDNA within clinical trials. And one of them was just the fact that it does identify a patient that has a poor prognosis and selects a higher risk patient population. And so if we look at some of the big trials that have come out recently, so PALLAS was a hormone positive, HER2 negative study. Affinity was one looking at HER2 positive patients. But those studies required 6,000 and 5,000 patients respectively to show efficacy of the drug. Similarly, IMvigor, like we mentioned, was about an 800 patient study. If we enrich that for ctDNA positive alone, we can see that the two breast trials would have drastically reduced to just under 500 patients if you enrich for ctDNA positivity. Same thing in IMvigor, suddenly that drops down to about 150 patient study. And so you're really identifying a way to enrich the study to find that efficacy in less time and far cheaper. And so biomarkers have certainly been something that has become more and more present in the field of oncology. So there's the diagnostic markers, the prognostic markers, like we identified earlier, looking at who's got a better outcome, and then the predictive biomarkers. Now, predictive biomarkers are certainly being used in clinical trials already. Specific examples would be tumor mutational burden, PD-L1 expression, and microsatellite instability. One of the issues is they all lack specificity. So we all see this favorable cohort, these markers that should identify patients that would benefit, but they are not, as well as a lack of standardization, both between measurements, companies that are measuring TMB or PD-L1, as well as what studies used as the cutoff. And so when we look at IMvigor 10, what we see here is if you looked at the ctDNA positive patients and looked at the TMB high ones, there definitely was a benefit to the addition of atezo. If we look at the TMB low, still looking at ctDNA positivity, we see that there was not a significant benefit to addition of atezolizumab. Similarly, PD-L1, if you were an expressor and received treatment in that ctDNA positive cohort, there's benefit, whereas it was not seen in that PD-L low or negative cohort. And so we're starting to see this synergism here where using biomarkers to identify who would most benefit from treatment and enriching it for the ones that really need the treatment can start really shaping clinical trial design. So those are some of the use cases, and then also treatment response monitoring can play an important role. That's particularly seen in the immunotherapy or immunocheckpoint inhibitors, where we know there's this phenomenon of pseudoprogression where radiologic imaging may not be able to distinguish who's actually progressing or who's having the idea of the pseudoprogression happening in patients. And so if we look at IMvigor 10 and say, if you're ctDNA positive at the start of treatment and just 6 weeks in, so at cycle 3, cleared, how did that correlate with disease-free survival and overall survival? And we can see that if you go from positive, negative, even very early on at 6 weeks, we're identifying a patient cohort that's really going to benefit and hopefully have a durable response to therapy. One of the big studies that was used to look at this was the paper by Bratman et al. And so that was the INSPIRE trial. And what that was a phase 2 trial looking at pembrolizumab across solid tumors. And it was enriched for different cohorts, but the idea was these recurrent solid tumors went on to study and receive pembrolizumab. And we can see that in the blue line, those are patients that were ctDNA positive and had a decrease in the amount of ctDNA, relative to the green line, which is those that had an increase. If you had an increase in ctDNA, those patients had a progression-free survival of just over 2 months, and very few of them went on to have a response. Certainly, if you have progression in the tumor as well as a rise in ctDNA, none of those patients went on to achieve an overall response rate. And I think it's important to point out that there was a 98% ctDNA detection within this patient population, really highlighting the need for that tumor-informed assay. We can then separate some of these responders out a little bit further by saying, if you're ctDNA positive and you go on to clear ctDNA, how does that correlate with survival? And you can see it was 100% overall survival for those patients that cleared ctDNA. Then there's also those that decrease but don't go on to clear, as well as those that increase. And you can see that the survival decreases with each of those groups. And so again, very early on, as early as 6 weeks, both in IMvigor and this INSPIRE trial, we're identifying who's responding to treatment. And so when starting to design clinical trials, we're seeing that ctDNA correlates with the overall response rates. And so there is Medicare approval for treatment, both in the pan-tumor immunotherapy monitoring, as well as in muscle-invasive bladder cancer. And so this ctDNA can be used as an early endpoint in clinical trial design. So not fully validated yet, but one that is certainly being discussed in the FDA's draft guidelines, is that this may be helpful in early signal finding of drug activity. So very early trials being able to identify, are patients clearing, are they responding? And so then ctDNA can start to be used as a surrogate endpoint. The idea being, if, like, for example, if 70% clear with drug A and 30% clear with drug B, before waiting to the full event rates that may take a significant amount of time and money to identify, you're identifying very early on who may be benefiting most from treatment and whether the treatment is efficacious. And then there's also the recurrence monitoring, that there is a significant lead time to the detection of recurrent disease. And that's been seen across multiple solid tumors. You can see here that the specificity almost approaches almost 100%, such that if you became ctDNA positive, those patients with enough follow time become positive. And the lead time varies across solid tumors. And so there already are trials being developed that are using Signatera or molecular residual disease monitoring as part of either the inclusion criteria, as an integral, or also as an integrated biomarker within studies. One of the larger studies to highlight this was the Galaxy study. And so it's a 3-arm trial. Galaxy was the arm that was just looking at observation. The other 2 arms that composed the entire Circulate Japan study was the Vega arm, where if you were ctDNA negative, you went to a de-escalation arm. And if you were ctDNA positive, you went to an escalation arm. Recently at ASCO GI, the Galaxy study, so the purely physician's choice prospective, just observation of what does the ctDNA do, we identify that prognostic value. So just looking at a single time point, 4 weeks after surgery, if you're ctDNA negative versus positive, we're really separating out the good prognostic patients from them. And then if we look across different disease stages, the higher stage 2, 3, or 4, again, we're identifying a cohort within that ctDNA positive group that's benefiting from the addition of adjuvant therapy. So these patients are all ctDNA positive in the green lines with treatment and the blue lines without. Then if we say, let's look at that ctDNA negative cohort across those same populations, and you see they have an excellent prognosis at baseline, and that the benefit to the adjuvant therapy then wasn't there. And so I hope I've been able to highlight some of the uses of ctDNA within clinical trials as both a prognostic and a predictive biomarker, and some of the use cases that exist currently for Signatera. Thank you.
So thank you very much. So it's now my pleasure to invite to the stage Dr. Ross from Foundation Medicine, and I would like again to thank him for being here today with us to share with the entire audience possible interaction between, again, academia and industrial partners. So thank you very much again, and the floor is yours. I will talk about, of course, comprehensive genomic profiling in GU cancers.
Thank you so much. It's an absolute pleasure and honor to be here in Milan today at this wonderful, I think I would call it a symposium. You're calling it a retreat. It's a very scientific and medically rich program, and I'm enjoying being part of it very much. So I chose to speak about liquid biopsies today. 50 years ago, I think it was the year 1972 that Professor Spies was born, I was a pathology resident in training on my hematology rotation and looked at a peripheral blood smear in a patient with advanced metastatic breast cancer and saw some cells on the right Giemsa slide that I certainly didn't think were blasts, and I couldn't figure out what they were, and the attending hematologist went over them with me and said, those are circulating breast cancer cells in that unfortunate patient with advanced disease. And that sparked an interest in the ability of blood to guide therapy for cancer patients that has recently, I think, reached fruition with the development of the actual liquid biopsy. My disclosures. I think we've had a very, very exciting evolution in cancer treatment of precision medicine and personalized medicine, and the number of agents often linked to specific biomarker or genomic alterations has grown almost logarithmically of late. But in blood, we have a mixture of a variety of different potential sources of circulating DNA. It can come from white blood cells, of course, on that patient. It could come even from bacteria in that patient's colon. It could come from apoptotic benign cells in various parts of the body. But in cancer patients, it can also come from leaking DNA into the bloodstream from the tumor itself, which we, of course, call ctDNA. And here you see this schematic drawing describing other potential sources of DNA in the blood. So we have tissue biopsies and we have liquid biopsies, and DNA can be extracted from both for purpose of sequencing it, usually now by next generation methods, in order to help guide therapy for patients, especially with clinically advanced disease. But now, of course, we know also for patients with early stage disease who are candidates for neoadjuvant regimens. The tissue biopsies have, of course, the advantage of a much larger amount of DNA that can be extracted and the ability to control for focusing on tumor versus benign, but they involve getting the tissue. Now, the tissue may be available archived because the patient had a resection or a transurethral biopsy of the bladder or needle biopsies of the prostate, and it already exists. On the other hand, the use of DNA to guide therapy often requires that therapy has already been given, and the early original pre-treatment tumors may not be informative in many clinical settings. That's when the thought of liquid biopsy comes to mind. Do we do a metastasis biopsy, or do we do a phlebotomy? One is very easy, very safe, and very fast. It's very quick to take DNA from blood. With paraffin-embedded tissue, there's a much more elaborate series of steps to get the DNA out. When do we decide which to use? What we like, what's more convenient? Or do we decide based on the patient, their disease, the nature of their disease, the clinical stage of their disease, and maybe even other tests that guide us whether to use liquid or whether to use tissue? So let's talk quickly about the history of the liquid biopsy. I've put circulating tumor cell assays just because that's where we began. 20 years ago, we had the cell search looking for immunomagnetic bead, captured circulating tumor cells. And in some disease types, especially prostate cancer, this was very informative of response to treatment. But unfortunately, it was difficult to get DNA out of the captured cells in order to be able to design or plan therapy. And the CTC assay remains only rarely used today.
What has taken its place is circulating tumor DNA, ctDNA, and that's what my focus will be for the next 12 or 13 or so minutes, designed for mutation detection and characterization. And one should always keep in mind that a mutation, an alteration in the genomic sequence of the DNA from tumor is not a uniform, accessible change. That short variant mutations are easy to detect. Short insertions and deletions are much harder. Fusions, depending upon the nature of the fusion, can readily be detected in liquid biopsies, but homozygous deletions and copy number changes like amplifications are heavily dependent upon how much DNA has been extracted, since they are comparative assays to built-in white blood cell controls, if you have it, and they challenge the system for its sensitivity and accuracy. So not all mutational changes are equal when it comes to the ease of detecting them in a liquid biopsy. I'm not going to talk about bone marrow, and I'm not going to talk about urine as a liquid biopsy for patients with bladder, renal, and even prostate cancers, but there is a literature for urine-based testing. My talk is blood-based only. So here we have the liquid biopsy listed here. There's two major commercial vendors of liquid biopsies in the United States, and that's Foundation Medicine's test, the F1 Liquid CDX, and its competitive assay from Guardant, the Guardant 360. These can serve as a disease burden, as we just heard from Signatera. Using informed circulating tumor DNA is far superior than next-generation sequencing as a method of determining residual disease because of the extraordinary cost of repeated NGS tests on blood versus the ability to do it with an informed PCR or similar based test. But the primary role for the liquid biopsy, at least today, is to try to guide therapy. It can be to decide primary therapy, or it can be how do we overcome resistance to the primary therapy, and that will time when the sample should best be collected. The biomarkers like blood TMB and MSI status, as well as others, are also detectable in blood, and their clinical utility constantly is being refined as more studies employ them. So hear more on the liquid biopsy. I'm going to talk a little bit about clonal hematopoiesis in a few minutes. That's an important confounding problem that we have sometimes, although we now are quite knowledgeable about how to avoid calling clonal hematopoiesis as tumor DNA derived as well. And finally, as you see at the bottom of the test, it's not tissue first. It's not liquid first, it's the patient first, meaning the decision is made based on the clinical assessment of the patient. And I'll give even some examples in genitourinary cancer of using even other ancillary tests to try to help guide this. So there are a lot of problems when we do this. There's not very much circulating tumor DNA in blood, even in patients with a very advanced disease. And some tumors, even when advanced, don't elaborate very much circulating tumor DNA. So we have to be very careful which patients we decide to do the test on, because nothing can harm the patient more than the lost time of trying a liquid biopsy that will fail and the significant cost of doing that. And in some insurance settings, for example, in the United States, there's only one NGS test that the insurer will pay for. And if it's a failed blood-based NGS test, that patient is no longer covered, perhaps for a future tissue biopsy that would be done now that the blood didn't inform. So a great deal of thought has to be put into the decision by the treating physician whether to do liquid and when to do liquid, so that it doesn't cost in time and money. One of the advantages of liquid has been always that it could overcome the issue of tumor heterogeneity, which we're going to hear about later in today's symposium. In general, it does help quite a bit. There are some problems, but here's an example of a melanoma patient in which the liquid biopsy pretty much got the driver mutations and the passenger mutations that were partially shown. The driver, of course, in all of the sites, but different passenger mutations in different sites, but the liquid got them all, even the story going on in the brain, which is unusual since we kind of think that most mutations in tumor in brain are not going to be elaborated into the CT
ctDNA that we will assess when we do a liquid biopsy. But it can overcome tumor heterogeneity. Here are the two, just quick comparison of the two commercially available liquid biopsy tests in the United States. I don't know if the Guardant test is heavily marketed in Europe. The Foundation One Liquid, of course, is. So here's an example of a large tumor array of how much circulating tumor DNA you might find. I've put arrows for the three major GU cancers, bladder, renal, and prostate, showing that all three of them, with bladder and prostate a little bit more significant than RCC, elaborating significant amounts of DNA on most liquid biopsies. So for this particular tumor type, GU cancers, liquid biopsies are quite readily used when selected patients are best assayed. A lot of variabilities in ctDNA studies. A lot of factors can influence not only the clonal hematopoiesis issues, but issues involving a variety of methodology, how the DNA is extracted. The goal is to maximize the amount of ctDNA obtained from a blood sample using the best chemistries you can design, because it's such a fleeting amount. And below certain levels, one cannot make really significantly accurate assessments. So selecting patients which have an unfortunately high ctDNA in blood is the best way to get very informative liquid biopsy results. And that's going to lead to this concept of the tumor fraction. So here are the kinds of alterations, of course, we look for in liquid biopsies, and they're not a surprise, they're the same that we look for in many tissue biopsies. We see prostate and bladder here, and for prostate cancer, liquid biopsies of the late have been very focused on how can they guide the use of PARP inhibitors, meaning beyond BRCA1 and 2, the ATM mutation, which still remains a approved indication for PARP inhibitors in prostate cancer in US. But we are now starting to find other alterations that are useful in planning therapy, some impacting the endocrine approach, the androgen ablation approach, and some even predicting responsiveness to docetaxel. Our most recent liquid biopsy study has been on the SPOP, the SPOP gene in prostate cancer, and how it predicts that chemotherapy is likely to be less effective and maintenance of anti-androgen therapy more effective in that subset of patients. For bladder cancer, of course, it's heavily focused on the target we've already learned about, the FGFR. So as we go forward here and look at liquid biopsies, I should again mention what I spoke about a few minutes ago, which was germline testing. Now, a liquid biopsy for cancer therapy decision-making is not a germline test. It is using a germline sample. There's no question that the blood is a major germline sample for sequencing mostly the white blood cell DNA for inherited mutations that could not only drive the patient's current cancer treatment decision, but also inform the family on their familial risk for that disease or other associated diseases. We don't have patient permission when a liquid biopsy is ordered to report germline results. And although it's much easier to detect germline status on a liquid biopsy than a tissue biopsy, because you have the white blood cell DNA in there that you can separately assess, you have to do the reporting very carefully so that it doesn't violate legal standards about germline status. But when we do, we certainly can cover all of the ESMO guidelines for what genes should be assessed for genetic susceptibility to cancer, many of which, of course, also drive treatment selection, including the PARP inhibitors with the BRCA germline mutations and many others. So here we see this tumor fraction study. This is emerging, this ability to calculate using an aneuploidy denominator, the actual portion of ctDNA that's coming from tumor versus coming from non-tumor sources like WBCs. And it's a very significant prognostic factor. As the tumor fraction index increases, the patient's risk of having a disseminated disease, of having even therapy refractive disease goes up significantly. And as you can see from the chart to the right on the survival curves, it doesn't matter what tumor type it is. High tumor fraction means adverse prognosis. Here's an example of a patient with prostate cancer who had a liquid biopsy. Couple of quick backgrounds, and again, this was a search for BRCA. This was a germline. Patient went on PARP inhibitor and did well. But I want to go to the next stage of this. I'll skip through this, through the report, which is a little too detailed, to understanding that not all BRCA alterations in prostate cancer are the same. In the BRCA mutation spectrum in diseases like ovarian and breast cancer, where BRCA1 dominates over BRCA2, a homozygous deletion is extremely uncommon. But in prostate cancer, which is dominated by BRCA2, not BRCA1, homozygous deletion is about 1/5, around 20% of the alterations, which makes it 2-3% of clinically advanced prostate cancer has a BRCA2 homozygous deletion. Well, why does that matter? And I'll get to it in a second. Here we just see the different sites with it. We found in this particular study that when PSA is below 5 nanograms per deciliter, the chances of an uninformative liquid biopsy are so high as to formally recommend that in prostate cancer, a liquid biopsy should not be ordered for patients whose PSA is below 5. Now, of course, a treating physician will then say, yes, but I have Gleason 10, or I have Gleason 9, knowing that PSA is not as accurate a predictor of disease burden for those patients, since each tumor cell is making so much less of it than a classic Gleason 7. And so you may override that and go ahead with the liquid if you know it's a very high grade. But in a classic 7, if it's below 5, we recommend you don't try a liquid biopsy. So here is this patient who's had a liquid biopsy that showed a BRCA2 homozygous deletion after years of therapy with hormonal therapies, Taxotere and other drugs. PSA was, I think, 600 at its peak, and disseminated disease, lungs, liver, a high disease burden, finally got sequenced from blood and had a homozygous deletion. And the patient went on a PARP inhibitor and had a durable, dramatic, sustained response. Why is this difference? Well, when you have a BRCA2 base substitution mutation inactivating this tumor suppressor, the most common, your resistance emerges due to the production of BRCA2 reversion mutations, in which under the stress of the PARP inhibitor, the BRCA gene mutates and produces a new protein. It's not the perfect wild-type protein, but it's good enough to restore the loss of homologous recombination defect, and the patient becomes resistant to the PARP inhibitor. But if you don't have the gene, because you have a homozygous deletion, you can't make the reversion mutations. These men, if you identify them early, can go on a PARP inhibitor, maybe instead of certainly cytotoxic chemotherapy, and maybe even without androgen ablation therapy. They are so sensitive to PARP inhibitor and stay that way. And this was an example of this particular patient who went into complete remission with such a wide burden of disease and then sustained that remission for years. In urothelial carcinoma, liquid biopsies are also very informative, especially in patients with late stage. And here is a plasmacytoid urothelial carcinoma with an E-cadherin, a CDH1 mutation, which we could pick up on liquid biopsy. We recently have a new study we just sent to the ASCO GU meeting with Professor Necki as first author, in which we were able to do a outcome analysis using Foundation Medicine's Flatiron Health Partnership for what are called real-world clinical outcome studies. And what we showed was something that had first been published in upper GI cancer, that when CDH1 is mutated, the patients are resistant to immunotherapy but retain sensitivity to chemotherapy. And we've shown pretty much the same thing with this outcome study in urothelial plasmacytoid CDH1 mutated bladder cancer, that the outcome when IO drugs were used is significantly less efficacious than when classic platinum-based chemotherapy is the cornerstone of the treatment. Great. A couple of quick words about clonal hematopoiesis. When we first discovered it, it was a bit of a surprise, but I don't think we should have not realized that as patient ages, they start to produce these clonal alterations in genes associated with hematopoiesis and genes not associated with hematopoiesis. And it turns out that several of them, especially ATM, are very much a part of prostate cancer. So we have to be very careful in a liquid biopsy not to call an ATM mutation that's actually coming from the patient's white blood cells, coming from their prostate epithelial cells, and have the patient go on a PARP inhibitor who really is wild type for a homologous recombination defect. I have a lot more information about this, but I want to just focus on one last thing about CHIP, is that it does occur in older patients. And it has been linked in multiple studies to the presence of cardiovascular disease, particularly ischemic cardiovascular disease, and that clinicians caring for cancer patients who order liquid biopsies, who get back a report that includes significant CHIP genes identified, should stop and think for a moment. Is this patient under the care of a cardiologist? Is this patient under the care on cardiovascular drugs? And just to make sure that this isn't something as a surprise, because we don't want to have a patient suffer a cardiovascular event that we could have prevented, and the CHIP would have told us that. Okay, I'm coming toward the end. So is it liquid first? Is it tissue first? No, it's the patient first. We have to decide the clinical status. Hopefully for bladder, we'll also get biomarkers that guide when to do it or not when it's in this clinically advanced stage, so we don't waste time and money. So blood-based testing is emerging as a clinically useful approach for managing cancer patients and helping to drive their therapy and predict the responses to both targeted and immunotherapy drugs. And whether to decide to do blood or tissue first is based on the patient's clinical status, not what's easier to do. I have to say, as a pathologist, I know for medical oncologists, ordering blood is good because you don't have to deal with the pathology department to get the block and submit it for sequencing. But you can't do that to the patient, because doing a liquid that's not going to give you an answer is deleterious for care. And for relapse and progression, of course, we heard from the Signatera presentation, and there are so many, that ctDNA tested frequently using a non-expensive, not an NGS test, but a test that NGS informed how to design, is a new breakthrough in how we're going to manage cancer patients in the future. And when appropriately used at the right time, liquid biopsies have a great potential to continue to improve precision and the ability to personalize the treatment for cancer patients. Thank you very much.
So thank you very much. That was an outstanding presentation. Thank you again. We do have 5 minutes for discussion prior to the coffee break. Yes, Andrea, and then Petros.
I guess I'm the only live person that can take the questions. The first presenters, we can't ask questions.
Yes, indeed, it's you.
Right, it's just me. Yeah.
Jeff, outstanding lecture as always.
Thank you.
Really inspiring. As clinician, as investigator, I have a question to you and to extend to the rest of the faculty. You perfectly outlined the fact that we should look at patient first, but how about the possibility of having some kind of biomarker that is able to coagulate all the information from tissue and from liquid biopsy? How do you feel that the possibility of having a composite biomarker in the real world will become a reality in trial design, in treating patients every day? What do you think?
That's a fantastic challenge, Andrea. I mean, when we compare liquid results to tissue results, we always have to remember that you just can't pick one from prior to treatment and one after the third or fourth line of treatment and say, look how different they are. Treatment for cancer impacts mutational analysis. And we thought at first radiation would be a particular impact on the tumor mutational burden, and now we realize that some cytotoxic drugs are even more impacting that, and all of the new evidence of using tumor like colorectal cancer, treating the patient with cytotoxic drugs just to increase the chance of response to immunotherapy. And when we use the liquid biopsy before and after, it changes dramatically. So that's the first thing. We can't compare the two if they're not simultaneously assessed at the same time in the patient's course of treatment. But when we do that, there are some things that liquid can detect more readily than tissue. Most things, though, tissue detects more readily than liquid. How to combine those remains a great challenge. and especially TMB is one. Not so much MSI, the correlation there is really solid, but TMB blood is usually higher, and especially if it's after therapy, it's higher still, and its ability to predict response to IO blood is still being, let's call it validated. The same thing with tissue tumor mutational burden. If the tissue mutational burden is for a single agent IO drug, it seems to be much more robust at absolutely predicting. When we look at the MSI array in colorectal, we saw that they're all now on label for pembrolizumab. But if the TMB, even though your MSI high is below 20, the response chance is significantly lower, and the durability of response is lower. If it's between 20 and 30, it's much higher, and if it's above 30, it's a guaranteed, it's 100% major response if you have both MSI high and TMB over 30. So those two are interacting together, and then of course you have PD-L1 to throw in, and I don't know, I mean, how are we going to do it? I mean, with some kind of AI program that can pick from this one and from that one, give them different weights, but we still wait for the perfect combination of them.
Jeff, fantastic talk, and thanks for a great talk and also what you have done in the field. I was sharing with you yesterday, you have created new avenues in cancer, so thank you for all you have done.
My pleasure.
The two quick questions for you, Jeff, to enlighten us is, number one, you made a great point about the distinction between germline mutations and somatic mutations, and with all the infrastructure you have set up, do you foresee a future where you can potentially get consent at the time of sending the test and potentially get a second sample for germline control? One question is that. And the second quick question, your comment about tumor-informed or tumor-agnostic liquid biopsies.
Great.
Thank you.
Thank you, Petros. Excellent questions. I mean, at Foundation Medicine, when we were developing the company in 2009, 2010, we asked ourselves, number one, would we do germline and tumor at the same time? And the decision was made strictly because of cost. There was no reimbursement for it in that day. To add germline would, number one, add to turnaround time, which could be deleterious to adoption. And then also to add the germline was all the approvals, the genetic counselors required. And so we decided not to do it because what was emerging from the algorithms and the pipeline was the ability to use a protocol we call SGZ, which actually looks at all the DNA sequences come from the sample, which mixes both germline from inflammatory cells, stromal cells, who knows where it comes from, and we could separately call it, not by extracting it separately, but just by being able to filter it via the algorithm that we could predict the germline. And it's very curious, the first paper that we wrote on it, we did list our one false result, where we said that the patient had a germline mutation, and they did a formal germline test, and the patient did not. There's only one case that didn't. And that patient turned out to have been a patient who earlier in their life had had a heterologous bone marrow transplant. And we had discovered a germline mutation in the donor of the bone marrow to that patient that wasn't in the patient's germline. Then became all the legal issues of, can we find the donor and inform them? And the legal decision was no, that we were not to do that. So we don't know who the donor was. So the accuracy is high, but you can't call it in every case. But a very high percent, well above 90, the germline can be done on a somatic test. But we still don't do it because of cost and turnaround time issues. Impact at Memorial Sloan Kettering does both. The Dana-Farber test, it did both. But they're not, under the same commercial restraints that a company like Foundation Medicine is.
Thank you. Andrea Rimonti, a question?
Andrea Rimonti at Zurich, IOR Bellinzona. I have a beautiful talk. So you said that clonal hematopoiesis are confounding factors, right? But there are many evidence from us and other groups around the world that show actually that clonal hematopoiesis can initiate, promote the progression of, for instance, prostate cancer or give rise to for instance, resistance to therapy. So I wonder, indeed it's known that mutation in myeloid cell, right, can drive prostate cancer, other urogenital disorders. So I wonder whether you guys are thinking to change your score or your assay in order to include actually clonal hematopoiesis as an important biomarker?
Yes, well, I think we have actually already done that in the more recent version of the report on the liquid biopsies, identifying clonal hematopoiesis genes and then a narrative of what their significance is. And it does include some of these newly emerging data points about resistance to therapy, not so much the cardiovascular disease risk, what I think we should put in there, but for some reasons they aren't putting that in yet, but we have done that, and that's a very good point. And that's especially true in prostate cancer, and it includes genes like ATM and others. Now, every now and then, we get like a JAK2 mutation that we want to call, CH, clonal hematopoiesis, and then we learn that this bladder cancer patient or this prostate cancer patient also has some type of myeloproliferative disease. So it isn't always a benign finding. It can indicate underlying and developing hematologic malignancy.
I have a very quick and urgent question. What do you think, as interventional radiologist, what do you think about to have liquid biopsy directly from the venous samples directly from the tumor and from the organ with catheter and with interventional radiology?
Yeah, that's an excellent question. I mean, for patients who you think the dilution of the peripheral blood would impact, and you have the ability to get a localized sample, that will increase and enhance the results. I don't know of any trials that are doing that, but it would certainly work. And it's something to think about where it's critical to get a sample. It's too dangerous to biopsy the metastasis, but it's safe to cannulate the venous drainage. I think that's an excellent idea.
So thank you very much again for this excellent presentation and discussion. So thank you all. There is now a coffee break and only 10 minutes, unfortunately. That's the 15 minutes, and we come back here for next session. Thank you so much.
So thank you again. We can start with the second part of the morning. And the first speaker is Dr. Brembilla for my group, for the group of the radiology department in Raffaele. And he will present the topic entitled Developing Artificial Intelligence in Perioperative Models. So please, Giorgio.
Hello, okay. Thank you very much for the invitation. My name is Giorgio Brembilla. I'm a radiologist at San Raffaele Hospital. I will give a quick overview on the studies we have on AI in our institution. And I will try the impossible, so to give some basic, very basic concept of AI and AI literature. That is, as you know, a very complex topic. Of course, my focus will be on radiology, but most of the concept can be applied also to any other field, for example, optics, robotics, or epidemiology. So let's start. As you know, to date, the interpretation of images relies on a qualitative evaluation done by radiologists, with obvious limitation in terms of subjectivity, inter-observer variability, and dependence on training and experience of the reader. But with advancement in medical imaging equipment, in digitalization of diagnostic images, and increased computational power, that now we are able to convert medical images into mineable data to extract a variety of quantitative factors to produce high-dimensional data. And this is the foundation, actually, of radiomics and AI. And so let's start from some simple definition, but they are very important. Radiomics is the high-throughput image analysis to extract qualitative features that can be morphological, statistical, or textural features from images that they are missed by human eye, so they can represent imaging biomarkers. We can use the radiomics feature to train AI models, and we can use AI to extract radiomic features so they are interconnected. Artificial intelligence, per se, is a very broad definition and refers to any computer method that performs tasks that normally require human intelligence, even simple tasks like face recognition. Machine learning is one type of artificial intelligence that develops algorithms to enable computers to learn from data and to make prediction on data that they have never seen before. And it's the type of artificial intelligence that we usually use in radiology. And deep learning, in turn, is a type of machine learning that uses a specific architecture. Namely, it's made of interconnected layers of software-based calculators that are referred to as neurons to form so-called neural networks. And the peculiarity is that deep learning can automatically extract relevant features from images. And finally, convolutional neural networks, it's a type of deep learning model that uses a mathematical computation that is convolution to deal with the amount of data that we have from images. And here we have a quick example of pipelines. For example, when you use machine learning, we have to delineate, for example, the tumor within the prostate. We extract relevant features that we know to be associated with cancer. And then we use this rule to train the model that will learn to detect tumor autonomously. In turn, deep learning, it's a little bit different in that we have an input that is, for example, magnetic resonance imaging. We define the desired output, and then it defines its own rule to recognize the pattern, to recognize pathology. And this is potentially a way more efficient, a way more powerful tool that can be even more accurate, but it comes with a cost, and it requires a lot more computational power, and it requires a lot more data to be adequately trained. And also, it represents a sort of black box we know the input, we know the output, but we cannot know what happens. We cannot know the rules of the machine. So sometimes it can be difficult to apply these tools within the clinical practice because we don't know what is going on in there. And this is a typical pathway for developing AI tools. So it is important to know that we need a training set that should be as large as possible to train the algorithm. The algorithm is trained and then is validated to see how it performs and which algorithm performs well. And also it is used, the validation, to optimize the hyperparameters of the algorithm. Then we end up at the final validation with a predictive model that should be tested. And we need to be aware that the test set should be different. It's a different concept, even if sometimes it's mistakenly used as a validation concept. They are two different things. Once we have the final model, we test it and should be an external testing. When these are confused, this can have a huge impact on the validity and on the interpretation of the results. Because if we use, for example, test set to then reset the algorithm, of course, we will have a problem with overfitting, with overperformance. So we need to know that there's a stringent rule for developing AI tools, and we should be very aware of this. Of course, there's been a dramatic increase in the interest in AI research in medicine, and not only medicine in recent years. But now it's becoming a little bit of a jungle, so we need to make a little bit more clarity in this literature. So what are, in terms of radiology, the potential application of AI? So in the very early days, the focus was in replacing radiologists to detect tumors with machines. But I'm still here, so probably the reality is a little bit different. And actually, we are missing a really great opportunity if we have only this focus. We can apply AI virtually on anything. And regarding the radiologic workflow, we can apply AI in selecting patient. We can apply, for example, AI for acquisition to increase the quality of the images and to reduce the time that it's required to acquire images. For example, for magnetic resonance imaging, of course, for image interpretation, for reporting, reducing the workload, and also for management, for example, biopsy planning or pre-treatment decision. This is one example. And this group used a deep learning algorithm that allowed to acquire biparametric MRI of the prostate in more or less 4 minutes instead of 15 minutes, reducing time, costs, reducing the need of contrast media, of course, and with increasing potentially in a dramatic way the accessibility and the availability of MRI and increasing the acceptability from the patient. So you understand that outside detection, there could be a very dramatic impact of AI. Or, for example, in this other study, they used AI to develop and validate an artificial intelligence algorithm to decide the necessity to perform dynamic contrast enhanced sequences in prostate MRI. And this model performed more or less like the experience reader. So if we had something like this, this could render the requirement for on-table monitoring from the radiologist obsolete, and we can perform contrast enhanced MRI only when needed. And this is just one example. When we go to detection and characterization of tumor, we have a plethora of studies in the literature that more or less they tell the same thing, so that AI performs really well in these tasks. So I cannot do a comprehensive review of the literature. It's really, really vast. But just to know that every model that is proposed in AI for any tool, for any purpose, at the end of the day, performs very well. So probably it's we had better concentrating on the issues, because we are not still using these tools. And why is that? We should be more aware, probably. We know very well the potential of AI, but we should be also aware of the limitation. And many times the studies in the literature have insufficient quality. in that they are retrospective and with selection bias, and they have some problems with standardization in design or reporting, high heterogeneity, for example, in a study on, in a survey on radiomics studies, the average quality was only 23%. Only a minority of the studies that generalizability assessment, clinical utility, or sufficient transparency. So, and mainly they are not sufficiently tested in multi-center studies, and it's lacking the head-to-head comparison with radiologists. So we still have many challenges in AI. The main, as I said, being numerous sources of methodologic heterogeneity, bias in model validation, as we already seen, and the lack of evidence of clinical translation. And this is one very important concept, is that for the nature of machine learning system, they consist in a set of rules that are trained to operate under certain conditions. So they can perform very well in certain scenario, and then if we translate them in other scenarios, they can also perform very poorly. So this is a problem of generalizability that sometimes comes at the cost of sacrificing the performance. And probably it's still early, because maybe one possibility to overcome this issue will be long-term increase of training data. And I mean, we need a huge amount of data to train algorithm to be generalizable. In terms of heterogeneity, this is, for example, the pipeline for radiomic study. And if you understand that each one of these steps can introduce variability, you know that the variability can be huge, and we need standardization. There have been already proposed a lot of AI quality evaluation tools for AI system development, and also for usefulness, to evaluate the usefulness in clinical trials. So it is important that we follow them both when we design the study and when we interpret these studies. And also, we already have a lot of commercially available CE-marked, FDA-approved tools, but we need to be aware that FDA-approved, CE-marked does not mean effective, does not mean useful. And only a minority of them have peer-reviewed evidence, and most of the studies demonstrate lower levels of efficacy. And it's not surprising that to date, not forever, but to date, the satisfaction of radiologists is pretty low, because sometimes they feel that there's no additional value, that they do not perform as well as advertised, and sometimes they add too much workload. They should be supposed to reduce workload, but if they are not tuned, they will add workload. And finally, there's an issue here. What do we do with AI advices? There's a concrete risk of over-reliance. So we do as AI say without any critical recognition on the advices of AI. So we need also to understand in advance how we will be using the AI tools. So just for the introduction, to recap, AI it's here to stay, no doubt, and it will have a huge impact especially on radiologic workflow. And it represents a unique opportunity to improve the efficiency of clinical and radiological workflow, increasing the performance and reducing the workload. But we need to be rigorous in methodology when performing and interpreting AI study, and we need to set realistic expectation on AI tool. And clinical knowledge must drive AI development to address clinically relevant needs. So we will do also a quick overview on ongoing studies regarding AI in our institution. The first study is, of course, on multiparametric MRI for prostate cancer detection. And this is, again, the same slide as before. We have this problem that we have commercially available tools, but we don't know how they perform and if they are clinically usable and clinically effective. So we are evaluating this tool that is QuantiProstate software. It's a very promising tool that is designed to help the radiologist not only detection not only for improving the judgment of MRI, but also for allowing a more efficient workflow and to reduce the workload of a radiologist. There are already few preliminary studies indicating a possibility of improved diagnostic accuracy, especially for less experienced radiologists, and a reduced reading and reporting time for both experienced and inexperienced radiologists. So the aim of the study we are conducting to validate essentially this quantitative process will be to investigate the implementation of quantitative process in our workflow with regards to time efficiency, inter-observer agreement, and diagnostic performance compared to the traditional pathway. It will be a single-center, multi-retrospective study on 200 men who underwent MRI and eventually biopsy in our institution. With at least, we expect to have at least 3 readers that are experienced radiologists, 2 inexperienced radiologists, and also urologists. Basically, we will include all the patients with high-quality MRI who did not undergo prostate cancer treatment or diagnosis before. And essentially, to resume the workflow, basically, we will review the images. Each of us will review the images with the AI and without the AI, with a washout period, and then we will compare essentially the performance. So the primary aim will be to compare the performance in terms of diagnostic accuracy of radiologists or urologists with or without the intelligence, the artificial intelligence tool for the detection of clinically significant cancer. And secondary aims, but still very important, we will evaluate the reporting time changes, inter-assembly agreement, and the benefit in all of this in experienced, non-experienced readers, and also to urologists. So we will have to perform the training with the software. We hopefully will start soon, and we will complete, hopefully, the study within 1 year. The other very, very interesting study will be to develop AI in another setting, that is multi-parametric MRI of the bladder, to identify complete response in patient undergoing neoadjuvant immunotherapy. So I do not have to explain how immunotherapy changed the treatment in bladder cancer. And also, we are now realizing that multi-parametric MRI could be actually a very effective tool in predicting complete response after neoadjuvant chemotherapy, and could potentially be one of the standards for treatment assessment. And it's already the standard for other similar topics like rectal cancer, esophageal cancer. So we know we have hopes and expectation, and it has also been already explored nicely by Professor Necchi and his staff. So AI in bladder cancer basically can be applied in many ways, but basically in 2 ways in terms of evaluation of response at cystoscopy to aid the identification of residual disease at cystoscopy, and on imaging using MRI. So current data on AI for bladder compared to, for example, to prostate imaging is very limited, and to date we have no study investigating AI for MRI in bladder cancer in a post-treatment setting. For example, here we have an example. We have here, this line is pre-treatment with this tumor that is very evident, and so after treatment it's still there. We have no doubt this is a very simple case, but I can assure you that especially in the post-TURB setting, things can be way more complicated. So it will be very useful for us to have a tool to help us identifying residual disease, and also to include all the clinical and non-radiological data to predict the complete response to immunotherapy. We have ongoing collaboration with Oking Inc. and Columbia University on this. And basically, our study will aim to develop an algorithm to predict response to the neoadjuvant pembrolizumab on MRI of the bladder on 160 men who underwent MRI before and after neoadjuvant chemotherapy. So we will have 320 scans, and these will be patients that are already that will be taken from the Pure 01 study. So this would be a single-centered, non-randomized retrospective observational study with the primary endpoint of correlating MRI with pathologic complete response. So we will evaluate MRI to extract radiomic features that are associated to complete response and to train a machine learning algorithm that will be trained and validated and tested for this task. Also, the performance will be evaluated against and together with clinical predictors that will be used also as covariates in multivariable logistic regression models to predict complete response. And a satisfactory algorithm will be the one that will be outperforming in terms of discrimination and net benefit through the decision curve analysis, the known clinical predictors of the response. And also this was a very interesting, a very important concept that when we use AI, we also can exploit the multimodality. We can include clinical information into AI tools that also use radiologic information. And this is known to perform better than the single approaches alone. So thank you very much for the attention.
Okay, thank you, Giorgio. I think we have just a couple of minutes for a couple of questions. Please, Andrea.
Outstanding talk, compliments, and I would like to assure you that we are proud to have you here in person, and they will make sure that you will stay here with us in person. My question is very simple and hard at the same time. What do you see regarding the possibility of using artificial intelligence as a way of reducing disparities between countries in accessing diagnosis, in accessing therapeutic evaluation, therapeutic efficacy? So do you foresee any possibility for you to be of any help for your colleagues in Africa or in Asia or in South America to develop these tools and to be helpful also for patients in these geographical regions by using artificial intelligence? This would be, to me, the major step.
Yes, of course, because AI is above all about optimization. So you can optimize each step of the workflow to have it performed in a more efficient way, less time-consuming, less costing. So I definitely think that if we develop in the right direction, the AI tools, they can be used to increase the accessibility to cares and to diagnosis, also in less experience and less settings with fewer, resources, of course.
Thank you very much again. So now it's our honor and pleasure to call to the stage Professor Andrea Limonti, who is a worldwide well-known expert in translational research in prostate cancer. He is head of molecular oncology at Institute of Oncology Research, full professor of oncology at Università Svizzera Italiana in Ticino. He actually published extensively on the role of innate immunity in prostate cancer on the major journals like Science, Nature, Cells, and anywhere else. So please, Andrea, we have the honor to have you here, and the floor is yours. You will touch upon the role of innate tumor immunity in prostate cancer, please.
Thank you, Alberto. Thank you to organize for this beautiful meeting. So it's really an honor to be in Milan and to give this presentation. So I don't have to speak about the relevance of prostate cancer. We know that prostate cancer is still a major cause of death. The reason is because we are unable, yes, to treat patients which are affected by castration-resistant prostate cancer. So and my team is trying actually to understand the mechanism by which CRPC is initiated and progress, and whether we can identify therapy that either revert CRPC in hormone-sensitive prostate cancer or that treat CRPC by, for instance, using the anti-tumor immune response. And during the year, we have contributed to the field of prostate cancer pathogenesis by generating multiple transgenic mouse model of prostate cancer, starting with the first mouse model back many years ago, where we identify, together with other, the tumor suppressor P10. We were the first to generate a knockout of P10. So 10 years ago, was still not known whether P10 was a relevant tumor suppressor gene. You can see how fast is the research. And we have later on start to cross this mouse model with multiple different mouse models in order to understand how the prostate cancer is initiated, progress, and even metastasizes. So we have focused our attention on metabolic rewiring or the acquisition of multiple genetic alteration that can essentially give rise to metastasis. So, but today I want to discuss about the role played by the tumor immune response in propelling prostate cancer and give rise to CRPC. This is the work from Diletta Dimiti, Alberto Toso, the now work at Roche, and one at Humanitas here in Milan, that many years ago in 2014 discovered essentially that a subset of immune cell known as a polymorphonuclear myeloid cell, or also now named also neutrophil, essentially there are no difference in this marker, could actually confer treatment resistance in mice treated with either chemotherapy or hormonal therapy. As you can see that there are many other groups around the Pigno lab, like Pandolfi lab, that have validated this finding. So we now know that when the tumor prostate cancer form, this is strongly infiltrated by this population of neutrophils, which is constitute the major immune set infiltrating the prostate cancer. Together with Jan de Bono, team Royal Maxer, we were able in 2018 also to spot the presence of this myeloid cell in small metastases in patients affected by CRPC, and to observe essentially that the number of these CD15 positive, CD33 positive cell increase in CRPC patients when compared to hormone-sensitive prostate cancer patients. And this is in line with other data which have been reported by multiple groups that demonstrate that an increased number of neutrophils correlate with the decreased number of lymphocytes. This NLR is actually prognostic in prostate cancer patients, and patients that have, for instance, high NLR do not respond to either chemotherapy or androgen deprivation therapy. So, but how these myeloid-derived suppressor cells are essentially recruited into the tumor? So we discovered in 2015 that there is a receptor here, which is called CXCR2, which is expressed by this population of cells that is expanded from the bone marrow of a patient when the tumor is initiated. And the reason is because the tumor secretes a lot of CXCL2, 3, and 5, which are analog of interleukin 8. This bind to the CXCR2 receptor, and therefore there is a flux of this myeloid cell into the tumor. So now we know how this cell can be recruited, but how this myeloid cell can control prostate cancer growth. So for many years, we have worked on cellular senescence, which is a response that can be elicited, for instance, by chemotherapy or targeted therapy. So a cell which are treated with chemotherapy can decide two things, either to die or to arrest in a irreversible manner. This is the definition, essentially, of cellular senescence. So we discovered that this immune cell, this myeloid cell, were actually capable to rejuvenate prostate tumor cells treated with different chemotherapies, as demonstrated by this paper in 2014. And this was due to the fact that this myeloid cell, which infiltrate prostate cancer, can release interleukin-1 receptor antagonist, which is needed for induction of cellular senescence. And therefore, we envisioned back in 2015 that the blockage of this receptor, presence of myeloid cell, could essentially enhance the efficacy of standard of therapy, such as, for instance, chemotherapy or androgen deprivation therapy. And this is essentially the case. We were able to partner with AstraZeneca in developing a CXCR2 antagonist that we have now moved in the clinic. And as you can see here, essentially, this is a simplified cartoon. While there are a lot of myeloid cells which infiltrate the tumor in a patient that is subjected to chemotherapy, if we block the recruitment of this cell in the tumor, we enhance the efficacy of chemotherapy, because this cell cannot produce oncogenic factors. And this is, since they also control the immune system, or actually the immune response versus the tumor can be reactivated. But now I also want to show you another important role of this myeloid cell. This is has been shown in another paper we published on Nature in 2018, thanks to the contribution of Aranna Calcinotto, which actually came from San Raffaele. So Aranna Calcinotto demonstrated that androgen deprivation therapy can further increase the recruitment in the tumor of myeloid-derived suppressor cell, and that actually this myeloid-derived suppressor cell, when co-cultured with the tumor cell which were subjected to enzalutamide treatment, were actually able to promote the emergence of resistance by activating the ROR-STAT3 gamma pathway signaling. And so Arianna discovered essentially this myeloid-derived suppressor cell, once recruited in the tumor, can release interleukin-23, which bind to the interleukin-23 receptor, which is expressed in prostate cancer cell, particularly in patients subjected to androgen deprivation therapy. And by doing this, essentially, this activate the proliferation and the migration of this cell. So this finding was also reproduced by Johan and us in patients affected by prostate cancer. We now know that CRPC prostate cancer, patients affected by CRPC have elevated level of IL-23, and there is a correlation of IL-23 with essentially myeloid-derived suppressor cell infiltrating prostate cancer. So when we use an antibody which block IL-23, or we engineer a mouse model that doesn't express IL-23 in myeloid cell, tumor respond better to therapy which deprivate the mouse from essentially from androgen. And we have, as I will show you in a bit, move two different therapy to the clinic targeting this myeloid cell. The first is an antagonist, as I said before, of the CXCR2 receptor, and the second one is an antibody that blocks IL-23. So this is the result, here in this program, which we name a co-clinical program in prostate cancer, where we are trying essentially to move different discovery done in the lab, in the clinic. And these are the two studies, the ACE study that we have run in collaboration with Jon and Silke Gillessen, which is here, and the other trial is the ACTION trial. So now I'm going to talk about the result of the ACE trial, since the ACTION trial is still ongoing. And you can see that in this trial, we actually used for the first time this inhibitor of CXCR2 in patient in association with enzalutamide. And actually, this worked in 6 out of 22 patients. We were able to observe like a response, so we have a partial response. And again, this is the first time that a compound that target not cancer cell but immune cell elicit a positive response. This is a second patient here. This is a partial response. Elicit a response in prostate cancer. However, as I said, only 6 out of 20 patients respond. And so we want to try to understand why some patients do not respond to the CXCR2 inhibitor. So this is an effort that is ongoing at the moment. But we think these are essentially new data that I'm going to present here for the second time. The first time I present at Prostate Cancer Foundation. We think that the tumor find a way to recruit this myeloid cell also in patients that are treated with the CXCR2 inhibitor. And now we end up to discover that thanks to the contribution of another team member of the lab that was working on the secretory phenotype of prostate cancer by using a very complex technology which is called polysome profile analysis. In other words, we measure the mRNA level of different secreted factors which are loaded on ribosomes, so that are going to be translated. So there will be essentially a protein. By intersecting the presence of secreted factor with receptor expressed in myeloid cell, we were able to discover that there are indeed multiple secreted factors which can additionally recruit myeloid cell in prostate cancer, even in mice, and we also think in patients treated with these CXCR2 inhibitors. However, there are like 4 factors, this is very interesting, that are called big ligand, SPP1 and HGF, that they bind to different receptor presence of myeloid-derived suppressor cell that are very strongly upregulated in the prostate tumor microenvironment. And by knowing, and in particular, there is a very high translation efficiency. So the tumor translates a high quantity of SPP1, HGF, and big ligand, but not of other factors. So we focused on these three factors. We were able to see for the first time that actually these three factors can recruit myeloid-derived suppressor cell into the tumor. It can also enhance the immunosuppressive and pro-tumorigenic function of this myeloid-derived suppressor cell. So since, as I said, these factors are strongly translated in cancer, we wanted to understand how this translation had happened. And so we end up to discover that in prostate cancer, there is a very high level of phosphorylation MNK, which actually control phospho-EI4E. Why this is important? You are a major clinician here, so you don't care. But in other words, there are essentially inhibitors of this MNK, which are actually in the clinic, and also and that we combine, thanks to this notion, with the other inhibitors, which are already in the clinic, of the AKT pathway. And so by combining ipatasertib, which is an AKT inhibitor, with this MNK1 inhibitor, we were able completely to revert the secretory phenotype of prostate cancer and to impact on the recruitment of this myeloid-derived suppressor cell into the tumor and to reactivate a positive anti-tumor immune response. So we think that this combination of EFT508 and ipatasertib is a novel way to go, a novel type of immunotherapy in order to suppress myeloid-derived suppressor cell, potentially also macrophage, and reactivate a positive anti-tumor immune response in cancer. I try to run because I know that I have only 15 minutes, so I hope I made my job. So I want to thank the people who made the work happen, Prostate Cancer Foundation, IRC, and other funding agencies that have supported this work. Thank you.
So thank you very much, Andrea, for this great talk. I don't know if we have questions from the floor. Can you please elaborate a bit more about your novel research or how the interaction with this myeloid-derived suppressor cell functioning and the microbiome of the prostate? Is there any link you're currently studying on, whether we can modulate or we can, in a way, increase or modulate the function of these innate cells by modulating the microbiome? Is there a way to go?
Yeah, well, so there have been recently a lot of publications, including one from our team, where you are also one of the co-authors in Science, that demonstrated that the microbiota of prostate cancer patients is really important for the disease progression and the resistance to therapy. We have done like a number of experiments trying to understand whether the microbiota can actually instruct essentially this myeloid cell, but we didn't see essentially a big effect, right? So there are many papers where there is this link between microbiota and myeloid-derived suppressor cell. We think that the effect that we see is more due to the fact that these microbes can produce actually androgen rather than instruct a tumor immune response. But now we have an additional story going on with the microbiota, where we also correlate the presence of candida, for instance, to the possibility to instruct the tumor immune response. And we have like evidence that this is the case for the candida, for instance.
Andrea, wonderful work and really, really impactful, very promising, for the present and the future. Two quick questions from me. One has to do with the potential discordance between blood and tumor tissue. We have published some work in bladder cancer, looking at MDSCs and what is happening in the tumor tissue may not be reflected in the periphery. So one question for you is whether there is any potential for circulating MDSCs in prostate cancer or not. And the second question is, again, in bladder cancer, we have interest in natural killer cells as part of the immune response, especially response to BCG. Any comments about NK cells in prostate cancer? Congratulations again.
Okay, thank you. So there are two nice questions, right? So the first question is whether the polymorphonuclear myeloid cell in the blood correlate with the tumor infiltrating one, if I got correctly, right? So Johan de Bono is actually doing like this follow-up study where we are taking these NLR high patients, so patients with a lot of neutrophils, and trying to understand if these neutrophils are indeed polymorphonuclear myeloid cell. And what is observing essentially that there are many cases in which there is no correlation. So very low level in the blood, but the high level into the tumor, right? So this is kind of intriguing. We still don't know why this happened. We have some evidence that, but we can discuss later on, that could lead to accumulation of this cell into the tumor. So prolonged cells which are perhaps mutated that survive longer into the tumor, but they are not expanded from the blood. And the second question is about NK cell. Now we have, we never worked, but we recently, I recently bumped on a data from the lab in which we are working with senescence modulators. So we have drugs that induce cellular senescence in prostate cancer. And we found that when we use this combination of drug, we have a lot of NK cells which are recruited through IL-33, and are activated strongly by the secretory phenotype of this tumor cell. And we see a strong response in prostate cancer and a reactivation of also T cell. So I think they have a lot of potential, and I'm particularly intrigued about the possibility of this NK CAR cell. I don't know if you guys are working on that. That, in my opinion, could be really promising in prostate cancer. Well,
Noel?
Yes, congratulations on that, and very entertaining. We've been doing parallel studies looking at P10 loss, etc., with knock-in and knockout in relation to phosphorylated FRNA2, which is a substrate of AKT, and they work interactively. What we found is that the effect of P10 loss is negated if the phosphorylated FRNA2 isn't present, and these are all migratory pathways. So you didn't look at that in your data, and I wondered if you might consider it. The second thing is what we found in looking at the leading edge of tumors is that the activation of the migratory process is within a very short space of the leading edge of the tumor, and we've mapped this out with spatial immunofluorescent chemistry, and whether you'd be able to do that in your models.
So we didn't look at, so what's the name of this regulator of AKT that you...
Phosphorylated FRNA2. We have a series of papers.
FRNA2, yeah, exactly. So
we published the latest one earlier this year.
So we found actually an elevation in phosphorylation EIF2, but we didn't focus on mechanism of blocking the EIF2. But we found that it's upregulated. Yeah.
When we did a combined study which was looking at it in the lab, but we also looked at it in patients who we'd followed for about 20 years with death, prostate cancer death as an outcome. And the difference in outcome was in years in terms of P10 loss with phosphorylated FRNA2 in the primary. It was very prognostic.
Yeah, now, for instance, in this study, we partnered with Holger Mock in Zurich, and we found that the PDCD4, which is another regulator of the EIF4E complex, is also very prognostic in prostate cancer. So I think that we should look in more detail to all this regulator of translation as a novel biomarker. And actually, we have seen that AKT ipatasertinib elevate, for instance, EIF4E phosphorylation, and that's why perhaps I didn't mention that. The reason why we want to combine IPA with MNK inhibitors come from the fact that we found a strong elevation of EIF4E phosphorylation upon ipatasertinib treatment.
Yeah. If you get the chance to look at it at the leading edge, you might find that quite instructive, because everything seems to be booted up within a very small space.
Well, thank you.
Thank you very much again, Andrea, for the excellent talk. So now we go to the next presentation. It's our pleasure again to invite to the stage Dr. Derret. She actually will talk about tumor heterogeneity in prostate cancer. Dr. Derret is coming from Pisa, now working in Mount Sinai in New York City. She has been very well known. She is very well known for a great work on biomarkers in prostate also. So please, we are all keen to hear your presentation.
Thank you very much, Alberto, and thank you for your invitation. It's a great privilege to be here today in Milan and with so many great scientists. I'm a clinical pharmacologist, so my presentation will mainly focus on predictive biomarkers of resistance and response to therapy into a scenario of heterogeneity in prostate cancer. So just to start, I would like to highlight some of the key points about tumor heterogeneity. We know that prostate cancer is characterized by a clinical, morphological, and molecular point of view of a highly heterogeneity. This heterogeneity is mainly determined by genetic and epigenetic alterations. Technological improvements like next-generation sequencing, comprehensive genomic profile, artificial intelligence, and liquid biopsy teach us that the tumor heterogeneity is very complex. We can have an interpatient heterogeneity, that is a diversity because between different patients. We also have intratumoral heterogeneity into the primary tumor, and we also have an heterogeneity between the different metastatic sites, and we talk about intertumoral heterogeneity. So when we talk about tumor heterogeneity, we include epigenetic, expression, post-translational, morphological, phenotypic heterogeneities, and all contribute to the disease progression and the clinical manifestation of a solid tumors. We will talk about prostate cancer, but these mainly characteristics are shared between all the solid tumors. So when we talk about tumor heterogeneity, now we are also able to identify what could be a clonal model clonal progression of prostate cancer. We know that the tumor is originally composed by different cell clones characterized by different molecular alteration. During the progression, there is an evolution of different clones that are spatially separated, and they go to constitute the primary tumors with different and distinct genomic driver changes. What we have when the tumor progresses and metastasizes under the selective pressure of the systemic therapies is that the metastatic dissemination of a tumor subclone accumulates with further genetic and phenotypic alterations, and this will build a different tumor under a molecular profile very different from the primary tumor. So we know that the prostate cancer is highly heterogeneous, and we also knew that from the morphological point of view, because we know that the prostate tumor may have different Gleason score. So this is a representation of a radical prostatectomy specimen with two distinct tumor foci. You can see that there are different Gleason score into this different section, and this is one of the most clear representation of tumor heterogeneity, talking about the morphological heterogeneity. At the basis of this morphological heterogeneity, there is a molecular heterogeneity, and you can see here in this clonal and subclonal heterogeneity in a tumor tissue. You talked about PTEN previously. Now I'm showing you how this tumor is able to show a subclonal loss of PTEN in a subset of cancer glands. You can see the differential expression of PTEN into the same lesion. This is mainly one of the reasons why we had the ipatasertib trial failed. Maybe the tumor heterogeneity may be one of the causes of this failed. So what we know is that the clonal evolution of all these molecular alterations is selected by the treatment pressure. We have the initial presentation of a tumor mainly characterized by different clones with different allelic fraction. We have the recurrence of the disease, and at the resistance of therapy, as I told you before, there is an expansion of the resistance clones that are able to proliferate under the selective pressure of a treatment. So this is the schematic representation of what actually a pharmacological treatment is able to do. We have at the baseline the coexisting of heterogeneous cancer cell clones, what the treatment that you are administering to your patients is to kill the sensitive cancer cells and to allow the proliferation and the differentiation of resistant cells. And what we know about prostate cancer is that the number of clones increases at the increasing of the PSA values. So I will focus my presentation on a few molecular drivers. In prostate cancer, there are a lot of mutations other than these, but I just selected these mutations for timing reasons and also for their mainly clinical significance in terms of therapies. So I will focus on androgen receptor alterations that are the tumor driver and also predictive biomarkers of both response or resistance to treatment. There is PTEN deletion. You already told about PTEN a lot. There is TP53 mutation that I used to put together with RB1 deletion because together they represent a predictive biomarker of resistance to treatment, and there are the DNA repair genes like BRCA1 and ATM and so on. So talking about androgen receptor, I cannot escape from talking about the strange, unlucky story of the androgen receptor variant 7. This biomarker was published in New England Journal of Medicine and was quite unlucky story because we had a lot of evidences from the literature of the predictive role of these variants in prostate cancer as a resistance to the hormonal treatment. We had evidences on circulating tumor cells, evidences in exosomes, in tissues, in RNA, but we still don't use this biomarker in clinical practice. Maybe the factor that we are still lacking is to give an ARV7 a cutoff. The study only mainly focused on the presence or absence of the ARV7. Maybe a cutoff will help to stratify patients as really resistance or responders to therapies. But the androgen receptor is also a predictive biomarker of resistance to treatment in sense of overexpression of the receptor. We know that patients who have been exposed to hormonal treatment, in this case is enzalutamide, overexpress the androgen receptor. And this is one of the mainly pharmacologically mechanism of resistance of solid tumors. They overexpress the target of the therapies. So we already have a lot of evidences about the androgen receptor overexpression. You can see here the pink curve that represents patients with androgen receptor overexpression. But today, since we increases our number of drugs, I would like to introduce another predictive biomarkers related to the androgen receptor that are the point mutation of the androgen receptor. These point mutations may be acquired during treatment. They usually appear in the binding site of the androgen receptor and the drug. And what they do is to activate the receptor in some case, but particularly some mutations are able to transform some drug from antagonist to agonist. And this would be very important and very interesting, also in terms of identify a correct sequence strategy of treatments for those patients. You can see here, even if the number of patients is not very high, the green line represent the patients with the androgen receptor mutations treated with abiraterone or enzalutamide. Another mechanism of resistance to hormonal treatment, I previously mentioned the RB1 mutations and TP53 because they can identify a particular mechanism of resistance that is the histological switch from adenocarcinoma to neuroendocrine histology. And this is a very interesting study conducted on circulating tumor DNA to recognize the transformation to castration-resistant neuroendocrine prostate cancer. You can see the molecular profile that is very different between the adenocarcinoma and the neuroendocrine histology with an increasing in loss of genes, of an increasing in the number of non-synonymous single nucleotide variants, and in particular, you can see here in this representation, there is a lack of mutation or focal gain of androgen receptor, and there are many hypermethylated genes. So this was rucaparib. One of the main mechanisms of resistance is the loss of CDK12. I think this would be very interesting because CDK12 may be a predictive biomarker of resistance to PARP inhibitors because it led to genomic instability and to increase of neoantigen expression. And at the same time, CDK12 loss may be a predictive biomarker of response since this increased neoantigen expression may give sensitivity to PD-1 inhibitors. You can see here that the CDK12 patients who had no response to PARP inhibitor may have a higher PSA response rate to PD-1 inhibitors. So a very preliminary data, but that could be very interesting for prostate cancer. I'm going to finish my presentation just highlighting a new concept, and I would like to bring you this data, this very interesting data about the differential response of BRCA2 versus BRCA1 patients to PARP inhibitors. You can see here that apparently, even if the numbers are very low, but patients with the BRCA1 mutations respond less to PARP inhibitors. And I think that the conclusion and the results of this paper are very interesting because the authors say that the differences in response might be related to the co-occurrence alterations in the BRCA1 group. I think this is a very interesting result because with the improvement in the biological knowledge, with the technological knowledge, we also learn to talk about co-occurrence mutations and not only of mutually exclusive mutation. We were used to talk about mutually exclusive mutations since a few years ago. What I would like to introduce with those data is the concept of gene dialogues. Because when we talk about co-occurrence mutations, we do not have to think to a functionally isolated role for each mutation, but we should start thinking about how these mutant genes are connected between each other. Because we know that from a biological point of view, genes are able to dialogue between each other. And today there are a lot of studies that uses artificial intelligence, for example, to address the entity of these gene dialogues. You can see here that there are a few characteristics of a gene when it's mutated in a complex of other genes. These characteristics are the degree or the connectivity or the betweenness of the mutant genes. How to translate these gene dialogues into your clinical practice and how to learn how to treat those patients. This is one of the studies that we are conducting in PISA about the gene dialogues. This is the case of BRAF. The question was why, if a BRAF is a driver gene, why colorectal cancer do not respond to the same drug of a melanoma patient? This is why, because of the gene dialogues between the tumor. These are the gene dialogues of the BRAF gene in colorectal cancer. These are the gene dialogues into the melanoma patients, and these are the gene dialogues of BRAF into non-small cell lung cancer. So maybe one day, earlier, I think, we will be able to use this information on how genes are able to dialogue between each other to understand how to best treat our patients. So to conclude, about tumor heterogeneity, primary prostate cancer are often multifocal with spatial and morphologically distinct tumor foci, which may show non-overlapping truncal genomic alterations, suggesting that multiple clonally distinct cancers can arise in a given patient. Intratumoral and intertumoral heterogeneity present within the prostate gland poses diagnostic and therapeutic challenges. despite the multiclonal or primary cancer therapeutic intervention seems to select for a single dominant clone. The development of novel technologies will allow us to navigate these challenges and refine approaches for translational research and ultimately improve our patients' care. Thank you for your attention.
So thank you very much, Marta, for this very nice presentation. We have time for one quick question because time is running very fast. So from my side, very quick question. Are all PARP inhibitors the same?
No. Absolutely not. No, I mean, we also have some pharmacological characteristics that differentiate the PARP inhibitors. For example, the ability to bind and to create the fork into the DNA. There are many pharmacological characteristics that are able to differentiate PARP inhibitors from a molecular point of view. I would say that the mainly differentiation of PARP inhibitors we will have will be into the resistant mechanism, and mainly not on their clinical activity that is already demonstrated that they are quite the same, and maybe we will see it into the mechanism of resistance.
Thank you very much again.
Thank you. So we have to run to the last presentation. Dr. Larker from the Urology Department of San Raffaele Hospital show us the results of the clinic development of the von Hippel-Lindau syndrome, which has been built in these two last years in this hospital with very great results. So please.
Thank you very much. My name is Alessandro Larcher. I am a urologist. I have the honor to present our program devoted to VHL disease, which basically means that I will take the credit for the work done by others, because this is a very multidisciplinary clinical research program, basically involving the entire institute. Von Hippel-Lindau is a protein with a key role in renal cancer. If it doesn't work, HIF accumulates in the cells, thus promoting growth, angiogenesis, cell proliferation, and ultimately cancer. And the importance is critical because of this apical position, very upstream relative to all the targets of all the systemic agents that are available for this disease. From a practical point of view, patients with the germline mutation in VHL disease have a very heterogeneous clinical phenotype. This is the most common cause of genetically defined renal cell carcinoma. And according to those estimates, we expect an active population in Italy of 2,000 living individuals, which is a lot of work for us, as you can see, because this is the only center that is recognized by VHL Alliance in South Europe and in Italy. And this was critical for us because since the very early development of the program, we wanted to work step by step with the patient association in the development of our clinical activity and also of our research program, which for us basically it's one thing. So when we designed our program, we wanted to assist our patients into three individual steps that corresponds to three different moments in their management. Number one would be the indication for genetic referral and genetic testing, which basically is the patient that has fear to have the syndromic disease, and we do not have a clear diagnosis yet. How to do that? First, we always want a pathologic confirmation of a primary which is highly suspicious for VHL disease. And then, if this is corroborated by, for example, a high-risk primary or by multiple low-risk primary, or by a family history which is suspicion, then we go for testing. There are recommendations which are endorsed by VHL Alliance as well. but the level of evidence that we have here, and this is a common problem that those of you manage rare disease are very familiar with, are only expert opinion based. So at the very beginning of our program, we have done this huge review of our repository of the institution, and we were able to merge the clinical data set of all those different clinicians managing the primaries that are common in this disease. We merged all the data together with the central pathology unit, and we merged also with the results of patients that were elected for genetic testing, and this allowed us to create a kind of scale of the primary that are the most frequently associated with the syndromic disease. As you can see here, in red, the proportion of patients with confirmed pathologic variants in VHL locus. In case of central nervous system hemangioblastoma is 15%, in case of retinal hemangioblastoma 35%, which are figures entirely different, for example, to patients that are treated for a sporadic clear cell renal cell carcinoma, in which the risk of syndromic disease is less than 1%. So this is a kind of balance between how often this disease appears in a sporadic setting relative to in a syndromic phase. And again, here the literature is very poor. What's next? So provided that the diagnosis is confirmed, what can we offer to our patients? This is a disease which is not the typical renal cancer that you take to the OR, you operate, and then you say goodbye, you will have a fine life, but it's a kind of marathon that those patients have to run through all their life. So surveillance is a key option to, let's say, plan the economy of multiple treatment that those patients will receive during their life. So this is a common experience also of the overseas colleague. We have a lot of patients traveling the country that wants to be treated by us or managed by us, so we have to be as fast as possible. We manage the patient in an outpatient clinic, and in 3 days we are able to offer all the instrumental and diagnostic examination, plus the clinical consultation with us as urologists, with the pancreatic surgeons, and with the neurosurgeons, and of course with the medical oncologist. This surveillance program is, by definition, an observational prospective studies that allows us to basically gather key information that are dramatically lacking in the literature so far, because, for example, it is unclear what is the burden of the disease, it is unclear what is the heterogeneity that we observe between patients, and so we have opened our program in January 2021, and now we are almost full because we have a capacity of 1 patient per week. Why? Because those patients, as you can see in the table, are extremely problematic to manage, and they stress the healthcare significantly because of the burden of disease. Just consider that only 7% of the patients were free from any VHL primary, and basically if you see one of these patients, the chance that you will have to perform some kind of active treatment is more than 50%. Another very interesting observation, since we have the option to have all these services in-house in the institution, we have a close collaboration with our geneticist and with the genetic counselor, and one of the most intriguing line of research is to try to better decipher the relationship between the germline pathogenic variant and the clinical phenotype. Again, because you can have a 60 years old gentleman without basically no significant disease, and very young patients which are instead badly affected. And surprisingly enough, we have stratified the clinical features of those patients according to the type of mutation, distinguishing missense mutations relative to patients with a complete deletion, and patients with the missense mutation had a higher burden of disease, which is kind of strange because it tells us that patients in which the protein is lacking at all fare better than those that can have a kind of misfolded or a still partially functioning VHL protein. That in a way tells us that even if the transmission pattern of this disease is autosomic dominant, the clinical burden for the patient is way, way more complex. Next step, in case of a patient that we have to drop from the surveillance program because of an active indication for active treatment, what to do? This is the first patient that we had to treat that is, as you can see, extremely problematic. It's a 52-year-old man that didn't want to follow surveillance program very, very precisely, and so that was the scenario that we were facing. In transparent, you have the renal parenchyma, which is basically 0 on the left side. This kidney is silent on the renal scan. In purple, multiple renal cysts that were benign, and then the orange one instead are primaries that we know that are clear cell renal cell carcinoma. Both kidneys were previously heavily treated owing to renal cell carcinoma, and this is the 3D reconstruction system that we use for sporadic renal cancer to plan our surgery. In this case, the plan was was way more complex, but we decided to perform a radical nephrectomy on the left kidney because, again, it was not functioning, and to try to be as conservative as possible on the right one. So this is the left radical nephrectomy, as you can see. And we were working in a close contact with the engineers who developed the models with us, navigating the model together with us in the operating theater. This is the section of the left renal hilum, and then the completion of the left radical nephrectomy. It is important that this kind of approach is very useful for the multidisciplinary management of this disease, because also for the anatomy pathologist was key to this kind of map to understand basically what they were observing and grading. So on the right side, this is the preparation of the right kidney, and again here the plan was to mark and count each specific lesion. There were 10 in total. After that, we had to clear the kidney from all the cysts to get the most accurate access to the kidney, and I'm happy that our interventional radiologists are here with us because they did an incredible job, as you can see. We were basically targeting each lesion one by one with a local tumor ablation that in this case, in this peculiar setting, is not a percutaneous maneuver, but is performed directly on the kidney in the surgical field together with us in the OR. So our strategy was to be, again, to save as much nephrons as possible. We treated all the lesions that were the most complex with the local tumor ablation, whereas those that were the most endophytic and, let's say, easier to enucleate, as you can see, were treated by means of partial nephrectomy. Again, the ultimate goal was to try to avoid dialysis for this man, so this kidney is not clamped, and those resections were performed by keeping the perfusion, let's say, of the kidney, and with a very, with the close resection margins to the tumor, as, let's say, as close and as aggressive as possible. So the completion of this surgery, again, is the same that we performed for sporadic cancer with the reconstruction of the vessels and the closure of the calyces on the resection bed. So clearly this patient was prepared for dialysis, but luckily enough, despite the expected spike in postoperative creatinine up to 6, the patient always had a urinary output that was decent, more than 100 cc per hour. So the advice from our nephrology was to wait and not perform upfront dialysis. And luckily enough, on postoperative day 15, serum creatinine was 3.4, starting from a baseline of 2.4. So clearly, we gathered the clinical outcome of those data, but I would say the most intriguing part and the most intriguing opportunity that we have in dealing with this disease is what is asking ourselves what is the best way to treat those patients, because for ourselves as surgeons, we do not want to perform this case, and we are convinced that the way forward is to work together and to identify systemic agents that can effectively treat those patients. The landscape and the offer for those patients has been dramatically changed 1 year ago by this pivotal phase 2 trial testing an inhibitor of F2 alpha. The major issue that we have is, of course, that, as you know, this drug is not approved in Europe, and the evidence that we have is very, let's say, initial in this regards, because there are very strict inclusion criteria for these studies. And let's see this issue from the perspective of our clinic. If we try to test how many of our patients would fit into the inclusion criteria of this trial, it was only 23%. And the reasons for the specific exclusion are listed in this table. That is one of our clinical study that is submitted to the upcoming conferences of next year, American and European Urological Association. What's the next step of our approach then? We save every single cell stemming from those patients, and we have developed this protocol of a very thorough translational analysis in which we examine the clinical features of each individual primary, and plus we have performed in this specific patient a single-cell RNA sequencing of 5 individual primaries with a specific approach that we saw in the previous presentation, with a special attention, let's say, for the intertumoral and intratumoral heterogeneity. And I'm happy to share the first results of this investigation, in which we, of course, have investigated the expression. Each color here corresponds to a different primary. The purple one instead is the normal tissue, in which we have investigated the expression of F1 alpha and F2 alpha cluster genes. Why that? The idea, of course, is what happens if I treat these patients with such a drug? Would I expect a consistent response among different primaries or not? Which, of course, is critical. But the beauty of this approach, as you are familiar with, is that you can basically investigate whatever, you can query whatever marker of of systemic agents that you can. And for example, this is also the expression of markers of response to immune checkpoint inhibitors, which again was consistent among the 5 primaries that we have investigated. So I want to close my presentation with just a glimpse of what we will be working on in the next months. On the left, this is the picture of the first patient-derived organoid that we have cultured from one clear cell renal cell carcinoma. Plus, we want to replicate the same approach that we have so far established for renal cancer only to extrarenal primaries, which is going to be basically the focus of our investigation in the next month. This is the specimen resulting of one of our patients treated with duodenocephalopancreasectomy owing to this neuroendocrine tumor that is currently under sequencing now. Thank you very much.
Excellent talk. So we have time just for one question, please.
So I applaud, first of all, your institution developing and becoming a VHL Alliance institution. I reviewed the application when it was sent to the Alliance, and I think it was just critical for Europe to sort of develop this, and I applaud, again, that you're the initiator to do this, because I think it's a critical need which is unmet right now. The question I have for you is belzutifan. You know, the real-world experience with this agent is a little challenging. No one really knows how to use it, which patients. Clearly, I think the Peloton study was innovative and gave us some thought, but I still think we're challenged to understand which patient population benefits best, when do we initiate it based on the, obviously, heterogeneity of the manifestations in which patients present. And sort of I reached out to the company. I think a real-world experience to understand this, I think, is critical, and I think maybe there's an opportunity among VHL Alliance institutions to do this and maybe really give us a better understanding how clinicians, how we apply this in clinical practice. Would love to get your thoughts on this.
I think this is a great point. The unique opportunity of this disease is that it's, to me, is a very peculiar setting in which we are allowed to test and to understand the effect of systemic agents on the primary, which is very unique in oncology, I think. And this is the reason why we don't know the answer to your question and your point, but I think the answer should stem from a common effort of surgeons and oncologists, because the data that we have so far the main issue with that, to me, is that we are relying on clinical response assessed at MRI. I would like to know how many of these tumors have pathologic response. I would like to know the markers of non-response in the primaries that are not responding to the drug. And I think the only way to do that is to investigate this kind of drugs, belzutifan or others, in studies of pre-surgical therapy. Thank you very much.
Congratulations to you, Alessandro. You are a very committed, dedicated, and passionate investigator. And congratulations to Andrea and the Salogna and all the URI team. A fantastic work, huge work, is in a very, very difficult disease. So compliments.
Thanks a lot. Thanks a lot again. This would not be possible without the support of our oncology team. And I don't want to scoop what they will tell us about VHL on their side in the next session. Thank you.
So thank you very much again to you all. This has been, at least to us, a fantastic session. And on behalf also of my co-chairman, Professor De Cobelli, we would like to thank you again for all your fantastic talks. And I think now we are ready for the next session. Thank you.
So let's open the session on clinical trials. This is really well suited because it would be instrumental for us for the subsequent session, which is dedicated to the opening the doors to the multidisciplinary collaboration with other groups worldwide. So let's start first with Giorgio Gandaglia, who will provide us with an overview of the ongoing clinical trials in prostate cancer. Please, Giorgio.
So good morning, and thank you for this kind invitation. I'd like to thank Professor Necchi for inviting me here today to describe the ongoing clinical trials in the field of prostate cancer. And actually, it will be a journey starting from the diagnosis to the latest stage of the disease, such as castration-resistant prostate cancer. We have approximately 20 trials, starting again from diagnosis to castration-resistant stages of the disease, and we will focus on the main trials which will be discussed, and we will have a look at the study design. This is an issue which has been already discussed today, and it's the role of PET-CT in the diagnosis of prostate cancer. And actually, this trial has been recently funded by the Italian Ministry of Health, and it's aimed at evaluating the role of a fully hybrid PET-MRI system using PSMA to identify patients at the pre-biopsy stage who should be considered for a prostate biopsy. So patients with a suspicion of prostate cancer who should receive a prostate biopsy, and these patients will receive a fully hybrid PET-MRI, and the primary endpoint of the study is the predictive value of this approach for the diagnosis of clinically significant prostate cancer and for the reduction in the detection of clinically insignificant disease and the number of biopsies spared. And this study is waiting for EC approval, and it has been just funded. It will include 167 patients. Another interesting ongoing study is on the role of MRI-targeted biopsy and systematic biopsy in patients with a suspicion of prostate cancer, and this study has the aim to identify the optimal biopsy scheme for men with a positive MRI before prostate cancer diagnosis. These are the initial results of the study, and we can see that the majority of patients actually have a diagnosis in the first MRI-targeted core, and when we look at the additional role of concomitant systematic biopsies, we can see that a number of 12 cores should be considered in order to diagnose correctly up to 90% of clinically significant diseases. We have an interest also in other imaging modalities, such as microultrasound, and this is the US MIRROR trial. It is a prospective single-arm study aimed to assess the role of microultrasound for the diagnosis of clinically significant disease. This study currently enrolled more than 100 patients, and these are the results. You can see that multiparametric MRI, which is compared to microultrasound in patients with before prostate biopsy, so patients who are candidates for a prostate biopsy, well, in this setting, a multiparametric MRI has a higher sensitivity and specificity compared to microultrasound, but still we have some patients where a clinically significant disease would have been missed by MRI alone. So it can still play a role in a subset of patients. This is a study which has been extensively discussed by Dr. Brambilla, and it is on the role of artificial intelligence in prostate cancer, and we plan to start with patient enrollment in December. And finally, for the diagnosis stage, we have a study aimed at assessing the role of novel biomarkers. This is a commercially available biomarker, the SELECT-MDX, and the aim of our study is to assess the role of SELECT-MDX in men with a negative or a suspicious or let's say, equivocal MRI defined as a PARATS score equal or lower than 3. These men will receive a SELECT-MDX test and then will be considered for a systematic biopsy approach. And we will assess in a total of 314 patients the sensitivity, specificity, and accuracy of SELECT-MDX for the identification of clinically significant prostate cancer. When we move to neoadjuvant therapies, we have been involved in the Proteus trial. This trial is aimed at assessing the role of ADT plus apalutamide versus ADT alone in a perioperative setting, 6 months ADT before surgery plus 6 months of ADT after surgery in high-risk prostate cancer patients. We enrolled 10 patients. The total study population is expected to be more than 2,000 patients, and the study completion date is in April 2027. And this is a spontaneous trial available at our center, where actually we designed a trial aimed at assessing the role of pembrolizumab in the neoadjuvant setting for high-risk prostate cancer patients. We know the role of immunotherapy in several diseases, in several urological malignancies. Data in prostate cancer patients are still lacking, and the aim of our study, this is a prospective single-arm phase 2 study, is to assess the role of pembrolizumab in the reduction of the rate of lymph node invasion in prostate cancer patients. And this study has been approved by our ethical committee, and we are waiting for the final approval by the Italian regulatory agency. Moving to the staging and restaging setting, we have been very active in the field of PSMA. We were able to develop a novel tracer for PSMA radioguided surgery, and this is an ongoing study aimed at enrolling approximately 100 patients. We currently enrolled 30 patients, and the study is based on the concept that the use of an intraoperative gamma probe in patients who were injected with 99M technetium PSMA imaging and surgery the day before surgery could allow us to correctly identify the exact site of metastasis in the lymph nodes and to identify additional metastatic sites as compared to an anatomically defined pelvic lymph node dissection. You can see that the specificity of the tracer is extremely high at the per-patient analysis, but still, when we look at the sensitivity, we are struggling with a low sensitivity, and this is probably related to the spatial resolution of the probe, which is better compared to preoperative PET MRI or PET-CT, but still can miss micrometastatic disease. We have also available trials comparing the accuracy of PSMA and bombazine for the detection of metastases in the primary and recurrent prostate cancer stages, and these studies are currently enrolling high-risk patients, 50 high-risk patients in the primary setting, and 60 patients with BCR in the recurrent setting. Moving to salvage therapies, we are a center participating to the Primordium study, which is a randomized phase 3 controlled multicenter open-label trial enrolling patients with PSMA PET positive recurrence after radical prostatectomy. And these patients are men with a high-risk BCR as defined by the EAU guidelines. Patients are randomized to radiotherapy plus ADT versus radiotherapy plus ADT plus apalutamide, and the treatment phase is a 6-month treatment phase, and you can see that the follow-up is based on repeated PSMA PET at 6, 12 months, and at the time of disease progression based on PSA values. And we already enrolled 5 patients in this study. When we move to the metastatic hormone-sensitive setting, the Amplitude trial is currently recruiting patients at our center. This is a large phase 3 randomized placebo-controlled double-blind study, and the aim is to enroll a total of 788 patients with metastatic castration-sensitive prostate cancer based on conventional imaging alone. All these patients and all patients included in the trial are patients with germline or somatic homologous recombination repair gene mutated metastatic castration-sensitive disease. And patients will be randomized to niraparib, which is an orally active PARP inhibitor, or abiraterone alone. So niraparib plus abiraterone versus abiraterone alone. And the primary endpoint is progression-free survival. And finally, we move to the non-metastatic castration-resistant setting, and here we have an observational study which aims to find out in the real-world setting whether darolutamide is a safe and effective option for patients with prostate cancer, and this is again in the M0 castration-resistant prostate cancer setting. And the primary endpoint is represented by treatment-emergent adverse events. And this study aims to enroll approximately 1,000 patients. The first intermediate analysis have been published and released at the GU ASCO 22, where the safety and tolerability profile is consistent with what reported by phase 3 randomized trials, and in particular the ARMIS trial. When talking about metastatic castration-resistant prostate cancer patients, we have an ongoing phase 3 multicenter randomized open-label trial, which is the CONTACT-02 trial, and this trial aims to evaluate the efficacy of cabozantinib in combination with atezolizumab versus novel hormonal therapies, and actually this study is focused on patients previously treated with novel hormonal therapies such as ABI, apalutamide, darolutamide, or enzalutamide, who have progressed on that hormonal treatment. And the previous docetaxel is allowed. The endpoints are oncological endpoints such as progression-free survival, overall survival, and the expected sample size is approximately 580 patients. The Keynote 365 study is a study aimed at assessing the safety and efficacy of the administration of pembrolizumab combination in men with metastatic castration-resistant prostate cancer. This is a phase 1b/2 study, and the primary endpoint is the decrease of 50% in PSA values, adverse events, and an objective response. You can see that the study design is pretty complex. We have approximately 9 different cohorts, and the inclusion in each cohort is based on the previous treatment received by the single patient. We are currently recruiting patients for this prospective study. And finally, we move to the Tropion trial, which is a trial aimed at assessing the safety. This is a phase 2 trial which wants to assess the safety in terms of adverse events and the objective response rate of an antibody drug conjugated anti-TROP2 IgG1 monoclonal antibody conjugated with a tumor-selective cleavable drug linker. And here, patients with prostate cancer are included in the sub-study cohort 3, and they are divided into groups according to combination therapy. 40 patients in group A, plus other 30 patients in group B. The STELLAR-1 trial is aimed at assessing a multi-target inhibitor of receptor tyrosine kinase, and this is a phase 1 open-label multicenter trial, and patients with prostate cancer, metastatic castration-resistant prostate cancer are included in this study, and you can see that the primary endpoints are mainly the same as compared to previous trials. And finally, we have been involved also in the PETRA trial, which aims at assessing the safety of a novel PARP inhibitor. Again, here we have 5 different models, and prostate cancer patients are represent approximately 16% of patients included in this trial, and the primary endpoint is represented by adverse events. So this final slide is an overview of all available trials at our institution in the field of prostate cancer, and with this I would like to thank you for your attention.
Thank you, Giorgio. For the sake of time, we can leave the discussion at the end. You can stay if you like on the stage. And let's jump to the bladder cancer arena. Daniele Raggi will provide us with the overview of the ongoing trials. Daniele has, since the very beginning, the courage and then the patience to follow me since the initial steps. So please, Daniele, are you still alive and then well? So you can.
Thank you.
You can proceed.
Thank you, Andrea, for this kind of invitation. I think I have to run because we have many kind of clinical trials in this setting. I'm going to show you an overview on the ongoing clinical trials in bladder cancer. These are my disclosures. So the agenda, let's start with non-muscle invasive bladder cancer. So more advanced disease, muscle invasive disease, and of course in the late, the metastatic setting. Let's start with BCG unresponsive disease. This is the oncologic story so far. Let's start from the early 90s with BCG approval, and then going through the late 90s with Varubicin, the first FDA-approved intravesical drug for BCG unresponsive. And then we finally arrived to 2020 with approval of pembrolizumab. That is the first new agent approved for CIS, BCG unresponsive disease, followed by the data of the Keynote 57 trials. So in the last 2 years, we have now 3 new compounds, FDA granted for the approval, the oportuzumab, nadofaragene, and obviously the last interleukin-15 superagonist, NAI. This is the organ-sparing landscape in 2022, this year. This is an organ-sparing approach to the BCG unresponsive disease. As I show you in this box, in the last 2 years, we have an increase of the interest of the publication on GU, for example, GU, ASCO, or ASCO annual meeting of new compounds. And this is very, very important for us. Let's start with our clinical trials. This is the Keynote 676 cohort A, cohort A, so in BCG unresponsive disease, high-risk disease, T1, high-grade TA, with or without CIS. There is stratification by the PD-L1 expression and the disease history in terms of mounts of relapse. So we have randomization 1-to-1 to receive the standard of care control arm, so the BCG rechallenge, substantially, versus the BCG plus pembrolizumab, with the primary endpoint, the complete response rate. This is the cohort B of the same study. This is for BCG naive disease. So we have a very high risk disease. Again, T1, A-grade TA, with or without CIS, stratification by PD-L1 expression, and the presence or absence of CIS. Once again, we have the BCG control arm versus the pembrolizumab every 6 weeks with full BCG maintenance course or reduced maintenance course of BCG. In this case, the primary endpoint is the event-free survival. Let's go to another clinical trials, the Sunrise-1 clinical trials. This is a combination approach of IO and a new device, the TAR-200. This is an intravesical gemcitabine device, a sort of pretzel. So we have, in this case, only patient with CIS BCG unresponsive, with or without papillary disease. We have 3 cohorts, the one cohort with sertralimab alone, immunotherapy, TAR-200 alone, or the combination of both treatments. Also in this case, we have the primary endpoint, complete response rate. As you know, we have a strong rationale for targeting FGFR mutation, especially in non-muscle invasive disease, because we have a positivity of the mutation or fusion genes in 40 to 70% of non-muscle invasive disease. And this is the background for the TOR2 study in selected patient harboring mutation or fusion of FGFR genes. And we have 3 cohorts in this case. The first cohort with papillary disease, BCG unresponsive disease, randomized 2-to-1 to receive erdafitinib orally, a TKI and a selective inhibitors, versus investigator choice intravesical chemotherapy. In this case, we have the primary endpoint, relapse-free survival. The second cohort is for CIS disease with or without papillary disease. We have the administration with only one arm of erdafitinib with a primary endpoint complete response at 6 months. And in the third cohort, we have the BCG naive disease, intermediate risk. Again, erdafitinib alone with primary endpoint complete response at 3 months. Let's move to the more advanced disease, muscle invasive disease. This is the background. We know that cisplatin-based chemo is the standard of care again. We know that adjuvant nivolumab improves disease-free survival in very high-risk disease. Neoadjuvant IO is an interesting approach, and we need for predictive biomarker. This is the algorithm of treatment. We have patient radical cystectomy candidate or candidate to have a bladder preservation. So in radical cystectomy candidate patient, we have to administer neoadjuvant chemo if cisplatin eligible, followed by radical cystectomy, and then adjuvant nivolumab only in selected very high-risk patients. This is our clinical trials in Raffaele Hospital for cis-eligible patients, and we have other 3 clinical trials in the cis-ineligible patient candidate to radical cystectomy. This is one, let's start with ongoing sponsored clinical trials. This is the Optimus phase 2 trial for cisplatin ineligible or refusal patients stratified by PD-L1 expression, only one arm of treatment with retifanlimab, radical cystectomy, and then observation only. This is very, very interesting, the primary endpoint of this study that is a biological endpoint with represented by the change from baseline in CD8 positive lymphocyte within the resected tumors. This is the Keynote 905 phase 3 clinical trial against cisplatin ineligible patient. We have one arm, control arm, direct to cystectomy, and then observation only. The pembro arm, so perioperative treatment with pembrolizumab, and the combination arm, perioperative with pembro plus enfortumab vedotin, anti-nectin-4. This is our other sponsorized clinical trials, the Keynote B15 phase 3 trial in cisplatin eligible patients. We have the randomization to the standard of care treatment, so chemo, gemcitabine plus cisplatin, versus pembro plus enfortumab, radical cystectomy, and then adjuvant treatment only in the experimental arm. And this is the Volga trial, phase 3 trial. Again, in cisplatin in eligible patients, we have a triplet combination with durva plus treme plus enfortumab vedotin with an adjuvant treatment with durva and treme after radical cystectomy, an arm with durva plus enfortumab and then durva plus the surgery, or the control arm without treatment. In these two studies, the primary endpoint are the PCR and the event-free survival. Let's move to our academic trial. This is the SURE-01 and SURE-02 phase 2 clinical trials. In the SURE-01 trials, we have the administration of 4 cycles of sacituzumab govitecan before radical cystectomy and then management per standard of care. Or in the SURE-02, we have the combination of sacituzumab govitecan plus pembrolizumab, then radical cystectomy and 12 months of adjuvant pembro. The primary endpoint of this study is the pathologic complete response rate. Let's go to the third academic clinical trials, the NUR combo trials. This is a combination study of chemo plus IO. We have an assessment of the disease by CT scan, PET FDG, and MRI, multiparametric MRI of the bladder, before and after the treatment. We have the administration of nivolumab plus nab-paclitaxel, so radical cystectomy, and then adjuvant treatment up to 13 cycles with nivolumab. Again, once again, pathologic complete response is the primary endpoint. So today I'm very proud to can show you the first interim and safety analysis of this trial. This is the cohort 1 of the clinical trial. Only 13 patients with median age of 63. 61% of patients had only T2 disease, and 46% of patients expressed pure urothelial cancer at the TURBT. This is the efficacy data only in 11 patients. We have a complete response rate of 27.3% with a downstage to non-muscle invasive disease in 72.7 patients. This is the safety analysis of 13 patients. We have all the patients underwent to radical cystectomy. This is very, very important because of the safety of the combination in terms of surgery. We have 2 discontinuation of nivolumab only in the adjuvant setting due to adverse events, and 1 nab-paclitaxel on the cycle 4 in the neoadjuvant treatment. We had 1 death, unfortunately, after the cystectomy, but not related to the experimental drug combination. This is the adverse events that we see in these 13 patients. Let's move to the adjuvant setting. In Italy, we don't have the opportunity to give nivolumab, so we have the INVIGOR 11 clinical trial. This is a well-selected population, very high risk population that underwent to serial ctDNA testing. When positive, we randomized 2-to-1 to receive adjuvant atezolizumab versus placebo with the primary endpoint disease-free survival. Let's close with the 3-modality approach, so conservative approach. This is the Keynote 992 phase 3 trial. There is, after maximal TURBT, the treatment with concurrent chemotherapy plus radiotherapy with or without pembrolizumab every 6 weeks with maintenance after the end of radiotherapy. And the Sunrise 2 phase 3 trial that had the control arm represented by chemoradio, and sertralimab plus TAR-200 has experimental arm. Let's close my presentation with the metastatic disease. This is the backbone, obviously. Cisplatin or carboplatin-based chemo is the standard of care. Avelumab maintenance in responders only show very, very interesting and promising data on improvement of overall survival. A minority of patients, unfortunately, received the second-line treatment, and we need to improve survival since the first-line setting. This is the current paradigm after ASCO and ASCO of this year, with the possibility to increase our opportunities. Sacituzumab govitecan, for example, added to checkpoint inhibitors, trastuzumab deruxtecan, and enfortumab vedotin plus pembro in first line in cis-eligible or ineligible patients. This is our studies in first-line metastatic setting, the EV302 studies. These are patients with metastatic disease, chemo and checkpoint naive patients, randomized to receive chemo, so gemcitabine plus cis or carboplatin versus the combination enfortumab plus pembrolizumab with a dual co-primary endpoint, progression-free survival and overall survival. This is the TROPiCS-04 clinical trials. This is for more advanced disease. Progression, patient progressed after cisplatin or carboplatin-based chemo and checkpoint inhibitor. We have randomization to investigator's choice chemotherapy versus sacituzumab govitecan with the primary endpoint, once again, the overall survival. This is the TOR study, confirmative study, phase 3 study of patient with metastatic refractory disease with FGFR aberrations, 2 cohorts, 1 cohort for patient treated with prior PD-L1 inhibitors, so erdafitinib versus chemotherapy, the standard of care, or for the cohort 2, erdafitinib versus pembrolizumab, so second line of treatment. Primary endpoint is the overall survival. Let's close with the last study. This is an industry partnership for early drug development. This is a phase 1-2 trials of BT8009. This is an antibody drug conjugate against Nectin-4. It's similar to enfortumab vedotin. This is the study. This is the phase 1-2 study of safety, pharmacokinetics, and the preliminary results. We don't have the part A, that is the escalation dose of the phase 1, but we have here in hospital the part B and C, so the expansion cohort and the renal insufficiency cohort. So, to summarize, these are the currently enrolling phase 1, 2, and 3 trials in urothelial cancer. I think that for our patient, this is a very, very good opportunity from non-muscle invasive disease to heavy pre-treated disease. Thank you for your attention.
Thank you, Daniele. You can stay on the stage, and then Laura Marandino will present the overview of the ongoing trials in renal cell cancer. So please, Laura, the floor is yours.
Thank you. So let's switch now to trials enrolling patients with renal cell carcinoma at our institution. These are my disclosures. So you can see here, this slide is quite empty, and this was just the situation was just 6 months ago. Luckily, the situation really changed during this last period, thanks to the hard work of some people. So let's start with no metastatic renal cell carcinoma and N1-NED disease. So as Dr. Capitani already showed, the KEYNOTE-564 trial established a new standard of care, so in reality the first standard of care in Europe for the adjuvant setting of high-risk renal cell carcinoma. And then the drug was approved by FDA, by EMA. However, the drug is not reimbursed here in Italy. We also know that the setting is quite challenging for perioperative strategies, and in fact, we heard about these 3 negative trials of immunotherapy at ESMO 2022. As I said, we don't have the opportunity to administer pembrolizumab as adjuvant treatment for renal cell carcinoma patients. However, we have the opportunity to offer to our patients here the LIGHTSPARK-022 trials. So this is a randomized phase 3 trials of belzutifan plus pembrolizumab versus pembrolizumab for adjuvant risk renal cell carcinoma. So basically, these are the main criteria. So this trial includes patients with intermediate high risk, which mean PT2, grade 4 or sarcomatoid, PT3, or high-risk disease, which means PT4 and plus disease, and also the population of M1 net disease is included. So those patients who had a radical resection of metastasis at the time of nephrectomy or within 2 years from nephrectomy. And only 12 weeks are allowed between surgery and randomization. So this is very important for the urologists here because we need to discuss very early the cases of these patients. And as I said, the control arm here is pembrolizumab, and this is the only study which has pembrolizumab as an active control arm. And the experimental arm is belzutifan plus pembrolizumab. So belzutifan is a second-generation small molecule If2 alpha inhibitor, which means that it wants to target the angiogenesis at its most proximal source, which is different from other TK inhibitors such as cabozantinib or axitinib. As you can see here, they act at a peripheral site. And we know that belzutifan show a very interesting response rate, both in von Hippel-Lindau syndrome as well in very pretreated patients with advanced renal cell carcinoma. So the primary endpoint of this trial is disease-free survival, and while overall survival and patient-reported outcomes are secondary endpoints. Let's switch to first-line metastatic renal cell carcinoma. We know that now, basically, all patients receive IO combination treatment, so double therapy based on IO-TKI or IO-IO. The combination of oxipembro, cabo-nivo, and nivolumab, ipilimumab are reimbursed here in Italy, so are option for our patients. This trial really showed very interesting results in terms of overall survival, objective response rates, and also duration of response. However, there are still patients who have a primary resistance or develop an acquired resistance. So, of course, there is the need to do more for all patients. There are trials that now are trying the strategy of just adding drugs, so triple therapy. And this is one of the trials, the LIGHTSPARK-012 trial. So this is a first-line trial for clear cell carcinoma. And the control arm here is pembrolizumab lenvatinib, which is the combination which has for the higher objective response rate so far in renal cell carcinoma. And the first experimental arm wants to test an intensified immunotherapy strategy, so by adding a CTLA-4 inhibitor to pembrolizumab and lenvatinib, and in this case, a co-formulation of quavonlimab, the CTLA-4 inhibitor, and pembrolizumab is used. With the second experimental arm, they want to test if an intensification of the anti-angiogenic strategy is successful by adding belzutifan to pembrolizumab plus lenvatinib. In this case, progression-free survival and overall survival are the primary endpoints, and the true triplet arms are compared to the doublet arm. Let's switch now to second and further lines of treatment. Of course, now the biological and clinical nature of our second and third line treatment patients is changing, because basically before those patients were patients only treated with mono TKI therapy, but now are basically patients who have progressed to a combination strategy. So we can hypothesize that these are different patients from we are used for before. So we need, of course, trial in the setting. We can offer our patient the LIGHTSPARK-011 trial. This is a randomized phase 3 study which compare in second and third line treatment the combination of belzutifan, lenvatinib versus cabozantinib. In this case, only maximum 2 prior line of treatment are allowed, and the last prior treatment should be an anti-PD-1 or PD-L1 therapy. This is the experimental arm, so the combination of lenvatinib plus belzutifan. Why this combination? Lenvatinib is a tyrosine kinase inhibitor, which against the VEGF-R receptor, but also other receptors such as VEGF-R. We already spoken about belzutifan, so the aim is to inhibit multiple oncogenic pathways as well as to enhance VEGF inhibition. Primary endpoint of this trial are both progression-free survival and overall survival. Let's switch to non-clear cell carcinoma, starting with papillary renal cell carcinoma. This is the most common subtype of non-clear cell of renal cell carcinoma. However, still this is a rare disease, and we know that it's even harder to produce robust evidence in this setting. Of course, clinical trials are required in the disease, and I think that is very interesting of papillary renal cell carcinoma is that the percentage of MET-driven tumor is high. It's even higher in the papillary type 1, and of course, this could be used as a potential target for treatment. And we have these biomarker-driven trials for advanced first-line treatment for patients with papillary renal cell carcinoma. So in this case, there are a two-part screening because only patients with MET-positive tumor are selected for the trials. The selection is done by next-generation sequencing, and no co-occurring fumarate trace mutation should be detected. There are 3 arms in this case. So the control arm is sunitinib, that is even reimbursed in our country for the setting. And the first experimental arm is the combination of savolitinib plus durvalumab. Savolitinib is an oral potent selective MET tyrosine kinase inhibitor. This drug showed in the SAWAR study interesting results in patients with MET-driven papillary renal cell carcinoma. However, the trial was early closed, so it was not possible to derive firm conclusion. The drug in combination with durvalumab show interesting results as well in the advanced setting in patients with MET-driven papillary renal cell carcinoma in the Calypso study. There is another arm here, as you can see, the durvalumab monotherapy. In this case, a crossover is allowed only for this arm in case of progression of disease. The primary endpoint, in any case, is focused on the comparison of durvalumab savolitinib versus sunitinib. Let's finish with the last trial. This is a phase 1 trial, STELLAR 01. Dr. Gandaglia already talked a little bit about this. XL092 is a novel multi-target inhibitor of receptor tyrosine kinase, such as MET, VEGF-R, but also targets pathway associated with tumor immune suppression. Another thing that is interesting is relatively short of life, which is, of course, interesting in terms of management of the drug. Dose escalation results have already been presented, and the recommended phase 2 dose is 100 milligram. And now here at Raffaele, we have the opportunity to include patients in the expansion course, so both the monotherapy strategy and the combination with atezolizumab. So both patients with clear cell renal cell carcinoma can enter the trial. A patient treated with a maximum of 3 prior systemic treatments. This is true also for non-clear cell carcinoma. And for this patient, also the expansion cohort with immunotherapy exists. This is just to show that in the last 6 months, the opportunities for our patient to really increase, both in clear cell renal cell carcinoma and non-clear cell. There is, of course, much work to do. And with that, I want to really thank people who are not talking today, but who are really essential for running all these trials. So our research nurse, Greta, and our 3 study coordinators, Rossella, Daniele, and Tiziana. Thank you.
Great talk, Laura. And finally, we have Tiago Padua from Brazil. He is the grant recipient of the ESMO Fellowship, the second year, and we are proud to have him on board on our group. And he will present us the overview of the ongoing trials in rare tumors, penile and testis cancer. So please, Tiago.
Hi, everyone. Thanks, Andrea, for inviting me. I'm really honored to be here as a speaker today. And I have been working in San Raffaele for the last year as a ESMO fellow. It has been a very enriched experience. And I will talk a little bit about the ongoing clinical trials in hairy GU tumors, so adrenal tumors, testicular cancer, and penile cancer. We know we have so many challenges to treat this kind of tumors, lack of guidelines, slow accrue recruitment, and also limited funding opportunities. And international and multi-center collaboration is essential to improve patient care. In the Global Society of Hairy GU Tumors, led by Philip and Andrea, is a case of success in stimulating medical education, creating guidelines, and stimulating clinical research in this area. Now moving to the clinical trials. The first trial is in adrenal tumors. It's a phase 2 study to evaluate the efficacy and safety of bezuclastinib monotherapy in patients with advanced pheochromocytoma, paraganglioma, or PNET tumor. Bezuclastinib, as Laura just mentioned, it's already approved in US for the treatment of RCC associated with a VHL mutation. And if you look to PPGL tumors, we know this hypoxia is also one of the major drivers of tumorigenesis. And we can find around 70% of VHL alterations in sporadic pheochromocytoma. And then there's a rationale to to test this drug in this kind of tumor. This is a phase 2 trial with 2 cohorts. The cohort 1 is with pheochromocytoma and paraganglioma. In the cohort 2 with PNET tumors. Each cohort with 70 patients. They will be treated with bezuclastinib, 120 milligrams per day until toxicity or progress of disease. And the primary endpoint is response rates, and as secondary endpoint to have disease duration of response, PFS, overall survival, and safety. The main inclusion criteria: patients higher than 12 years old, patients should have locally advanced or metastatic disease, not amenable for surgery or curative treatment. Patients can be treated in first line or later lines, but in first line, patients should be not candidates or refuse systemic chemotherapy. We have another ongoing clinical trials in adrenal tumors. I would like to share this website, adrenalmass.org. It's a resource from the Global Society of GU Hairy Tumors, where you can find a lot of information about adrenal tumors, including other ongoing clinical trials. Moving to penile cancer, in locally advanced setting, patients with lymph node disease. We know that surgery, chemotherapy, and radiotherapy are options of treatment, but we don't know, it's not clear how to sequence, how to integrate all these strategies. And you have a very important trial, the IMPACT trial. It's an international penile advanced cancer trial. It's a phase 3 trial. Actually, it's the first phase 3 trial in lymph node positive penile cancer. And it has a very interesting design. It's a Bayesian design. So patients with penile cancer, N1 to N3, M0, this design allows 2 sequential randomization. The first randomization will test the neoadjuvant treatment, so it's the IMPACT neoadjuvant. Patients will be randomized 1 to 1 to 1 to no neoadjuvant treatment, Arm B, TIP as neoadjuvant chemotherapy, or Arm C, chemoradiotherapy as neoadjuvant treatment, followed by inguinal lymph node dissection. And based on the pathological report, patients will be classified in low risk of recurrence or high risk of recurrence. Patients with high risk of recurrence will be randomized again. It's the second randomization, IMPACT pelvic, to prophylactic pelvic lymph node dissection or just surveillance. And it's important to note that the patients who not receiving neoadjuvant treatment, they'll have the chance to receive adjuvant chemoradiotherapy. This will be important to understand the role of neoadjuvant or adjuvant treatment. The primary endpoint is overall survival, and you have as secondary endpoints GFS, safety, and rate of surgical complications. The last report in ASCO GU this year, we have already almost 70 patients in the first randomization and 10 patients in the second randomization. So we need to continue recruiting patients for this study because we will answer a lot of questions in the treatment of penile cancer. Moving to metastatic disease, we know it's a very poor prognosis setting. The standard of care is platinum-based chemotherapy. In the second line, chemotherapy is associated with low response rates, and you have a lot of clinical trials investigating monotherapy or no other new agents. Here is just an example of the ongoing clinical trials. We have clinical trials with immunotherapy in second or in first line combined with chemotherapy. And you have an important trial, the Orpheus trial, recruiting patients in Italy and Spain. Orpheus is a phase 2 study to evaluate the efficacy and safety of retifanlimab in advanced penile squamous cell carcinoma. So retifanlimab is an anti-PD-1, so it's an immunotherapy trial for patients with metastatic disease, penile cancer, recruiting patients in Spain and Italy in 13 sites. It's a single-arm phase 2 trial with 18 patients. The main inclusion criteria, patients with T4, NE3, or ME1 disease, treatment naive or after progression to first-line chemotherapy. Patients will be treated with retifanlimab every 4 weeks until toxicity or disease progression. And the primary endpoint is response rate, and for secondary objectives to have safety and overall survival. Now, the recruitment is closed. Probably they will have the results soon, the next conference. The estimated study completion date in the clinicaltrials.org is December now. So maybe next year we'll have the results presented in the next conference. And last, a very important trial in testicular cancer, the TIGER trial. It's a randomized trial of TIP versus TICE as initial salvage chemotherapy for patients with germ cell tumors. We know that around 20 to 30% of patients with advanced germ cell tumors will require salvage chemotherapy. And as options of treatment, you have conventional dose chemotherapy with VIP or TIP, or high-dose chemotherapy with sequential stem cell transplantation. And you have an important geographic variation around the globe. So, for example, in UK, it's preferred conventional dose chemotherapy. And if you look to Germany and Indiana and US, it's preferred high-dose chemotherapy for this kind of patients. So it's, we need the answer of this question. In TIGER trial, it's a very important trial. It's an international collaboration, including North America, Europe, and Australia, to answer this question. So around 420 patients will be randomized 1-to-1 to TIP or TICE, the other is high-dose chemotherapy. Patients will be stratified by prognosis, risk class, and continent, with the primary endpoint of overall survival. The main inclusion criteria, so seminoma or non-seminoma, patients with progressive disease at first-line chemotherapy. Patients must receive 3 to 6 cycles of platinum-based chemotherapy, and no more than 1 line of chemotherapy is allowed for in first line. And you have good news about this trial. Now in October last month, Feldman just published in Twitter that the recruitment was completed for this trial. It's a very important mark because it's a rare disease with a difficult recruitment. This is thanks a lot of investigators, some of them here. So congratulations to all of them who works in this trial, and show us that do clinical research in rare tumors is difficult, but it's not impossible. We can do that together. And with that, I finish, and thank you for your time.
Thank you, Tago. Outstanding talk. So we have time just for a couple of questions, and then we will close the session. Ashish, please.
So first off, I want to congratulate all of you on the number of clinical trials you have available for patients across the disciplines. It's very commendable, and it's really impressive to see that, and also summarized beautifully by everybody. So that's great. I have a comment and a question, and let me preface this by saying, as chair of SITC, Society of Immunotherapy for Cancer, and also the IBCG, and also I work closely with the FDA, one of the things that we've done over the years is improve the appropriate endpoints for clinical studies, right? When it comes to metastatic disease, and I'll speak specifically to bladder here, that's relatively easy. You have survival. But when it comes to non-muscle invasive bladder cancer, for example, the whole paradigm for Keynote 57 and all the other studies started from work that we did with the FDA where they allowed single-arm studies. So that's how in 2020, when I was at the FDA getting Pembro approved, it was on that single-arm paradigm. Moving to the neoadjuvant space, we had a workshop with the FDA a couple of years ago during COVID, and it was published last year. And the recommendation is to not use pathologic complete response rates as a surrogate endpoint for neoadjuvant studies because it doesn't correlate with outcomes, doesn't correlate with death rates, survival, anything of that nature. And I noticed that several of your studies does have pathologic complete response rates as your endpoint. Any thought to modifying those studies? That way you could potentially have these drugs, regimens, move into registration phases if you're successful.
Yeah, it's an outstanding question. Of course, it touches all the main points in the drug development and biomarker development in this disease. Very briefly, I could say that the path response endpoint is a very well-suited endpoint for doing research, for enriching trials with the biomarker data, for us as investigators to do in academic research, but it's not well-suited for the patient side. This is not the ideal biomarker for the patient interest. Of course, for the patient, we should look as every adjuvant or neoadjuvant trial to survival. Of course, I fully agree. The other point that I would like to add is that we are still far behind from the identification of safety endpoints and acceptable threshold of safety in these patients. Is it acceptable to lose one patient in this clinical setting? How many patients are we allowed to lose due to toxicity in this setting? Or which is the threshold of toxicity, of specific toxicity to accept in this clinical setting? These are all questions that are still unanswered. And I think that the consensus in this regard is highly required. Petros.
First of all, I want to echo what she said. This is impressive, and I want to congratulate all of you. This is not easy to do. The amount of infrastructure and resources is amazing, so congratulations. The question is relevant, Andrea, to what you're saying. You know, how much we have to do to incorporate more patient advocates in clinical trial designs. I know you and me were talking about this. How much we can collaborate or even across the Atlantic Ocean, right? How can we do more trials together? Any comments on those too for many of you, and congratulations.
Yeah, thank you, Petros. I think that the possibilities for collaboration are huge today, and we'll see in the next section how many possibilities there are currently for collaboration. And regarding the patient standpoint, I definitely think that it's time to have a patient advocate on board on every clinical trial that they will design. A patient advocate should be involved, should be on board as a board member of a clinical trial, because otherwise we lose the perspective of the patient, and we may be too much focused and concerned on our clinical side that is not always overlapping with the patient interest.
I don't mean to be redundant, but I'm blown away to see the comprehensiveness of your clinical trials. I think it shows your commitment, your dedication, and truthfully, as we all know, when patients come to our clinic, they're looking for hope, they're looking for innovation. So I think you're all doing exactly what our patients want and seek. And you know, Diego, I think I'm definitely touched with the exceptional work you, Laura, and obviously Andrea has been a leader for our society since its infancy. But I definitely think like things like adrenal cancer, like in your recent review, it really is depressing to see how the paradigm has not changed over recent years. And truthfully, as we've tried to do, is get more of a global representation. And I think, you know, some of the thoughts we've had obviously has been developing comprehensive international tumor registries of these patients, because parts of the world, as we all know, are underrepresented in how they care for this. And I think if we're going to improve the paradigm, particularly for whether that be variants of certain cancers or rare cancers, we need to integrate all of the worlds to do this and to learn from one another.
Yeah, thank you, Phil. We are all very proud of these guys. Thank you. So it's the level of glycemia is very low, so it's time definitely for lunch. We should be back if you agree on 2:30. So we'll keep 30 minutes delay, no problem. 2:30 we'll be here to restart. Thank you.
If we can all take a seat. So this part of the day will be extremely interesting as we are going to listen to top speakers from all over the world and telling us specific things that they are doing at their own place. And I'm delighted to introduce to you my good friend, Professor Clark from the UK, who will talk to us, the UK clinical trial machinery. I think it is very well described, the Stampede model. Please, Ned, thank you for being here.
Thank you, Francesco. And it's a great pleasure to be here. And the session after lunch is always the most difficult one, I think. So let's see if you can stay awake. I'm going to talk a little bit about the Stampede trial model, and I've been involved with Stampede for many years now. And what we have tried to do with Stampede is engage the UK's healthcare system to effectively work with the grain of what happens in the country, building with a novel trial design, Stampede, and also more recently engaging with large-scale data sets, such as from the National Prostate Cancer Audit. I'm the joint lead for this for England. And we collect information on between 40 and 50,000 new cases every year and have done since 2013, so we can match that with hospital episode statistics. And I'll talk a little bit about that in a minute or two. But first, let's go back. The rationale for the model of Stampede was to try to improve outcomes for prostate cancer. We had limited options, both for the M0 and for the M1 patients. And we had an idea for a flexible trial design, which largely came out of the MRC. Here's the gang of 6 that designed it, and Max Palmer, who's head of the MRC Clinical Trials Unit, and his colleague had this idea for a multi-arm, multi-stage trial. So you can see the group, that's Nick James, Malcolm Mason, and David Durnley, clinical oncologist, myself, Matt Sides, and Max. And now we have a team of about 40 working at the MRC, so it's a big outfit. Now the principle is this, that with a multi-arm, multi-stage trial, it was very different from a conventional phase 2, phase 3 type thing. Now this model, which you see on your right, usually takes about 15 years to yield a result, and there are some drugs which fail at this point. The MAMS trial was to set everything off at the same time and have a common control, and to have different phases of the trial, phase 1, 2, 3, and 4, and ultimately, when a drug dropped out because it was either too toxic or ineffective, then we could put another drug in. And you'll be familiar with the agents which we had. Not all the drug companies were able to give us their drugs. There were some drugs which we simply weren't able to access. And we went with what had evidence for efficacy in the clinic and or the lab. And these were our 5 with the standard of care. Now, the first thing I'm going to show you is a graph of how long it took us to get up to 140 centers, just about. And you can see that took about 5 years. The advantage of the MAMS trial is when one agent drops out and we rebadge another agent and put it straight in, is that the trial infrastructure machinery is all there. So for different arms, you can see when we started to add arms, this was the effect when looking at recruitment. So you can see here is how long it took us to get the first tranche in, but then we were up and running with the next tranche in 3 months, and those are the next 2 arms of the trial after that. So we're very quickly able to re-engage with 140 centers and keep the trial running, something which we've done successfully. Now, the other thing that you have to consider when running a trial over a long period of time is that things change. And the standard of care in the control arm changed and has continued to change as the trial has evolved. So in 2015, we were able to consolidate the data on docetaxel. That became a standard of care, so the control arm had to change. And again, when we published on abiraterone here in 2017, again, the standard of care had to change. And that is helped, or was helped, by collaboration with large international groups. Many of you will be familiar with this graph, which is from the ICECAP collaboration, which Stampede and the MRC were integral with the Boston team and others around the world. What that shows very clearly here is the linear correlation between metastasis-free survival and absolute survival. And again, that was hugely helpful in rebadging the M0 component of the Stampede trial, because we could then look at these two arms, which was the abiraterone and enzalutamide arm, and rather than wait for survival, which is what our original plan was, we went for a meta-analysis of the combined trial with metastasis-free survival. And of course that resulted in the publication in December 2021 online, subsequently in print in 22, of the M0 study of the combination of abiraterone, ADT and radiotherapy, which roughly halves the rate of prostate cancer death and has changed the standard of care yet again. Now, it was always our principle to have a major translational element to the Stampede study. And there are two phases of this. As always, these things get planned in a bar somewhere. This was at ASCO in Chicago when Malcolm, myself, Nick, and Gert Attard worked out how to run Stratosphere. And we've added to that the biomedical imaging group, or BIG team. So we have two major translational research projects, amongst others. We have a number of other collaborations. One is the biomedical research group, which is coordinated through UCL in London and headed by Gert Attard. We're all contributory to this, but Gert leads the team. And there's a biomedical imaging group, which I lead at the Christie in Manchester, where we've managed to collect about 24,000 scans from the Stampede patients, and we put that together to define a variety of elements, and I'll show you a bit about that in a minute. This is how the Stratosphere tissue acquisition works. All the tissue from the various centres is brought into a central tissue bank, which is actually in Wales, and then transferred to London, where it goes through a process of evaluation, quality control, and you can see the combination of people here who are working with this. Dan Burney is the senior pathologist, but we've got, in addition to Gert Attard and team, a variety of research fellows of considerable talent, I have to say. And to give you an example of the sort of stuff that comes out, this is the genomic medicine paper in 2022. We have papers which will follow from this, and papers which preceded it as well, which looking at copy number alteration, which is factored for tumour volume. If you concentrate on this graph up here, it's a somewhat complicated thing, but you can see we've got M0s, M1s for high and low volume, and what we can see is the differential response to treatment and the fact that the copy number alteration, even with pelvic lymph nodes, is exactly the same as metastatic disease. And so that is helping us to unpick some of the genomic aspects of the disease, its substratification, and how it responds to different types of treatment. The big group challenged the existing dogma that metastatic disease couldn't be treated by local therapy. It started really with this notion. We published this paper in 2014, which looked at the way in which high volume and low volume behaved in castrate resistance. And so we decided to work on this with Stampede and two very bright research fellows in collaboration with the radiology department at the Christie. And this is how it works. So the scans come in through a central repository, they're assessed, they're allocated to treatment arms, the data is cross-correlated with all the treatment therapies that the patients have had through the MRC clinical trials unit, and we work them out into low and high volume for the treatment and control arms. And of course, that has worked out, as I mentioned this morning, that the bone scan actually is a direct predictive surrogate marker for response. This is the follow-on paper from this piece of work, which was largely from Adnan Ali, looking at the bone metastasis number, 1, 2, 3, 4, 5. And you can see here that this is a continuous variable. It doesn't just go 0 to 4 and then you've had it after that. You do get responses all the way up, but the biggest response, there's the equivalence line, is about here, at 3 to 4 metastases. If you look at progression-free, it's a little longer. So the standard of care in M1 disease for low burden, as defined simply by counting the number of metastases on a bone scan, is radiotherapy to the primary site. We published this in 2018. The follow-on paper with a longer-term follow-up at 8.5 years, we published this year in PLOS ONE Medicine. Now, when looking at burden, no one takes account of the lymph nodes, and this was a glaring omission in our view. We've pulled in all the CT scans, we've quantified the nodal burden, we've quantified the location, we've looked at differential response to abiraterone and docetaxel, and rather to our surprise, this is what we found, that actually, if you have bone and nodal disease, then docetaxel doesn't seem to work. But if you've got bone-only disease, then it really is quite effective. And so the notion that docetaxel is dead is really not true. Now, another thing that's important in a trial like STAMPEDE is the harnessing of the power of the meta-analysis team. And these people you see here are all members of the MRC Clinical Trials Unit meta-analysis team, which undertook, and Ashish and co will probably remember the MRC bladder meta-analysis team. That was these people did the same work. And what they do is pull together the data from trials, and they pull together the individual patient data, and that's an important distinction. This is work which is about to come out. You've not seen this yet, but the MRC meta-analysis team put together all the data from the different trials in M1, looking at metachronous and synchronous prostate cancer. And you can see here, this is progression-free survival by disease volume at randomization. Clearly, there's an effect on disease volume, but actually, when you look at whether it's metachronous or synchronous, the metachronous is very clearly a different disease to synchronous disease. Now, taking that a stage further, we can also look at other things which present something of a surprise. And I draw your attention to this. And again, this is going to be in the same paper, but this looks at clinical stage. And this has not yet been done. This is the clinical stage of patients receiving docetaxel. So you've got low volume, CT1 to 3, T4, high volume. And look at this. These are patients who've had docetaxel. Now, this is previously unrecognized, and we all know that prostate cancer produces, in some circumstances, really bulky tumors in the pelvis. And nobody pays any attention to that because it's a systemic disease. But actually, the use of docetaxel in this setting, produces a really huge survival benefit. And I think we may need to revisit exactly how we manage these patients. Now, in these final few slides, I'm just going to show how you can link the national data sets which are available in your countries to the trial data sets for real-world validation. And we've been doing this with STAMPEDE, with data sets like the National Prostate Cancer Audit in England and Wales. And you can see the kind of stuff that we get information from. We have very accurate hospital episode statistics. Every time a patient comes into hospital for a procedure, it's documented by a code, and we can access that code. We get data from the National Radiotherapy. Every machine in the UK is linked to a central database. We know what patients have had, what their radiation has been, and we can put all this together and link it to treatments within trials like STAMPEDE. Now, I'll show you this series of slides which gives you a feel for the power that you can get from this. So we published this in Cancer Epidemiology. This is on fractures in patients receiving ADT. Now, this is not just radiological fractures. These are fractures requiring hospital admission. These are genuine fractures, joint replacements, and so on. And you can see, don't try and read this table, but these are all codes which equate to a procedure. And you can see the numbers that we work with. 152,000 boils down to about 80,000. So we've got low intermediate risk here, 40,000. 25,000 locally advanced and just under 14,000 M1s. And you can look then at the fracture rate out at 5 years, and it really is quite striking what happens to a patient with M1 disease presenting in England, which is that the fracture rate at 5 years is approaching 30%. And even in M0s, it's not insignificant when you scale that up for the numbers involved. Of course, then, what relevance is this to STAMPEDE? Well, we can back titrate this. And this is work which is going to be published early next year, where we pulled in the fracture rate in M0s and M1s in the bisphosphonate arms of the STAMPEDE study. And once again, you can see what we've done, which is we've taken the STAMPEDE data, we've linked it to the hospital episode statistics data, and we've got really quite substantial numbers, which will show what the fracture rate is in M0 and in M1 disease. And just off the record, I can tell you that if you don't give a bisphosphonate early on at bone protective dose, the fracture rate is roughly double what it would otherwise have been. So it comes down to about 15% from 30% at 5 years. Now finally, this is where STAMPEDE's going. We've closed off STAMPEDE 1 now. We have to complete and analyze the data from metformin and estrogen patches. We have a lot of translational work to do, but STAMPEDE 2 is now going to focus on this approach. So we will take men with metastatic disease only, no M0s this time, and they'll be split into patients who are low volume according to conventional imaging and high volume according to conventional imaging. PSMA will be allowed, but it will not interfere with the randomization. And those with low volume will be randomized to standard of care or standard of care plus SABR up to 5 metastases. In the high volume, these will be randomized into arms A and P, which is basically PSMA-based lutetium and PARP inhibition in BRCA-mutated patients. We're fully funded, everything's ready to go. We'll start this element of the trial probably in January 2023, and it will probably run for another 15 years, and I hope will yield the kind of information that STAMPEDE 1 has yielded. We're looking also at the development of the translation aspects, centralization of images, centralization of tissue, etc. And we're also looking at STAMPEDE International. This is going to be a new departure, and if you consider it like a McDonald's franchise, so there's a brand, which is STAMPEDE, there's a central data repository, which is the MRC Clinical Trials Unit, and there's a protocol. And that protocol can then be applied in individual countries, whether it's in North America, Europe, Australia, wherever it is in the world. The individual country will finance their own trial. The data will be processed through the MRC CTU. And I hope then that we can look at other aspects like surgery, the true role of PSMA, many other things that we can't do in the UK that certain other countries can do. So we would invite you to consider joining in this enterprise as and when we get it up and running. Thank you.
Can I make one quick question? Can you please explain to us, at the beginning, when the idea of STAMPEDE, the ideas for STAMPEDE came together, why surgery was excluded?
Because it wasn't a standard of care at that stage. We were looking at the ultra-high risk, Francesco, and you may recall at that time that there were certain groups, big groups, treating prostate cancer who wouldn't operate on high-risk prostate cancer. So we're looking at PSAs of 40 and so on. When we submitted for STAMPEDE 2, we put in a default, which was surgery, and we planned to recruit something like 750 patients as a preference arm, because it is an unanswered question. We all recognize that. We wanted to get information on it. Cancer Research UK, who were the funders of the trial, said that it wasn't a standard of care. They refused to fund it, and they said, you need a separate trial. Our answer was, you're never going to get a separate trial. So it was a frustrating exercise. I wish we'd have been able to put surgery into STAMPEDE 2. The way we're approaching it is through international collaboration. So we hope you'll consider joining.
So Noel, congratulations, of course, a huge amount of work, a huge number of achievements. Commenting on your achievements would be too easy. So let me address you a cruel question. Based on everything that you have presented, outstanding achievements, what is still missing? If you have to identify a thing that is primarily missing in this design, you mentioned the Stampede too, that may be an answer, but what is your view regarding what could be the next step in order to further improve, to further rise the bar of the quality level of Stampede?
Well, I think that what I would say is get the numbers right. And if the trial is big enough, it's surprising what you can do with it. And I would also engage with clinicians. We have a big trial management group now, which Silke's part of, and the contribution of Switzerland has been important. I would get the trial big enough. I would be patient and wait. So something that is reporting too early is not helpful. And with a commercial trial, there's always a pressure to produce something quickly because obviously the patent's running out, et cetera, et cetera. So in Stampede, we always planned on survival as the main endpoint, and we looked at deaths in the control arm. So we waited until it reached a specific point. What's interesting, actually, Andrea, is that in analyzing the metformin bit, which Silke and I were looking at, the death rate from metastatic prostate cancer is much less. The survival is much greater. So, as a community, we are doing pretty well, I think, from where we were back in 2005.
Thank you. One question by Petros, and then we move to the next speaker.
Noel, congratulations, and really, really inspired by all the work you have done in UK with Stampede. I think it's an example for all of us, right, to follow this amazing paradigm. I want to hear your thoughts about when you were starting designing this study. How do you get, the participation? How do you build the team? Because obviously there are so many different moving parts. And how do you any tips on assembling the team and getting interest in a common goal? And of course, how do you divide credit in that effort? Pragmatic question. Thank you. Great job.
Well, it's a very good question. So coordinating a big organization requires focus, but it also requires inclusion. And so in starting right at the outset, we had a small group that came up with the idea, worked through it, put the basic design together. But then we had to think about how to include the major centers. And by major centers, it's not just university hospitals. Some of the biggest recruiting centers have been our big district general hospitals. Include them in the trial management group, give them a voice, listen to what they're saying, have it minuted. We meet, in the setup stages, we will meet every month to 2 months by telephone initially. Then publication, the TMG members all go on the paper in a specific order. And then the groups that recruit the most are also included as named authors. The rest are mentioned in the supplementary information. I think the third thing is that for the different arms, we've had a policy where we have an individual run with a specific arm. So Gert Attard runs abiraterone, Chris Parker ran M1RT, that's arm H, Silke is running the metformin arm. And so those individuals have an ownership of it. It comes in under the umbrella of the trial management group and everything is minuted and agreed, but that's roughly how it works.
Thank you very much. Congratulations. So next speaker, it's my privilege to introduce to you Professor Gillesen from Bellinzona, Switzerland, who is going to address us with the Swiss experience with SAKK. Please, Silke, thank you for being here.
Yes, so the Swiss experience, and our trial organization is called SAKK, and is a bit about challenges and opportunities coming from a small country. So these are my conflicts of interest, very long. And for our foreign guests, because a lot of people don't know where Switzerland exactly is, especially in the States. I think there's a confusion with Sweden. So that's us. And it's very, very small, 40,000 square kilometers, 26 counties, very complicated, 8 million inhabitants, 4 languages. So this is a country that I guess a lot of you have never heard of. And here, this is our population, and that's also a bit our problem. We have a rather homogeneous population. They all men look like that. And we don't have diversity in our country, plus or minus. We have a very long life expectancy. We're normally in the world number 2 mostly. We have, but also a high cancer incidence population. And one of the problems that is very different, I think, from England is we have an unwillingness of patients to travel for care to larger centers. And also because, 5 minutes for them on a train is already a lot. And Laura is smiling, it's like that. And we have access also to new drugs rather easy. So this is, I mean, very nice for our population, but obviously also makes it a bit more difficult to make someone enthusiastic about going into a clinical trial, because we have Fortumab since months already available. We just ask the insurance when we have even Pembro for MSI high. We just ask the insurance, there is a paper, and we mostly get it. So it's a bit different from other countries. So what was our clinical research group? So it was actually founded in 1965, because most of our old oncologists were in the States. So our kind of the beginners of oncology were all coming from the NCI. So they knew the NCI and they wanted to do something kind of similar in Switzerland, but was obviously at that time not so easy. But they tried for the clinical part to found this SAKK. And SAKK for GU was a time very, very active with Studer, who probably some of you still know. Urs Studer was there and he was doing a lot of trials. But then when he decided to go more European in the OTC, then kind of the GU group died off, or slept a bit, let's put it that way. And then I came back from Boston and I started to do GU, and I kind of revived together with George Thalmann the GU group about 2009-10. So George helped me a lot in that time. And then but we had to start small, so we had these small non-randomized phase 2 trials, mostly in metastatic castration-resistant disease, but we always had kind of a translational part as well, so that was quite good. And then here, I think, you see here, I think that is also a very nice consortium, where I just wanted to tell you that we also kind of part of that via the SAKK, that Karim Fizazi and Bertrand Tombol in kind of grounded or whatever, so it's just like an artificial group, the Peace Consortium, where you as academic group can, if you have more than 3 groups interested, generate new trials, and I think that's quite a nice concept. But you have to find your own money, what is always the problem, as you know. Also in the SAKK, we had some money problems, so that's a bit surprising in Switzerland, but it happened. There were some things that didn't work out as planned. And here is our new organigram that we made. So people realized that maybe on the board shouldn't be only doctors, because they don't know so much about finances. So now we have also financial people and some also politicians in, because what was missing is kind of that political pressure to do clinical trials. And the GU group is one of the project groups in the SAKK. So there is Hem-Oncology and Oncology. And I just show you what we did. So these were all like metformin. I already did metformin before we went into Stampede, but in the MCRPC state. And we had a little bit of activity, very small, but we did a lot of, again, translational research. So I found that very interesting. And then We had some other trials, a maintenance trial with Oternorel. You know probably that this then had to be stopped because the drug wasn't pursued. We have also quite active group members from the radiotherapy, and they did a quite large phase 3 trial for salvage radiotherapy at different doses. And then I think the smartest decision we ever made is to collaborate with Stampede. So I'm really happy we did that, because I know that you also approached EOTC at some time point, and they said no. We as Swiss said, oh yes, please, please. And it was really, I think, probably one of the most intelligent things we did. And then I guess one of our interesting trials, I think, is a phase 3 trial, denosumab monthly versus 3 monthly, and I come to that later. So when you see the last 5 years for the publications, you see in red really most Stampede. So thanks to Stampede, we have been on the author list on a lot of trials. So again, when you come from a smaller country, and I know Italy is very big, but if you come from a smaller country, it's probably really makes a lot of sense to go for phase 3 trials together with other groups. And then you see in green, we have some bladder cancer, specifically because also from the Urs Studer era, there are still a lot of people interested in non-muscle invasive bladder cancer. And that's nice, but that was with the help of German centers. The same thing, as we said, the radiotherapy, we had a lot of help from the German centers. And then we have very enthusiastic radiotherapists who wanted to do a trial in seminoma, and he wanted to do it on his own first, stage 2AB, and I said, Alexandros, I think we have to go to the Germans to make them help us, and we have now published the first paper, so that's quite nice, with a combination, a little bit like Rob Harder does, involved lymph node radiation plus a little bit of carbo, but is clearly less toxic. So this is our ongoing study. That is already the second study in seminoma stage 2A and B, because we saw that's probably, it wasn't enough what we did for the stage B, so we now have like 2 different kind of treatments. We have then a perioperative treatment in bladder cancer, very similar to what has been shown, with also adding BCG. So we have kind of that affinity to BCG, but it was a bit problematic with really having the BCG is not something, I don't know what is in other countries, but in Switzerland sometimes there's a shortage of it. And then we have the phase 1 studies that we have also together with the phase 1 group of the SAKK. And in general, we have a little bit focused, because we are small, on MCRPC, including translational research. And you saw Andrea Limonti, because we have a lot of these guys who have really a fantastic background for translational research. We can do that easily. Salvage radiotherapy, we have the second trial running. And BCG is a bit also, I think, still from Urs, a bit our interest for bladder cancer, and then the seminoma. And I think this is quite interesting, at least for us. So we try to find a new founding opportunity, and that was in collaboration with Santé Suisse. That is a society of private insurances, because in Switzerland we don't have a national health system, we have private insurances, a bit like in the States, I guess. And we tried to make clear to them that they should fund our study, because that study is the prevention of symptomatic skeletal events with denosumab. And as you know, usually it would be given every 4 weeks, and we wanted to give it only 3 weeks, because theoretically that should be enough. It's a non-inferiority trial, so for us in Switzerland, obviously something that is quite a big endeavor. And you see here we decided to have patients with MCRPC, but also with breast cancer. And arm A is just standard of care every 4 weeks, and arm B is a loading dose first, and then every 3 months. And the primary objective is obviously to see that it's non-inferior if you give less. And so this was our kind of slide that we showed to the insurances. So the cost per patient per year in routine clinics in red. If they fund our study with all what the study costs, but you have to obviously give much less denosumab, because it in Switzerland is not very cheap. That would be the cost per patient per year when they would agree with our study. And in green, you see what would happen if we are successful, showing that we are non-inferior. And we were quite successful with that. So at least in the beginning, they said, okay, yeah, we're going to pay for it. So the financing of the trial is kind of cost neutral for them. Potential cost reduction if the trial will show non-inferiority. We hope, obviously, that less toxicity is associated with reduced secondary costs as well for the insurances. And then we said it would give them a good PR if they have a track record for supporting modern patient-friendly trials. And as I said, it did work in this. He's laughing, but I mean, it's quite true, right? So it did work. So they financed. Now they have said, okay, now they want to stop because they are, but I think we're going to finish the trial hopefully next year. So, and then I think someone talked about it this morning, but I think it's also important, and because also like Andrea and like Johan, I'm also involved in EOTC, I think we should also say, okay, there is important clinical questions in rare situations of a rare cancer even that we can only really answer with the global collaboration like the TIGER study. I was very much involved because I was at that time the responsible for the EOTC GU group, and Tom House, who we all know and love, was like first wanted to do the trial with MI&T, and then they weren't really interested, and then I could just get it into EOTC in time to the board that we could start it from the European side. And you have seen the slides. I think it's a really important question, conventional versus high dose in the first salvage. And just to let you know, so it wasn't that easy, right? So Alliance had the NCI funding. For Europe, we had Movember funding, so Movember, really big thank you to Movember. But just to let you know, it wasn't that easy. So the collaboration with Alliance from the European side, Andrea, you may be also kind of having some remembers. So I think I spent hours on the phone, so it was quite difficult at that time. So these international collaborations sound really good, but kind of legally and administratively, it can be quite difficult. So I think we should always think about that. How can we improve? So I think in summary, academic groups are really important for development of new trial designs, as Noel has shown the moms. Then also there is ideas of near equivalence instead of making non-inferiority trials that comes from Ian Tannock's kind of group. And also it's really important to answer important clinical questions that are of no interest for pharmaceutical companies, like the de-escalation trial that I showed you right now, or drugs like our trial with metformin, Noel. So I think there's just no interest or repurposing of drugs. So this is probably something we have to do. And then the main question, I guess we can then discuss these, how can we make international collaboration of academic groups also easier? And I think, can we do them with less bureaucracy? Especially like with the metformin, right? I mean, metformin is well known since, I don't know, 50 years, but still we have to do all the safety reporting as it would be a new phase 1, whatever, bispecific antibody. So why is that? I mean, that's a bit weird. And we all know, you know, all the paperwork we did before. Now it's even worse with the, to be honest, with all the digital stuff that comes in. And I think we would need kind of an advocacy group from all of us saying, hey guys, if we do a dose reduction trial, if I do denosumab only 3 months versus every month, it's not very likely that it is more toxic. So why do I need to really collect all that data? It doesn't make a lot of sense. But there, I think globally we should work on that. And then that is what we try to do with Stampede International. Can we perform the same protocol in different countries, groups, and just share the data. And I think this is something that maybe we should do more and more. Statisticians at least say there is no problem when we decide on it from the beginning. I tried to do it in a very small scale with a acti diet. You can remember our a trial with exercise and diet for patients with prostate cancer together with someone in Australia. Let's try if it's working. But like that, you have much more legal and administrative stuff, and I think the problem with probably then the authorships can be solved. So I guess this is a bit what I think we should do as a community. So thank you very much.
Do we have any burning question? A couple of questions prior to jump to the next speaker. Silke, I have a question to you regarding the Tiger study opening in Europe. I remember very well the initial times, and I remember on my shoulders our work, huge work that we did all together to open up the study in the European territory. And I remember very well that at that time, a few well-selected centers were instrumental with providing high volume of patients, were instrumental for the OTC, for the entire group, to open the trial, at least including the first patient, to have the first patient in, and then being able to open up the study to other centers. So my question is, how about the reverse strategy for groups like SAC, or the same may be for ECOG and other groups, Stampede, not to approach similar groups from other countries, but to approach directly single centers with high volume disease, and then expanding as a bottom-top strategy, rather than, and when focusing primarily on the possibility to having the first patient in and then expanding. Do you think that this reverse strategy may be feasible, more complex potentially? What do you think?
So, as you know well, I mean, we have seen that with the SAKK. Each country you open costs money when you do it not like in parallel. So that's the same for pharmaceutical trials in that sense, right? So you have mostly to decide on like let's say 2 or 3 or 4 countries, depending on your budget. And obviously then it would make a lot of sense to concentrate on the centers only that have a lot of patients. But then the question is, at least when I understood correctly, when you have opened once a country, to opening up more sites is less costly than opening up a whole country. So I think it's always a budget question, right? So is it worth having 3 patients more per year from a small site? How much does it cost? How much faster is then really the trial recruited? I think it's really depending on your question. If you have a very rare question like that one from Tiger, I think it makes only sense if you're opening up from the beginning only in big, like big countries, big centers, where it's centralized care. Whereas Stampede, I think, especially Stampede 1, was so broad that you could really open up also smaller centers.
Practical perspective, in Switzerland, which is like, we call it like a federated country in a way, that you have these different realities within the same country. Is it more difficult or easier to get connected with other centers and do multi-center studies? Or does it pretty much the same as in other countries?
It's in reality probably the same than in other countries. I just always joking as I told Noel, we are all speaking bad English. So we have given up like to speak in our own language because there were so many Germans now, Italians, French working in Switzerland, because there is that brain drain to Switzerland that, I mean, there is only rarely someone who speaks all 3 languages. It's mostly the natives like me, who are like also gone to school in Switzerland. So it's kind of, it has changed from the language part. So we do all our meetings in English, and we do kind of the patient information we do in 3 languages. That's the thing that is more complex. But apart from that, we are not Belgium, we are friends. in Switzerland. So we don't have the fight between the Flemish and the French-speaking. We are quite friendly, independent of the language and the region.
Thank you. So let's move to the next speaker. So it's my huge pleasure to invite to the stage Ashish Kamath, who is first a friend of mine, a good friend of mine, and second, he has so many positions and has made so many achievements in bladder cancer. He's president of the International Bladder Cancer Network, IBCN, founding and core committee member of the International Bladder Cancer Group. And so he will provide us with an overview of what is going on within these instrumental groups for bladder cancer patients. So please, Ashish.
Thank you. Thank you for that kind introduction and also for the invitation to be here. It's lovely to be amongst friends and colleagues and to actually see your institution. It's very impressive. And Professor Montorsi gave us a little history of San Raffaele, and it was kind of eye-opening. So again, on behalf of all my colleagues, thanks for having me here. You know, one of the things that often happens, and it's happened with you, I think, Andrea, as well, is because I've been president of both these organizations, people get them mixed up a little bit. It's the International Bladder Cancer Network and the International Bladder Cancer Group. And I'll go through both of these with you, sort of highlighting some of the differences, because they're both focused on bladder cancer, and they have the mission to improve the care of bladder cancer patients on a global scale. But the way we do it and the way the two organizations were founded and are run are a little bit different. So this is first our mission statement. The International Bladder Cancer Network, as I'll go through with you, was actually founded based on a grant that came to the NCI on bladder cancer markers. So the mission of the IBCN, the N stands for networks and marker. So it's to improve the diagnosis, prevention, and treatment of bladder cancer through the use of markers. The International Bladder Cancer Group, which is IBCG, which is kind of tongue-in-cheek because a lot of our work was done with BCG, so it was IBCG, International Bladder Cancer Group. The goal of that group is to look at the existing evidence, look at the existing trials, and then distill that down in such a way as to where we can inform the healthcare agencies in different parts of the world. We've helped established cancer networks in many parts, Japan, Chile, India, and also to help the FDA, the EMA, and other regulatory bodies with their endpoints for clinical trial design. The membership of both is open to anybody that's interested in bladder cancer. So it's urologists, medical oncologists, translational researchers, pathologists, radiation oncologists, statisticians. Anyone that's interested in bladder cancer can apply and be considered for membership. Now, that is true of the IBCN more so than the IBCG. So anybody here that wants to apply to become a member of the IBCN can. You send in your application, it's reviewed by our board. Unless there's a red flag, you are usually able to be part of the IBCN. There's a nominal membership to be part of the IBCN. The IBCG, you can send in your application, but that is more by invitation only. And I'll explain the differences as to why that occurs. There are no dues for the IBCG because we expect everybody that's part of the organization to put in a lot of effort, and everybody does. So many of you here are members of that. So there's no dues expected from you to be part of the IBCG. Now, just a brief history. The IBCN, like I said, was founded by US-based pathologists and urologists. It was Code, Cardin-Cardo, and Wallman were the pathologists, and Bart Grossman and Yves Fredet essentially responded to the NCI that had a request for application. That's what RFA stands for those that may not know. And the RFA from the US government, the NCI, was to create a bladder cancer network that could essentially use what we knew at that time to harness the data from bladder cancer markers and create a network. The inaugural meeting was in 1997. Again, it was on diagnostic and prognostic markers. That grant was then fully supported by the NCI. And the NCI, eventually, that grant ran out in 3 years. But because of the success of the organization, the IBCN was then formally incorporated in Germany in 2006 and now exists as the IBCN incorporated in Germany. I've been fortunate to be president of IBCN now for almost 12 years, and hopefully I'll be able to hand it off to someone, Peter Black, hopefully, who's currently our secretary. The IBCG was created by urologists only initially, but there was an international representation from Europe, North America, and Asia to address unmet needs. And that unmet need at that time was what to do with BCG. BCG was, we knew that there was a shortage of BCG that was looming on the surface, what to do. So that's how the IBCG was created. The inaugural meeting, again, was in 2006, and we wanted to discuss best practices with BCG immunotherapy. At that point, many of you might remember Sanofi and Merck were the two largest manufacturers of BCG. Sanofi was going to stop manufacturing BCG, and our hope was if you got them involved early, they might not do that. So we had them support the initial meeting, but of course Sanofi went out of the business of producing BCG for various regulatory reasons. The IBCG now exists independent of the initial meeting. It was incorporated in the US more recently in 2018. So now let me talk about the two groups a little bit more in detail. So these are the current board members of the IBCN. Myself, I'm the US president. Peter Goebbels, the Europe president. Of course, we have a secretary general. And you recognize, I'm sure most of you here, Bernd Schmidt-Drager, Steve Williams, Roman Navrot, Lars Dreisgott, that does a lot of work when it comes to markers and ctDNA. And of course, Tillman is our treasurer-elect, so to speak. The membership has grown. So this is the initial small group. This is the next group that met, and this was the most recent meeting that we had, where you can see it's an explosion of the number of members. Like I said, anybody here that's interested and wants to be part of the IBCN can apply. Unless there are red flags, we encourage you to be there, because we're trying to foster young investigators, people that are in early stage of their careers, to meet with more seasoned investigators from across the globe, enhance your career, but also we learn from you. If you have ideas, a lot of these are chalkboard type talks that you give. We are there to help mentor people, grow the network, and essentially improve the penetration of bladder cancer research across the globe. Speaking of research, the IBCN does have its journal, and we partnered with the SUO journal, which is Urologic Oncology, many, many years ago. Michael Droller was one of the original members of IBCN. He has been editor-in-chief of Urologic Oncology since its founding. He just stepped down last year. And so we have a partnership with this journal. Multiple publications. I just cut and paste a few of these on there that come out from the group. We encourage all the young investigators to actually have a lead role in the publications. You can see here that most of these are, if not all of these, are based on tumor markers, whether it's in diagnosis, in prognosis, or when it comes from our international projects, many of which are, again, marker-based, tissue array, et cetera, et cetera. So now let me talk a little bit about the International Bladder Cancer Group. Like I said, this group was founded by urologists, essentially, from across the globe. I'm sure you recognize most of the people here that have a really strong interest in bladder cancer. Professor Maurizio Brausi, based out of Italy, was part of this. And the membership has grown over the years. You can see here we have a large geographic representation. There isn't anybody from Switzerland, because I don't think we knew where that country was. But now that we do, we'll correct that thing. And Andrea, your picture is not here because you have been delinquent. You haven't sent your picture to us yet, but Andrea is part of this as well. But again, this is by invitation. It's experts across the globe, and we try to get more people involved that are involved in bladder cancer. As part of the IBCG, we also have a health services research arm. Steve Williams is the director of that research arm. Petros is on that as well. And again, you recognize many of the faces there. Pat Hensley was a fellow with me last year. He's worked with a few of the people in the audience here. Roberto's over here. And he's gone on to University of Kentucky, and he's doing great work there, but he's part of this group as well. We do have a lot of publications, as you would expect from this group. But more importantly, these publications are such that we try to have an impact on the regulatory bodies across the globe. So our IBCG publications have been referenced in the EAU guidelines. They are part of the AUA guidelines. SITC, which is the Society of Immunotherapy of Cancer, formally has partnered with us, and we're coming out. It should be out fairly soon. It's the guidelines for anybody that is designing any trial in bladder cancer, whether it's metastatic disease, muscle invasive disease, early stage disease, or if it's even diagnostic, because we need these white papers. We need these so that the FDA, EMA, the Japanese Association, any regulatory body can actually say, if you did the study according to A, B, C, D, E, we should grant this drug approval if you meet the benchmarks that are in that paper. And as an example, this was one of the sentinel papers that came out from our group on how to do trials in non-muscle invasive bladder cancer. Before that, you saw the graphic that showed BCG in 1976, valrubicin in the early 90s, and then nothing till 2020. After this paper was published and was recognized by the FDA and put forth in the FDA guidance document, there was an explosion of clinical trials, as you all know, in the non-muscle invasive space. And in fact, when I was at the FDA in 2019, December, getting pembrolizumab presented in front of them, a lot of the questions from the FDA were directed towards what the IBCG had recommended, and did pembrolizumab meet the benchmark, et cetera, et cetera. And of course, then in January 8th, actually, pembrolizumab was approved for non-muscle invasive bladder cancer. So that's the kind of work that our group tries to do, is to help us as a community create clinical trials, design clinical trials, and then have appropriate benchmarks that if the trial meets, hopefully the drug will then get approved without much hassle. Of course, we also have recommendations on how to manage common diseases such as low-grade bladder cancer. As we all know, there's a lot of overtreatment, and we've tried to come up with consensus documents which are in a lot of the guidelines. The AUA and NICE has this adopted as well. This is a more recent publication. This is on BCG exposed, which, as many of you know now, BCG naive, BCG unresponsive, and what do we do with the rest of that, right? So that's another consensus statement. And this one here, shout out to European Urology Oncology, Wei Shen-Tan, who is from the UK and is now in my lab currently, led this effort on intermediate risk non-muscle invasive bladder cancer. This was published in EUO, and Alberto informed me and actually did a social media award to Wei Shen on the most frequently downloaded and accessed paper in their journal. So, hats off to the journal as well. So another example of our reach, because we've tried to make this global. So when COVID first hit the globe, and of course, Italy was an epicenter, New York was an epicenter, we were trying to figure out how can we harness the known immune protective benefits of BCG, right? So using our network of the IBCG, this is again a paper that got published later, but this data came out first. And based on this data, actually this trial was developed. So Mihai Nedia did a lot of the work looking at BCG when it comes to influenza, et cetera, et cetera. Our work as a group through the IBCG led to the BADAS study, which was BCG as defense against COVID, SARS-CoV-2. This was funded by the Bill Gates Foundation in Australia. In the US, of course, it's different. It was funded more by smaller groups. In the Netherlands, it was funded by Mihai Nedia's group. So a lot of work went on with this. And of course, until we had the definite vaccine available, this was being used in many parts of the world to help boost non-specific immune response to COVID vaccine. We do have an annual forum at the AUA, which is the IBCG AUA forum. So that's the work of the two organizations. What are some of the opportunities for collaboration for anybody here or for the San Rafael group? For the IBCN, we encourage you, as you say, as I said earlier, to send in your early stage careers. We encourage chalkboard talks. If you have a clinical trial idea or a drug development idea or even a basic science research idea, it's an excellent opportunity for you to get in front of the experts in the room at a chalkboard level. You get feedback, you take it back to your institution. I have collaborations going on with fellows from all over the globe with me, and then many people from my lab also have mentors that are scattered across the globe. With the IBCG, we are more consensus-based. So we try to have meetings that are based on specific needs. For example, if the FDA reaches out to us and says, we want you to come up with a recommendation for BCG exposed, that led to that publication. SITC, again, Society of Immunotherapy for Cancer, has done the same things. We also help with regional cancer guidelines. So in South America, for example, in Chile, the Chilean government has asked us to come in and help them with their bladder cancer guidelines. We're having that meeting next year in April. Petros, you're going to be part of that. You don't have the opportunity to say no. You're already on there. And we try to help different governments. The ECHO Foundation is something unique. I'm sure most of you know about it. This is the platform that a hepatobiliary surgeon, or sorry, medical oncologist, hepatobiliary, and the founder of Zoom, Eric Wan, founded before Zoom was famous. So this was in 2014, and it has a global reach of 1.2 billion people right now. It's congressionally funded in the US. It has funding in many different parts of the world. It's not for cancer yet. It's used more for other diseases. So it's used for liver disease, tuberculosis, a lot of different things. We and other groups are using the ECHO platform now for the oncology side to have a global reach. It's not telemedicine, it's more telementoring. So if I want to take you, Noel, and echo you, that's what it means. So we'll take your expertise and echo you, you get multiplied 5, 25, 125 times over. So anybody here that has an idea that you think is unique to you, it's your talent, it's your idea that you would like to see echoed in different parts of the world, we do the cancer part of it. If you're interested, just let me know and we can get you hooked up with those. Some of the other things are collaborative projects. Both studies, for example, we have registries that you can participate in, harness the collaborative experience across the globe. We have tissue microarrays, and an incubator really for different ideas and different assays, artificial intelligence based on slides they can upload, many, many opportunities which I didn't want to list here in the interest of time. So with that, I want to again thank you for the invitation and thank you for your attention.
A couple of questions from the floor. So Ashish, you have done so many things, so many achievements, it is impossible to comment all of this. Unless saying, okay, you are a master, super master. Your tweets or retweets by Petros have been already rounded all around the networks. So Petros.
I agree with Andrea. It's impressive what you have done, Ashish. Not to compliment you, but it's really, really remarkable. And all this work and supporting other people, it's really commendable. So congratulations. To Andrea's point, all these opportunities that you raised here and the impact in the field, definitions of endpoints, take a teamwork, right? And also opportunities for mentorship. Could you comment on that work that both IBCN and IBCN provide opportunities for mentees to also show their work? And again, congratulations.
Yeah, no, getting that praise from the two of you is kind of ironic because you guys do so much too. So I think it's, like people attract like people. Everybody here does that, right? But I think what's really important to recognize is that we are doing all of this for our patients, number one. And how can you have the most impact on your patients? Yes, as a surgeon, I can take care of one person at a time. I can train the fellows that come to MD Anderson and they can go in and train fellows. But the bigger impact, and all of us here believe in that, is through our mentees, but then also having a global reach. So that was the impetus behind both these groups. And then mentoring people is very satisfying because not only do you mentor people on how to take care of patients and understand the disease, but hopefully we are able to impart in them the desire to then go out and mentor other people in their country, for example, right? So that's a give and take. And to be honest with you, I learn just as much from my trainees as I teach them. I mean, the questions they ask, the challenges, some of the projects that they come up with, you would never think of on your own.
So Ashish, congratulations again also from my side. So as when I was asked by the AAU to fund the new journal, which is now named European Urologic Oncology, as you know, I was asked to actually put up the possible best dream team ever. And you came to my mind like the representative for bladder cancer, and I didn't expect you to say yes. But after 2 seconds, say, okay, I'm in, and count me in. So you have been one of the most successful associate editor of the journal. So thank you again for your involvement in EAU. So one question for you is about the groups. So we did have some, or there has been some issues about the importance of the International Bladder Cancer, the ICBN?
IBCG and IBCN.
IBCN. So when you give recommendations or you do somewhat your views on certain topics, sometimes your views, which sometimes cover gray zones of that specific disease, become a bit more important than the guidelines in the sense. So do you base your recommendations on evidence-based approach based on systematic reviews, for example, or is it more like your views on that, on specific subtopics in specific clinical scenarios?
Yeah, so first off, Abby, it's hard to say no to you. So when you asked me, I said yes, right? So, but it's hard to say no to you, and congratulations. I'm sure everybody in this room knows how quickly Albie was able to get it indexed and the impact factor, and again, congratulations to you. And also congratulations on asking me a very difficult question, right? So what we try to do, and that's the IBCG. So the IBCN does not come up with guidelines or consensus. That's more of a mentor network kind of thing. The IBCG, what we try to do is look at the existing evidence and do a systematic review, but then recognize that what works in North America may not work in Africa. It may not work in the Netherlands. It may not work in Japan. And we truly want to have guidelines and recommendations that work across the globe. So that's why some of our guidelines might not sometimes make sense, right? Because we may say, well, pembrolizumab is approved, but don't use that. Try intravesical gemcitabine docetaxel combination first before you try pembrolizumab. Now, again, and we do that in North America too, but the reason for that is pembrolizumab is very expensive, and in a country like Chile, they can't afford to use pembrolizumab as first line after BCG, but gemdosi is a lot more cheaper, and even though there's no prospective study with gemdosi, there's experience with 600, 700 patients that show 50, 70% response rate, right? And again, the FDA is coming around. So based on that, the FDA, again, has had a workshop where I presented some of our analyses and data, and I'm not saying they will, but they're considering using gemdosi as a required best practice control arm for any studies moving forward. So you're right, it's not just the evidence in a particular country or particular region. We try to flavor it for a global adoption.
Thank you, Ashish.
Thank you.
So let's move from one friend to another one. Johan Loriot from Gustave Roussy. Johan, you have a very difficult task to summarize in 15 minutes the achievements and works done within the GETUG. Please.
Thank you, Andrea, for this invitation to this speed dating. So I will try to give you an overview of the work conducted by the GETUG. So I provide here a subtitle. So is there still a room for academic clinical research? When you did your review on the past 10 years in bladder cancer, I think you mentioned only one academic trial. So I think it's still a relevant question for us as academic researcher. So clinical research in France in Oncology, mainly conducted by the GETUG, which is a network with 60 centers and more than 100 active investigators. We have one infrastructure to conduct a trial, which is Unicancer. It's the main sponsor for clinical trial, and the funding for us stems from the Ministry of Research, charities. We have two good charities in France, and of course, industry. And we try to collaborate with other groups like SOGUG, URTC, SAC, and other groups in Europe. So the structure of GETUG, basically, it's a multidisciplinary group with mainly medical oncologists and radiation oncologists, but also urologists from the French Association of Urologists, and pathologists, of course, statisticians, and also radiologists. So it's open to all. So I mean, investigators from the public practice and the private practice as well. So we have a steering committee elected every 5 years with the chair, and the current chair is Karim Fizazi. And we try to conduct clinical trial in the 5 different tumors, including the rare tumors and penile tumors. So GETUG was founded 30 years ago. And as you can see here, there is a steering committee with medical oncologists, radiation oncologists, biologists, urologists, and statisticians. And so we have a lot of trial, and half the trial are actually sponsored by Unicancer, and half the trial are sponsored by other structures like university, hospital, or comprehensive cancer center. And of course, to do that, we need to collaborate, and we collaborate a lot with the pharma companies, as you can see here, that funded the majority of our trial. As I said before, we tried to collaborate with a lot of different international partners. You can see on the map that we collaborate mainly in Europe to conduct clinical trial, but also other groups worldwide to share data that we can generate to conduct, for example, meta-analysis. So what is the G2 perspective for clinical trial? What is basically the strategy? The first is we try to develop practice-changing phase 3 trial that could have an impact, a true impact on the management of the patient. And so in this perspective, we try to develop a very easy trial to implement, so like pragmatic trial. Important enough, we have to conduct a trial in rare tumors, that's our mission. And also we try to leverage the data that we generate in the past, for example, to conduct meta-analysis. So here an example of the recent and ongoing trial. You can see here that the majority of the trial focus on prostate cancer, but we try also now to conduct a trial in bladder, in kidney cancer, and still in testis cancer, and we try in penile tumors. So some example of the phase 3 trial and pragmatic trials that we're trying to conduct. So historically, we conducted a trial in prostate cancer, in metastatic prostate cancer and localized prostate cancer. So you can see here a list of different trials that address very simple questions, dose of radiation, combinations, and we were quite successful in the past. And now we try to expand in other tumors, like in bladder cancer with the recent reported trial, the VESPER trial that we report this year, and also in kidney cancer with a very straightforward trial, the Carmena trial, that we report 4 years ago. So the lesson that we got from this experience is that if we can collaborate between urologists, medical oncologists, we can do very important trials. So it's very critical that our group try to attract young investigators from the different specialties. And also, I think one important but very simple message in frequent situation means accrual success, so a successful trial. Another aspect is to try to conduct trial in rare tumor, as again is very difficult and it's not the interest of the pharma to conduct a trial in rare tumors, so that's our mission. So historically, again, we conducted trial in metastatic testis cancer with a G13 trial that Karim reported a couple of years ago now. And we expand next with our experience and incorporating the PET scan in the management of patients with metastatic seminoma that we reported this year. And again, the important message here is that rare situations are challenging, of course. G13 took more than 10 years to accrue the 200 patients needed to address the questions. And to do that, I think centralization of care is critical, of course, in rare tumors. But recently, what we tried to do on top of phase 3 trial and pragmatic trial is to try to develop proof and concept trial based on biology. So here, some example, one in bladder cancer with a neoadjuvant pembrolizumab trial in bladder cancer. So the design was very, very similar to the pure trial. Patients were treated with pembro before cystectomy. But the question here were mainly to address the mechanism of action of pembrolizumab in this situation. And basically what we shown is that the intra-tumor infections by bacteria activate immune system, and this is associated with better response to pembrolizumab. Another example in kidney cancer was the Bionic trial, which was, I would say, a precision medicine trial that addressed the question of the utility of the gene expression classification in kidney cancer, and this experience was recently again reported by Jan Vanno in Lancet Oncology. Another aspect from our group is try to leverage the data that we generate in the old clinical trial. That's mean data sharing. And like many other groups, we try to share the data from, for example, GTUG 15 or the GTUG 12 in the ASCAP project. Another example is the meta-analysis, the artistic meta-analysis, and we provide some data from the trials that were conducted in the past. Here, an example with the GTUG 17 trial. Again, some other example with collaboration with UCL or with the American colleague here for other meta-analysis. So what is working in the GTUG? I think the accrual clearly works, and the collaboration between urologists, radiation oncologists, medical oncologists. I think we can provide good trial in a rare situation, rare tumors, and we're trying now to address different questions in all stages of the disease. So in early setting, in late stage, I think it works. What is not working? I think trial with complex process and infrastructures, it's quite different from Stampede experience for us. Also, there is a time to implement the trial in the context of rapid changing landscape, for example, in kidney cancer or in bladder cancer. And also, in our experience, you can have a very good trial, a very good idea. So you can develop a trial, but if not all investigators are convinced by the idea, it's crash. Here an example with the GTUG 12. So basically, this trial addressed the question of adjuvant hormonotherapy after prostatectomy. Very straightforward trial, and actually not all investigators were convinced by the question. As you can see here, the accrual was quite poor, and we have to stop the trial recently. So one of the most important issues for us in a clinical, in academic setting is to try to accrue patients quite rapidly. A large number of patients in the future are likely to be needed to address important questions, so in phase 3 trial, and probably national group are unlikely to do it, maybe except UK. So we need for a pragmatic transnational system be able to conduct such large trial. So Silke discussed a bit the PEACE program, so that the rationale of this consortium in Europe on prostate cancer. The principle basically is to conduct academic European trial, phase 3 trial in prostate cancer. The sponsor could be any academic group, so a group, an hospital, university. The budget is funded for, is provided for trial by trial. And there is a clear publication rule to make it possible that many investigators are committed to enroll in the trial. So this led to a position paper reported by Bertrand Tombal and Karim Fizazi. And the first experience was a PEACE-1 trial that was reported last year and published. So as you can see here, PEACE-1 was conducted in many countries in Europe, and clearly it was successful. We can accrue rapidly the patient needed to address the question, and finally we were able to report the data very fast. So we have now many other trials conducted in this consortium, like the PEACE-2 that completed the accrual. And again, here an example of the collaboration between France, Belgium, Spain, Italy. The PEACE-3, the sponsor is URTC, but France is participating to the trial, PEACE-4, and now we have 8 trials conducted by the PEACE consortium. We try to expand this experience in other tumors. Here an example in bladder cancer with the ALBAN trial that I'm pleased to conduct with my friend Morgan Roupré. So the question is very straightforward, BCG versus BCG plus atezolizumab in high-risk non-muscle invasive bladder cancer. So we conducted initially the trial in France, and then we tried to expand in Germany, Belgium, and Spain, and finally Germany declined and was not selected due to too many administration hurdles. So we conducted the trial in France, in Spain, and Belgium. But basically, we followed the example of the PEACE consortium. So the visions we can have for the academic clinical research. I think the main goal of academic research is to test new ideas and concepts. And to do that, we have to conduct fast trials at reduced cost without too much bureaucracy. The drug development clearly is conducted by the pharma, is sponsored by the pharma, which is critical, of course, for the patient. But new strategy, combinations or exploration of different patient populations, like patients with rare tumors, clearly is the mission of academic trial. And to me, the academic research is the way to develop the creativity, and especially the creativity from young investigators. So I know that a lot of young investigators are disappointed by academic research because it's a long time, it's very difficult, many hurdles, but we have, as senior investigator, to address these questions, we have to prove that academic research is important in oncology. And the main problem, I think it's not new, of course, is the bureaucracy. And there is three components of this bureaucracy. The first is data security. That led, at least in Europe, in over-regulations, resulting in a reduction in research. So the complexity of the trial and the need to collect so many items, so many data. There is some surveys that show that we use only 10% of the data in the CRF, in a clinical trial. So the unnecessary data capture, the quality of control, is a problem, and the associated overwhelming role of CROs and the increase in costs. And also for we try to collaborate, that probably the discussion we will have, but the data and sample sharing is quite difficult because there is too many administrative delay between two different institutions, so many signatures and validations. We discussed during the break with Andrea how many signatures you need to sometimes to provide to collaborate. So that's a problem we should address. Thank you for your attention, and thank you for Swazig Nenan from Unicancer to give me some figures and Karim from some slides. Thank you.
Thank you, Juan. We have time for a couple of questions. Quick question, if you. Basically, you have already anticipated my question related to the possibility of expansion, as I mentioned to Noel as a for Stampede, the possibility of expanding the activity for J2 studies to other countries, and do you have already initial steps in this direction? Yeah. The bureaucracy is overwhelming. One potential way of minimizing at least the amount of bureaucracy may be, as I mentioned, to try to approach single center, very high volume centers first, and then see whether you may be able to succeed in opening the other studies in the same country.
Yeah, there is different strategy. We try to collaborate between groups. I think it's quite difficult because there is the group has to maybe to approach different centers in the country, so it takes a long time to do that. But it could be a first option, because if you need a lot of patients, that I think the most appropriate strategy. But also, as you discussed, we can collaborate with one single center in different countries. Actually, for Albert, there is only one center at this time with Belgium, and it was an easy process to open the trial in Belgium. So it depends on the trial. Probably it makes sense to do that for phase 2 trial, for example, proof of concept phase 2 trial. But for the phase 3 trial, I think the most efficient way to collaborate is to collaborate between groups, like in PEACE Consortium in prostate cancer. Yeah.
Okay.
Noel, one quick question.
Well, congratulations, Johan. JETUG is a fantastic organisation and has done some brilliant trials. But it's been extremely successful in collaborating in meta-analyses and in designing trials. Just a message really to everybody to try to align the protocols as closely as they can be aligned, so that when it comes to the point where they read out, you can amalgamate the data, and it really makes things a lot stronger, doesn't it? I mean, Artistic has been a good case in point. The meta-analysis of JETUG 15 and so on, been really very helpful.
Yeah, thank you. Yeah, it's clearly a new strategy that we have, because we generate a lot of data, and we realize that this data were not used for the clinical research. So what we're trying to do is to engage young investigators to have maybe idea on this database that we have. Could be a meta-analysis with different groups in Europe. It's just an example, but I think the data that already are generated could be very useful, again, for the young investigator, like Paul did for the Artistic meta-analysis. You know. Thank you.
Now we should have Anders Bjartel connected virtually by YouTube link. So I asked the clinician. So Anders, are you?
Hey.
Yeah.
Hello, everyone.
We cannot hear you.
You cannot hear me now. My microphone is on. So
the volume is very low.
Yeah. Can we increase the volume, please?
Yeah.
So Anders,
can you hear me better now?
Yeah, the Anders Bjartel from Malmö, Sweden, is currently the chair of the European Association of Urology Research Foundation. He's managing a lot of initiatives within the EU and within the framework of academic research in EU. So his task will be to summarize the activities that we are doing within this fantastic association. Please, Anders.
Thank you so much. Now I try to share my slides. Okay, I hope you can hear me well.
Yeah, very well.
It has been a fantastic meeting. Thank you so much. I'm really honored to be invited. I'm really sorry I cannot be with you in person. I returned late yesterday from vacation on the other side of the globe, so I couldn't really make it. But I've been with you remotely since this morning. It's been really fantastic, and I really would like to underline a lot of what has been said already, that collaboration is the key. There are difficulties, we need to be humbled, and there are different ways to go. And we need to look at the more international perspective and also to really collaborate. So these are my disclosures. So this is what I would like to present to you today, a little bit about what is the EU Research Foundation, previous and ongoing studies and registries, and future strategies, and what we believe would be good to work on in the future. The EAU Foundation for Urological Research has been around for quite a number of years now, and the aim is to promote and facilitate and stimulate clinical research, but only basic research also, and set up a number of registries. So we really would like to bring together to create European networks within urological research, and to connect centers, and not only urologists, but also a multidisciplinary collaboration. So if you go to the EAU website, you can find this picture, the composition of the board, where you have a number of extremely talented, good and experienced researchers focusing on clinical studies, registries, basic research, and especially I would like to highlight the importance of engaging the young. Extremely active, and one example is from Milan, Georgic and Daglio, and many others. And you can also follow us on Twitter. So just a few examples of what we have performed within the EAU and what we have supported from the EAU Research Foundation. One of the studies, probably the most successful study, was the study on MRI by the group from London, many collaborators. The precision study was published a few years ago, presented by Vero Kasivisvanathan. And that showed us and really changed our guidelines how to perform MRI before prostate biopsies. So this was a big success. Another study that we believe could be a big success, and this has been discussed earlier today, the shortage of BGG. So one way to go would be to reduce the number of BCD installations. So that was this was a non-inferior study, but it was actually stopped halfway after an interim analysis, which showed that it was not good to reduce the frequency, the number of BCD installations. It was the opposite. So we had to stop the study, but it gave us a clear answer that we should not reduce the number of installations. And that was published in European Urology. And now we are offering young urologists and others to make sub-studies on the database that we have created. Another example, and this is to be humble that we're not always successful, and this was an excellent idea from Andrea Necchi, to treat patients after cystectomy with adjuvant an FGFR3 inhibitor after molecular screening with a Foundation 1 test. Unfortunately, less patients than expected, only about 10%, showed positive screening for the receptor mutations. So unfortunately, we had to stop the study, and that will be published in a report soon. So, and this is an overview of some of the ongoing recruiting registries and studies that we have now. We have great variation here within urology. We have not only oncology studies, we also have other kind of studies. One example is priapism study. This is a registry because we have identified a gap of knowledge in the guidelines how to, in the best way to treat priapism. So that was also an initiative from an Italian young urologist. And then we have the Route 1 registry, we're setting up with T1 bladder cancer registry. So you can find more information about these on the website. And then I would like to highlight again the group from London, Callan Moore and Vero Kasivisvanathan. And after the precision study, now they have started a PRIME study, also supported by Research Foundation, but also from other sources, funding bodies. So the PRIME study would probably recruit quickly. So within 2 years, 500 patients will be recruited. And this is to answer the question, can we go for biparametric MRI in the future, or which patient will it not work for? So it's a non-inferior study, and within the first 200 days, many patients, and almost 10 centers now actually have been opened, and the recruitment goes much faster than expected. So another few upcoming studies. We have the Bravery Registry together with Andrea Necchi and the group in Milan to collect rare variants of bladder cancers. And then more recently, we have now, together with a group together with Eric Barrett in Paris and Juan Martinez Salamanca in Madrid, designed a prospective multicenter study to collect a lot of information about focal therapy in prostate cancer, which will be more and more in focus in the future, we believe. So, but it's been discussed for many years to set up a registry from there to really understand what is the best way to go with focal therapy. So I hope we can get some answers, but that will, of course, also take a number of years. And there will be about 27 centers engaged. So, and this is another recently designed study, initiative from Vienna and from San Raffaele, where we would like to look at patients treated for oligometastatic prostate cancer, diagnosed using PSMA PET-CT, and then to analyze the time until they are castration resistant. So this is also under planning. Hopefully it will start before next summer, and there will be at least 12 centers, different centers from Europe involved in this. So now to also something that we believe will be important in the future, and that is to, we understand we cannot do prospective randomized trials for every gap to fill every gap of knowledge in our guidelines. So we need to look at something different. So in the future, we believe, and it's already been mentioned in the discussion today, that big data is important and to collect and combine data from different sources. So the first initiative was taken by Professor James Endell, urologist from Aberdeen. I'm sure you everyone know James by this time, and he took the initiative almost about 5 years ago. And EU, the European Commission, they funded this IMI initiatives, big data for better outcome in cancer. And it started, so it's been ongoing for almost 5 years now. I've been the deputy academic coordinator on the study, and we have learned a lot. And this is an overview of the group here. It's a big group working together, also with excellent input from Milan Group. And there are about 35 public and private stakeholders, and we have really had a possibility to work together with the industry in this project. And we have learned a lot, and I believe that the industry has also learned a lot from all the academic partners. So this was to collect big data and set up an analytic platform based on innovative tools. So this is the overview of the platform that we have been working on for 5 years now. We will end the work next year. So first, we made a survey to different stakeholders, patient organizations, key opinion leaders, major centers, other centers, etc., to identify the most important questions to address in prostate cancer. And we have a list of more than 50 questions. And then we shortlisted about at least 5 of them. And then we were working on the data sources to collect all different kind of information from patients. And also then a big task was here to handle the data, to harmonize the data. I mean, you can create a big database, but data has been collected different ways in different formats. You need to, and we have image also, besides clinical data, we have omics data, we have images, and so there is really need to know exactly how to handle the data and harmonize the data to be able to, and there are a lot of advanced tools that urologists usually don't really understand, but I think we've learned a little bit on why we can use the new tools and how to collaborate with experts on data analytics. So as in many other studies, I mean, the outcome would be to make it better for the patient and improve the way we practice evidence-based medicine. So, and you can find more information on the website here. So this is just an example of, we have, I think, at least 2 million patients now included in different databases here. And the blue boxes here represent data that has been now formatted to be analyzed. And then we are also still working on some other data sets. So this is from many, many different countries and also from both from the industry and academic centers. So this is something that we have built for the future. And this is the way how we can work on it. We can put data in a central database and use different tools there to analyze it. And we can also use the federated method where data stays behind the firewall at every center who will contribute. And then they will be provided with the tools to do the analysis of the data. And then the results will be exported. And it's up to every partner to decide whether they want to go for the central or federated model. And then now, last year, another initiative from James and Dow was to continue work on big data, but also add artificial intelligence models to analyze the data. And this will then be together with lung and breast cancer experts. And it was again funded by the European Commission for a 5-year IMI program. So we have started to work on this, and the experience from the pioneer, how to identify gaps of knowledge in the guidelines, and to build big databases has been transferred to lung and breast cancer expert. And then we have now included experts on analytics and AI models. So this started about last year, and I think this will be really exciting to see what will come out of it. So, and this is just an overview of the different partners involved. You see the industry, most of the companies are here, and many academic big centers are also involved in this. And then other stakeholders, organizations, the patient, of course, but also EURTC and other organizations. So now the final part will be what will come next. So again, James and Dow, he came up with the idea to create what we call the data haven. And this is to collect real-world data, try to build real-world evidence based on the data, and combine it with what we have learned and what we're doing within the Pioneer and within the Optima program. So, of course, it will be, at the end, better personalized treatment for urology patients. But so this is a little bit outside of the Pioneer Optima, where we will collect real-world data from centers that usually do not have the possibility to contribute very much to the big study, the big phase 3 trials and so. So that will give us a more broad picture of how patients are treated in different countries and what we can learn from each other from countries that are not always have the possibility to participate in the big projects. So, and why would real-world data and real-world data would be so important? Well, we cannot fill all the evidence gaps by randomized clinical trials. And also, data from these big studies usually come from centers of excellence, which will not always reflect what's going on and what can be provided for patients in other countries. And then I think evidence-based medicine in the future will also include real-world data. So this is almost my final slide here. This is how we can put everything together in one context in the future. We have the EAU Data Innovator Project. We can call it the Data Haven, the Data Service, and Evidence Hub, or whatever. And then we are already connected to different organizations from different countries. And the Pioneer, Optima are there, as you see, but also the EAU data space that is being created, but that covers many other diseases. So, I mean, I think we are like pioneers with the project in big data that we have within the EAU today. That is something that can be a template for how the European Commission will work in the European health data space. And also Darwin is a little bit similar to the Optima, that the next step you take in how to analyze the data. And Eden is another IMI project for big data that will facilitate other projects, how to use the new innovative analytic tools. And of course, many more databases can be added to this. So this is how we would like to see it from the EAU perspective in the future. So the future aims would then be to expand the portfolio. We have what investigator initiated, and we are more than happy to get ideas from the young academic urologists in Europe, and of course from other specialties. And at the ESMO meeting recently, I was really happy to see that the young academic urologists are now connected to the young ESMO and young ESTRO, etc. So it's really important to go multidisciplinary in the future. So, and not only project, but also registries. I think it's the future to create many good registries, and then to fill a gap of knowledge to identify from our guidelines. So big data, real-world data, data haven, that is what we would like to focus more in the future. And I thank you so much for being giving me the opportunity to talk to you today online. And I'm really sorry I cannot be with you in person and to discuss, because I think the interactions there is really also really important. So I stop here and thank you so much for your attention.
So we have time for a question from the audience, if any. One quick question for you, Anders. This is Alberto. How do you fulfill the requirements of being a GDPR compliance while you collect this data within the registries?
Well, that's really a key question. Thank you so much, Albie. And yeah, you know, we have discussed that a lot. And the only way to go here is to involve lawyers, and that we've done in Pioneer and Optima, because it's really important to get it right. And it's not easy. And it has also been mentioned earlier today, the difficulty in if you collect data from different countries, how to put them together and analyze it based. And there are some hurdles because of the GDPR, especially also if we collaborate with the other side of the ocean in the United States. That doesn't make it easy for us, but there are ways to solve the problem. And we have already some experience on what way to go.
Thank you so much again for being with us, and thank you for a great talk.
Thank you so much.
Now it's my huge pleasure to have Petros Grivas, who doesn't need any introduction, I would say. So today he will be the voice of ECOG Akron Group, and so he will try to summarize the activities and achievements of the ECOG Akron Group. But I would like to challenge your ability of doing research, of doing so many things for bladder cancer patients and for clinical research, by asking you first what you are not doing within ECOG Akron Group. I'm joking, please.
Mille grazie Andrea, mille grazie Alberto. Sono molto contento perché sono qui con tutti voi in questo congresso con qualità alta.
Petros, the official language is English, so be.
You know, I was planning to say that, you know, Ashish and Phil, don't worry, I will not speak, you know, Italian, but I will give the talk in Greek. So thanks very much for having me here. It's fantastic, and I'm really impressed on the quality of the talks. My disclosure is that at the end of this talk, I will not ask a question to myself. So I will start by giving you some idea about the infrastructure of the ECOG Akron Cooperative Group. Of course, in the United States, there are multiple cooperative groups, SWOG, NRG, Alliance, ECOG Akron, and of course, there are so many initiatives in addition to the amazing work that the JU committee is doing. So let me give you some examples of the amazing work that is being done, and I'm honored to be part of some of this work. So in terms of the structure of the ECOG Akron, there are multiple committees like the Developmental Therapeutics Committee, Imaging, Laboratory Science and Pathology, Therapeutic Studies and Cancer Control Outcomes, in addition to the particular disease groups. And of course, GU committee is a separate one, along with breast, sarcoma, and many others. And shout out to our good friend Keith Flaherty in MGH and Christine Spencer in NYU for leading the Developmental Therapeutics Committee and the Genomics Subcommittee, where we're developing different concepts. And again, it's great to work with all of them and participate in meetings and core groups. A couple of words about different opportunities within the ECOG Akron Cooperative Group. And I would start by saying that ECOG Akron is one of those groups working closely with the NCI, and of course, is being funded by federal resources, federal money. And of course, there are different venues for trial development within the ECOG Akron Group. And many of you might know the effort we are doing with the NCI called ComboMats, evaluating combination of target therapies or non-immunotherapy combinations, in other words, drug conjugates target therapies, in an effort to overcome resistance to single-agent targeted therapies. We have, of course, the ECOG Akron NCI mechanism, and we're working with drugs that have agreements, CRADA, with the National Cancer Institute. And of course, we have a third mechanism called PRECOG, which is a little bit different, and as you see in that slide, the differences. PRECOG works as a liaison, as a CRA, Clinical Research Associate, between cancer centers and industry. in companies, it's a much faster mechanism to get, small phase 2 trials done. Well, actually, we had a trial recently done in the neoadjuvant setting of bladder cancer with PRECOG, and we were able to get it up and running relatively quickly. Obviously, navigating a trial through the ECOG-ACRIN mechanism or the combo match, it's much more elaborate with much more bureaucracy, as Johan mentioned before. And in a kind of funny way, doing trial with PRECOG, it's easier. It's like driving a jet ski. However, the ECOG-ACRIN combo match is much more, I would say, logistically more challenging. It's like having a cruiser or a battleship. However, the impact you can have, right, by doing studies through ECOG-ACRIN and SWOG, other groups, and through the combo match, it's really impactful, having a huge amount of cancer centers collaborating together. So different aspects and opportunities and venues for different phenotype of trials. Very quickly about the advantage of collaborating within the cooperative groups. I give talks to mentees and young investigators, and they ask me, why should I be involved in cooperative group trials? It takes forever to open a trial. Why should I do that, right? And obviously, there are many answers to this question. Key opinion leaders across several fields are available, experience in trials across phases and different cancer types. Mentoring, which is very important. I asked Assis before about his amazing work he has done on that part. And of course, advising on portfolio development throughout trial conception. I think the talent is there, and also the variety of cancer centers well equipped to conduct trials across different phases, using different modalities, radiation, surgery, systemic therapies, and of course, the ability to include rare tumor types. That was a topic of discussion prior multiple speakers. As I mentioned before, if we think about the different opportunities that we have, the registration trial is a big effort, a big mission for ECOG-ACRIN, and you can do that through the ECOG-ACRIN mechanism, but also the PRECOG, this, let's say, more efficient, smaller infrastructure that's available. And of course, international collaboration, which is relevant to this meeting, is possible through the ECOG-ACRIN or the PRECOG groups. And of course, it depends on the ability of the company to commit drug supply and distribution, which is a major issue, even within the United States, right? If you don't have the ability to ship drug, right, to individual pharmacies, you may have logistical hurdles even within the same institution. And of course, there are already international collaboration. I think, Andrea, you have been involved yourself in collaboration between ECOG-ACRIN and different international members, including here in Italy. So a couple of words about the combo match. Many of you might have heard about the previous effort, the NCI match. I was involved in that effort as well. And we realized that, if you target a specific target in the cancer cell, you develop resistance. And I think Noel's question earlier today was about that, right? The need to have, evaluation of concurrent alterations. So combo match is trying to address this hypothesis. But if you have a genomically driven approach and you can target more than one targets in the cancer cells, you might actually hit, the redundant pathways. And what, Jeff, you illustrated earlier today so eloquently, that if you have a genomic mapping, right, through the work you're doing, you can actually map out potential targets and develop hypotheses for clinical trials. So we definitely, collaborate with Jeff and others in the field to have this opportunity to design the genomically driven and biomarker-driven clinical trials. Obviously, the goal here is to reverse resistance early on and improve upon efficacy. And you have to have, of course, safety as an endpoint as well. They're very, it's a wordy slide, but maybe one take-home message from this slide is that you need to have significant evidence of at least additive, if not synergistic effect in preclinical models in order to have a very promising, robust concept that can go through the combo match mechanism. So you have at least a couple of very robust in vivo models that can show that if you target A and B together, it's going to work better than having target A or target B alone. And obviously, this requires huge infrastructure, genomic sequencing, as I mentioned. And this opportunity of this big trial will also allow translational biomarkers, tumor tissue, circulating tumor DNA, collected in a serial manner, and of course, on study biopsies to understand, again, the pharmacodynamics are you hitting your target? And of course, at the end, can you understand mechanisms of resistance, right? And that's how can inform future biomarker-driven trials. And we have a village of people, a city of people, right? Statisticians, clinical trialists, and a lot of bioinformatics folks, genomic folks, as we discussed earlier with Jeff. And I think that's a beautiful way to develop drugs. It's a hypothesis-generating study, signal finding, and that's in one slide, the infrastructure. You have a designated lab, and you can have genomic testing that's standard of care, right? That being used in different institutions. There is no funding dedicated from the NCI for the genomic sequencing, so we rely on commercial available platforms like what Jeff said, or academic developable platforms as well. If the patient has genomic alteration that may be of interest, can go through this combo match mechanism, sign consent, eligibility criteria, and this match box can help with allocation of particular treatment for this particular arm, and then the patient starts for treatment, and then we have biopsies during treatment and at the end. This is the first wave that actually is launching. I am honored to be part of the working group of genes and agents for the combo match trial. I'm learning a lot myself about this mechanism, and it's a very robust filter and review process, how we select, out of, multiple proposals, those that have the highest chance, the highest promise to develop a positive results. And these are the first 1, 2, 3, 4, 5, 6, 7, I think I count 8 or 9 groups there that are actually planned to start in the next couple of months, probably the beginning of 2023. And this is really, really exciting to see the first wave of those trials and different targets being developed. There are multiple examples of other targets that are being looked at, and we have every 2 weeks we have a call with the genomic subcommittee, and we discuss the potential concepts and review and give feedback to young investigators who come up with ideas targeting, for example, HER3 or HER2 or another target, TROP2, in different tumor types. And this can be a basket trial design across tumor types, or can be a cancer type specific design only for bladder cancer or breast cancer, depending, of course, on the target and the biological role of this target in particular tumor type. So it can be either an umbrella study or a basket study or individual tumor type. Obviously, a lot to say about the GU Cancer Committee, led by the amazing Dr. Mike Carducci from Johns Hopkins. We have Dr. Naomi Haas leading the renal cancer subcommittee, Dr. Glenn Liu leading the prostate cancer subcommittee, and Noah Han, good friend, the bladder cancer subcommittee. And very quickly, I want to illustrate examples, just a flavor of what we're doing in the bladder cancer subcommittee. Of course, we don't have enough time to cover all the amazing work being done in prostate cancer and kidney cancer, which is really, really humbling to see what my colleagues are doing in the ECOG-ACRIN group with Naomi, Glenn, and Mike's leadership. But I'll tell you a little bit about bladder cancer specifically, and I will go by disease stage, and I will start by the non-muscle invasive bladder cancer. We heard brilliant talks today, and with Assis' work with IBCG and collaborations with FDA and CI workshops, we now have definitions and also relevant endpoints in clinical trials. And one example is a trial led by Dr. Max Gates in collaboration with Noah Han. They're both in Johns Hopkins. This is BCG, and this is BCG naive non-muscle invasive bladder cancer. We all recognize the issue of BCG shortage in the United States, and the FDA is open to trial designs that actually potentially evaluate new agents compared to intravesical BCG. So Max has designed a study, 870 patients, intravesical chemotherapy, gemcitabine docetaxel, compared to intravesical BCG. Primary endpoint is high-grade event-free survival. The trial is now approved by CTEP, is ready to go, and we're very, very excited to have this up and running and stratified by the presence or not of CIS in the 2 cohorts. Another study, and I was telling Phil about this a few minutes ago, is the ECOG-ACRIN 8192, and that trial actually is chaired by Dr. Ginny Hoffman-Sensins, and I'm honored to be the co-chair along with Dr. Margolis. And that trial is specifically for patients with upper tract urothelial cancer, for both cisplatin-eligible patients and cisplatin-ineligible patients. The former is being randomized to dose-dense MVAC, with or without durvalumab, so chemotherapy plus minus durvalumab, is actually supported by great work by the ECOG-ACRIN 8141 that Vitali and Ginny already published, that look at dose-dense MVAC as a single regimen that showed a pathological complete response rate about 14%, but significant downstaging. The question is, can you improve upon that with addition of durvalumab, and this is actually already up and running. I just considered my first patients a week ago, so looking forward for more centers and sites to open the trial. And this is cisplatin-ineligible unfit patients, durvalumab gemcitabine combination, and of course we're going to do this through the mechanism of ecocacrin and the collaboration of multiple cancer centers in the United States. Moving to bladder preservation, that's another exciting study I'm honored to be part of as a translational co-PI with other colleagues. It's Oncology 1806. This is bladder preservation. Patients get maximum TURBT, and they get randomized to chemotherapy and radiation with or without atezolizumab. So the question is, do you add benefit, do you add value or not by adding atezo anti-PD-L1 to chemotherapy radiation backbone? Primary endpoint is bladder intact, event-free survival, and patients get randomized, as I mentioned, after maximum TURBT. It's up to 9 doses of atezolizumab. This trial is more than halfway done. We're hopeful to finish accrual in the next year or so. So looking forward to be able to present the data in the future. And another trial with my colleague, Dr. Monica Joshi, she's in Penn State in Pennsylvania. This is a stage 3 patient population with lymph node positive disease. We don't know how to treat these patients really based on prospective trials. We do induction chemotherapy, and then in patients after induction chemotherapy first, they get randomized to chemoradiation plus minus durvalumab, and then there's a second randomization to adjuvant durvalumab or not. This is a very, very important trial. Hopefully, we'll be able to continue accrual and great effort. Moving to metastatic disease, just a few examples. There's so many trials to cover, of course, here. But this is another trial led by my good friend and colleague, Dr. Silpa Gupta, is at Cleveland Clinic. And this is the main CAV trial, phase 3 trial in the switch maintenance setting. As Andrea mentioned before, we had the practice-changing Javelin Bladder 100 trial that established avelumab as a switch maintenance therapy in patients with response or stable disease to chemotherapy, right, as a first-line treatment in advanced urothelial cancer. So the question is, building upon the avelumab alone maintenance therapy, do you add value by adding cabozantinib on that? So it's patients who get platinum-based chemotherapy, they have response to stable disease, they get randomized to avelumab alone, standard of care, right, and by itself or with cabozantinib. This is up and running, and again, I'm honored to champion this trial through the ecocacrin mechanism. This is a trial that a schema, actually, a slide that Noah presented a few weeks ago at ecocacrin, just to show you the different trials that we have mapped out in bladder cancer and how cooperative groups play a role, right, in the different disease settings and spaces. As you see, I showed you with red other trials that are being done by cooperative groups now, and I showed you Max Gates' trial with intravesical chemotherapy versus BCG. There's an alliance trial that it's pembrolizumab gemcitabine, and there's also interest in doing intravesical treatments in those patients with these agents, which is, I think, very, very interesting. Joshua Mix have done some pilot studies with intravesical pembro. I told you about the bladder preservation trial. I told you about the neoadjuvant upper tract, and there is also a great trial by Gopa-Iyer in Alliance looking at patients with DNA repair gene mutations. These patients may get chemotherapy in the neoadjuvant setting, and depending on the response to neoadjuvant chemo, there's evaluation of potential bladder preservation there. Very innovative trial. We need more data in this setting. Of course, many more trials, immunonutrition. Matt Galsky is doing a trial based on circulating tumor DNA in the adjuvant setting. Of course, many trials in metastatic disease. We're now thinking about the future and whether we should develop trials with antibody-drug conjugates plus immunotherapy. A lot, of course, to cover, but definitely impressive data in the field. And many, many trials that we try to map out. Very last slides here, 2 slides about cancer screening. My personal bias is that 10 years from now, hopefully, we'll put many more resources, and we'll have hopefully more successes in cancer prevention. Going back to ancient Greek, right, literature and history, Hippocrates was saying that an ounce of prevention, right, might be more important than like tons of treatment. So my dream, if you wish, is whether we can use, more efficiently the technology, the tools we have to prevent cancer. Can we do that in a primary prevention, right, avoiding risk factors, eliminating smoking, reduce obesity, implementing vaccines? Can we do also early detection, like secondary prevention? And in these 2 slides, I'll very quickly show you my thoughts I made these slides for ECOG ACRIN plenary session a couple of years ago. Can we use ctDNA for cancer screening? And I was honored to represent ECOG ACRIN in a working group in the NCI, led by Dr. Monica Berdagnoli, who is now the NCI director. Monica is a great visionary. So we talked about using ctDNA as a platform there. And we had discussions about the patient population, the testing strategy, how are we using liquid biopsies that Jeff mentioned earlier? How do we design this study in a very heterogeneous population, right, across different risk factors? How do we select our patients based on germline mutations, maybe smoking, patients who have high risk, high propensity of developing cancer? What will be the right endpoint in this cancer screening trial? How do we do this in a centralized operation through the NCTN, the National Cancer Trial Network? How would we collaborate with industry, right? And having existing studies being used in that way, and how we develop funding mechanisms and have a cohesive work incorporating labs and clinical practices in a compliant way in order to eliminate disparities and develop strategies for cancer screening using ctDNA in the clinical trial setting. And of course, as I finish here my talk, I think the National Clinical Trial Network represents this amazing opportunity to do practice-changing trials, leading these efforts for using ctDNA for cancer screening, early detection of minimal residual disease. Of course, we need a large number of patients to do these studies, evaluate the resistance mechanisms of treatments, evaluate concordance between tumor tissue and ctDNA. Of course, we need, as I mentioned before, collaborations, databases, and registries as an additional platform to complement clinical trial data. You need, of course, think tanks, working groups, and at the end of the day, you need a team in a global level to eliminate disparities and make this a feasible approach with enough sample sizes to answer these questions. And again, in my humble opinion, ideally prevent cancer, so detect it much earlier in order to improve outcomes. A lot of course, data points here, but I think it's a stimulation for discussion. Thank you so much for the invitation. Mille grazie. Thank you.
Thank you, Petros. Outstanding talk as always. So we have time for a couple of questions. Ashish, first.
I have to ask you a question, Petros, right?
Of course.
So, one of the things, SWOG, for example, has adopted a lot of patients into the design of clinical trials. You've been a big champion of having the patient voice. And over the years, if you could share with our audience, how has incorporating patients into the design of clinical trials changed the way you've actually designed and conducted trials? What have you seen, some pearls for our young attendees?
Absolutely, great question, Ashish. I think, number one, when I was first introduced in cooperative groups, I was still a fellow at the University of Michigan. And I was really impressed by the collaborative spirit and also the mentorship going along the way when you present the concept, the feedback you receive, which sometimes is very constructive and helps you improve the project, but also the presence of, as Andrea mentioned before, a patient advocacy voice, right? And how that helps us identify what is value for the patient. And that's relevant when we think about trial design, what is acceptable, what is not, safety endpoints, and also what is a meaningful, valuable point, adjuvant trials, right? Disease-free survival versus overall survival, right? This is a big debate. In conferences, we cannot agree with each other, but let's ask the patient. What does the patient think, right? That's an important paradigm. And because of the successes we have seen, number one, in feasibility, accrual of trials through cooperative groups, then I think we get positive feedback to design more trials. At the same time, when we see practice-changing trials, and cooperative groups have been really, really successful. If you look at ASCO plenary sessions, right, in the last 10 years, many of the practice-changing trials are from cooperative groups. So yes, it's an elaborate process, a lot of bureaucracy, a lot of logistical hurdles. It takes a long time to open a trial. At the end of the day, these trials represent a huge opportunity for practice-changing results, and I strongly advise and recommend to the younger folks, my mentees and others, to join cooperative groups. It's also an opportunity for networking, visibility, and feedback, and mentoring.
Thank you. Jeff.
Pembros, I wanted to ask you a provocative question on the end portion of your presentation, which was wonderful. I think you like science fiction, so this is a little science fiction. Do you perceive that ultra-sensitive ctDNA will someday detect mutations in a patient with no symptoms and no possibility of imaging or detecting or by endoscopy where the mutations are coming from. And without ever knowing and never wanting to know, the patient is treated with maybe just routine cytotoxic chemotherapy in a low dose until their sample is mutation negative. And then they're under continuous surveillance to keep them mutation negative, hopefully then preventing them from developing the cancer that was in a thousands of cells state rather than a trillions of cells state.
Jeff, you are visionary as always, and I think your question is very timely. And as I mentioned before, I think we're experiencing this enthusiasm that the novel technology that you mentioned can enable us detect ctDNA at a very early level. I think that's probably a reality to detect the ctDNA earlier. We have studies, from Dr. Meneta Liu and others, and you have done also work with, of course, your amazing platform. I think the big challenge we have is, what does this detection mean in terms of improving clinical outcomes? What is the value added if you detect that in the 1,000 cancer cell level, ctDNA detection level? What does it mean in terms of improving survival? And that's where the big question is. And I think there are studies being launched. That's why the NCI convinced this think tank. That's why I think some companies in UK actually opened already trials to answer this question. The challenge is how you design that trial, right? What is the right endpoint? If you look at overall survival, it will take forever, right, to read this trial out. Can you rely on an advanced stage endpoint? Do you do a stage-adjusted mortality? What population you use? And at the end of the day, who is going to monitor this patient, right? Yeah, of course. Who is going to monitor these patients? These are no cancers from the CAT scans. Are they going to be internal medicine doctors? Should we think about building in our cancer centers a precision oncology prevention wellness clinic to deal with these questions? I think it's happening, and I think your point is well taken. The question is, how do we prove the impact, and what should we do? What treatment should we do? Surveillance, that are active questions.
I think this is wonderful, your answer. Reason I thought of it was because of the recent experience for me, the first, and as a pathologist, a shocking experience at a molecular tumor board in my own institution, where the patient had chest CT mass, palpable flank mass. Liquid biopsy was done. KRAS G12C was detected, along with an NKX2 amplification, which means TTF1 was present. So we even knew from the liquid biopsy it had to be lung cancer. But the point was pathology did not have enough tissue to make a diagnosis. So medical oncology said we're treating the patient anyway. And the patient responded dramatically, felt better, and the flank mass could not be palpated. And then pathology said, we can't give you a diagnosis. Please set up another interventional radiology-guided biopsy. And medical oncology said, no biopsy planned, no histologic diagnosis required.
Impressive.
And this was the major experience for me, a patient doing well on targeted therapy who has no malignant cells anywhere in their medical record.
It's really inspiring to hear these stories and create more questions, right? Stimulate more questions. What is the optimal trial design to prove the clinical utility of liquid biopsies in the prevention setting? Huge opportunity. Hopefully, we can do that together as a team. Thank you.
Thank you, Petros. Thank you. Let's move to the final presentation. And now it's time of my partner in crime, Phyllis Peace, who will deal with the foundation of the GSRGT, the Global Society of Rare Geotumors. I admit I am biased because I have a lot of memories related to the foundation of this society. Actually, my memories are not very much scientific because I remember since in the very beginning of the discussion in the night time with my wife about the logo to provide to the society and something similar. So I'm digressing. So please, Phil, let us know what is going on.
So thank you so much. I applaud everybody here. We're in the final, we call it the 9th inning stretch, so we're finally nearly getting there. But Andrea, it's heartwarming to, first of all, give this talk here because the origins of the Global Society really lie in the foundations of this institution as really the co-founder of the Global Society of Rare Geotumors. And I think, You know, there's not much good things that happened during COVID, but I do think this society was really got its legs and its origins really during a time where we could do a lot of things virtually. So thanks for the partnership, and I'm very excited to share, I think, a lot of our, early achievements, but I think more importantly, our horizons in the coming years and months. So I don't have any specific disclosures other than my roles on the NCCN and with Andrea on the ASCO EEU panel, and in my role as the president of the society. So a historical perspective. So as Andrea shared with you, the society is really a grassroots effort from some conversations, and I would say research collaborations that Andrea and I have shared over the many years together, is realizing that ultimately rare cancers, as was discussed previously, are really underrepresented, particularly in many parts of the world where there's a large number of these cases are being seen and ultimately are not represented in clinical trials or in peer-reviewed publications. I also like to take a step back and sort of say that when we talk about rare cancers, we're not only talking about testis and penile and adrenal, we're talking about variants of various types of cancers. So defining what we're ultimately talking about and what the society is about is one of the critical steps. And we'll talk a little bit about our pathology committee, which has been pivotal to the early achievements of our work. So the society started back in about 2 years ago. Really, again, Andrea and I, and Andrea serves as the vice president and really the co-founder of this society. But really, we began by really looking and reaching out to many parts of the world where really we had leaders, we had people who were very engaged and wanted to do research and collaborations with us, like for example, India and South America, but it really didn't have a venue to do so. And I think this has really been heartwarming, is they've taken on this role and this opportunity and have really stepped up. And I think we've seen in recent months, I think, some early achievements. This is definitely possible related to strong leadership and at partnerships. And I definitely thank Professor Montorsi and Briganti for really working with us to make sure we can work with organizations like the EAU, for example, as well as the COW with Alejandro Rodriguez, and as well as other societies like the SIU. You know, I will share some slides with you. Is we had a global society, a rare tumors essentially session at the end of the SIU, really again showing the engagement of major organizations to want to work with us. And on that means I think we're very engaged to partnering again with similar societies who have similar interests and opportunities. So I will say that our mission is really focused related to advancing the care related to managing of rare tumors through global collaborations of the scientific community. And I think central to this is we want to make sure we're central in patient advocacy, making sure the patient's voices are heard. You know, I think that's a theme that we've heard throughout these talks today, is not only in the design of clinical trials we discussed, but the endpoints need to be relevant to the patients, not only to us as clinicians. So infrastructure, we have a lot of leaders that are part of this global society. We've had really great partnerships, and I would say many of these actually you see here, particularly on the left side of the screen, are patient advocates. For example, for peanut advocacy, ORCID has been really central to our work. The Testicular Cancer Society, many groups like the VHL Alliance have reached out to us to want to do webinars and educational platforms and venues, and I think that's really been something that's been spectacular. I definitely want to take a minute to also recognize Gagan Prakash. Gagan has been and has taken on the leadership role at Tata Memorial of Urologic Oncology, but Gagan has been an incredible leader for us in India and many parts of the world that have been underrepresented. So this is the infrastructure. We've been fortunate to have people and leaders like Ashish that have worked with us on our membership and partnerships. And I will tell you, and we're going to highlight, I would say, some early successes. We have a few subcommittees which have really hit home runs in the sense that they've really taken on this role and opportunity to really elevate it. And I think Diego mentioned one of them. To me, the Adrenal Committee has been a really spectacular committee who have done some really great work. I encourage people who are looking for a great platform in clinical practice of, you know, how do you work up an adrenal mass? How do you treat an adrenal mass? What are treatment algorithms and diagnostic algorithms? You'll see the link to the adrenal website, and I would say it is a really, really good one. It was highlighted in European Urology a few months ago, but I definitely encourage you all to look at it. So much like my colleagues, our society is, I would say, probably at an earlier level of evolution. I would say we're still growing. We're still looking to take on additional roles and opportunities. But I will say that this is one, the article which I say was central to really raising global awareness to the global society. This is a Nature Reviews Urology, which Marco Bandini, who's been from this institution, as you all know, has been a great leader, and I would say one of the definitely rising stars within the global society, but also within urology. And really, Marco and the group really highlighted what was critical, which is that you see that there's many, obviously, groups that are focused in rare cancers, but the honest truth when you look at it, and as the next slide will show you, there's a lack of consensus in management across these guidelines. And I've sort of seen that firsthand. I will share some personal notes as having been involved as the vice chair of the NCCN committee on penile and bladder cancer for many years, and now seeing the ASCO EAU guidelines and being involved in those. There's a lot of heterogeneity in how we treat. And ultimately, the roots of that ultimately is the level of evidence really in terms of how we care for patients is really still at a very rudimentary level, particularly for rare cancers. And I just have a few slides to sort of illustrate this, is when you look, for example, on management of penile preserving surgery, you see many parts of the world, and this is a JCO Global Oncology piece that is in preparation at this point, you see that there's high level of heterogeneity on how we do this across the globe. High focus, particularly in centralization centers in Europe related to penile sparing surgery, for example, but you see many parts of the world, particularly in Latin America, for example, high degree of lack or heterogeneity on how that's done. I would say that's unfortunate. I think who ultimately pays the prices are patients and their families. This is another example to illustrate as well in terms of management and I'd say management of nodal status in patients who are clinically node negative. You see that dynamic sentinel lymph node biopsy, for example, in North America, low level of penetration versus high degree of more inguinal lymph node dissection. But again, you see it's across the board and how we do this across the globe. So how on earth are patients to know how to treat and how to get their given care when we can't even agree as a global community in doing so? This is also related to chemotherapy. I would say IMPACT trial, as we were discussing earlier, hopefully will give us some answers related to this. But I would say we see this just for centers that we've tried to engage for the IMPACT trial is there's a lack of utilization of neoadjuvant chemotherapy in many European centers versus in North America, that's a little more advocated. But that's based on a phase 2 study of 30 patients. For many of our diseases, you'd be laughed out of the room if you presented this at ASCO GU and sort of said that was standard of care based on a trial of 30 patients. I also think this really highlights that there are really great resources out there for patients. This is a issue of seminars of oncology nursing, and Catherine Patterson reached out to us, and she's part of our group. And this is a dedicated issue of this journal to rare cancer. So if people looking for, it's a free resource, it has a number of different articles, but also this article I think is timely because it was written by patients, for patients, and it highlights all the various resources for patients out there related to rare cancers. So what have we achieved in the last 18 months? Well, I think we've done a fair bit, but I think far more to do. We've clearly had, and I would say the first global symposium, which we dedicated to penile and testicular cancer was, I would say truthfully, and I disclose I'm biased, was wonderful because we had the people who designed these clinical trials in testicular cancer and penile cancer debate among themselves the strengths, weaknesses, and where the horizons of this were going to be. And we had patient advocacy specific sessions highlighting again what are the unmet needs. I will say as well that this was very well attended. We had over 500 people attending, many of these being global clinicians across the globe who were really engaged and wanted to sort of learn from ultimately this global initiative relating to elevating patient care. These are some of these areas and resources, and ASCO, for example, has been a great resource to us. I definitely acknowledge the SCO, the SIU, EAU, and the CAL for really wanting to work with us. And Ashish, thanks for facilitating some of the work we've done with Euro Today and OncLive as well. And then for Petros. Petros is social media guru, as we all know. So in terms of our subcommittees, this group has really been fantastic. I think if we can mimic this across our other disease sites, we will be incredibly successful. And that's, I would say, the gauntlet is passed to all the people in this room. If you want to be engaged in various initiatives to elevate the care of rare cancers, we're always looking for motivated, interested, and engaged colleagues and trainees and faculty. And Andrea has facilitated a lot of this, but this group has really done a really fantastic job. They've really sat down with global leadership across the world to try to look at this and try to develop good educational and clinical resources. This is the website, and this is what it sort of highlights. again, in terms of how you manage patients, and really providing highest level of evidence. And I would say it's going to be, we're just redoing our website right now. It should be hopefully launching in the next month or two. But it really highlights, I think, a great resource that you can go for, and when you're sort of in clinical practice and trying to understand how you work up these masses. And this is, again, some of the resources related to it. Roger Lee, as Ashish and I know, has been a great, I would say, young, innovative thinker in the bladder cancer space. And he's worked with his committee, and Jeff has been a big part of this. I think the partnership that we've had with Jeff and Foundation Medicine has really been very important to us, because clearly in rare cancers, there's great opportunities to understand these tumors a little bit better. As we all know, it's very hard for our pathologists to agree on sometimes characterizing these tumors. So I think looking a little deeper in terms of the mutations, in terms of actionable sites that we could target these tumors is a great opportunity. And Roger's really focused in bladder cancer, but I think this has been one of the first area the genetics committee has sort of focused, is really to look at variants of bladder cancer. And the first one is CDH1 mutations. Jeff will be proud of me not to specifically state histological variants related to this, but I will tell you that it's really been great work, which I think highlights, what we want to do. We want to focus on variants. We want to focus in tumors that are underrepresented. And again, I was mentioning earlier, have global registries of these patients so that we can look at this and understand a little bit if there are differences in practice. You may all know this, but I was at a meeting about last year, and I had colleagues from Chile mention to me that their incidence of testicular cancer in certain parts of Chile are 10 times higher than they are across South America. We need to understand why that is. I think there's still a lack of characterization, even in our current day and age, understanding these tumors. So again, this is some of the work that's being done, and I think a publication is being prepared related to the work on specifically plasmacytoid, but specifically CDH1 mutated tumors, which I think will definitely carry fruit. And as I mentioned, this committee here, Lara Herrick is a director of pathology. She is also involved in the leadership of the U.S. Cancer Society, Clinical Pathology Society in the United States, and she's also taken on some global leadership. But Lara and her team have really started developing some great webinars for pathologists related to characterizing these tumors. As we all know, as surgeons or clinicians, if the diagnosis is wrong, oftentimes our treatment will be wrong. So Lara has sort of engaged some of the global leaders in these various tumor types and to try to help develop the tools for our pathologists to understand and to really standardize the characterization of these tumors. One of the fundamental questions I've sort of passed on to Lara, and she's developing at this point, is as a society, before we're going to sort of move forward, we need to define what a rare tumor is. As I mentioned to you, to me, it goes far beyond 3 tumor types. It goes to characterizing these tumors and to the work that Jeff has sort of been doing, looking at mutations as well and sort of sub-selecting and understanding the ones where particularly we're challenged in clinical care is the ones where we should clearly focus our energy on. And I would say that if you're looking for a great resource for your pathologist, I would encourage them to reach out and to us, because those pathological resources and webinars are online and are available related to penile, testicular, adrenal tumors, for example, and there's other ones currently being developed as well, like on urethral cancer. On that note, I would definitely want to sort of highlight that our global summit, the first one, which we had 3 years ago, which unfortunately, 2 years ago, sorry, which was again a virtual meeting, clearly in a setting of COVID was the only way to do this, was highly successful. But it really is something which really highlights where we want to go. And I'm looking at Laura here, who's doing some great work with our group related to developing some journal clubs. We have one that are being developed specifically in VHL, which I think is a wonderful opportunity. And also developing some tumor boards across centers across the globe so that we can learn from one another and also integrate, I think, the expertise of clinicians throughout the world in terms of clinical care. The summit we got and the feedback we got from the first global was overwhelmingly highly successful, but clearly this is just a start in terms of what we want to do. And last but certainly not least, for us to be successful as a global society on rare tumors, it takes great partners, and I couldn't be more blessed to work with Andrea as my partner in crime. I think that's really been exceptional. Gagan, I would say, has taken this on to try to grow us as a global society and brand. And I definitely see that there's very exciting things happening in India and South America, which we'll be definitely sharing. I was just at a meeting in Morocco a couple months ago, and they would want us to partner to be part of their Moroccan society meeting for many years to come. So we're looking for global partnerships. That doesn't mean to say that we want to sort of distill our brand and our identity, but really it's to really help elevate leaders and experts across the globe, make sure they're represented in developing a common message and improving patient care. Last but certainly not least, as I mentioned, this is our website and the resource that we have, and I have both myself, Andrea, we need to change. For some reason, we still have your old website, email, but we'll definitely do that on the next slide. But I think one thing that we wanted to highlight, and I think I applaud, my partner again in crime for doing this, is global clinical trials. Clearly, as Noel was sort of sharing, and I applaud the initiative of Stampede to do this, is in rare cancers, there clearly needs to be an effort to do this together. Obviously, it always comes down to financing when you do trials, but there are ways that we could do this very innovatively, very creatively, and also using some essential fundamental standards of care and really understanding, for example, surveillance strategies, or when we should ultimately potentially negate certain types of approaches, and when ultimately we should try to standardize other types of approaches or diagnostic tools, and definitely more to come. I think Andrea sort of wrote this, I would say, global perspective piece, but I really do think it's critical and fundamental to the society as well. We clearly know access to innovative, effective treatments like IO, for example, across the globe is very sparse, particularly in many parts of the world where ultimately there may be some financial challenges in getting so. And we need to equate this to make sure patients who benefit from this have access to this. But we're only going to be successful in doing so if we take this on as a global brand and as leaders from across the world in doing so. And along those lines, I do think that requires strong partnerships. Partnerships not only with societies, but partnerships with leaders and people who care for these patients across the globe. And developing, as I was mentioning earlier, some probably prospective registries of patients in these disease sites. We clearly need to raise the bar. You know, every time I give a penile cancer talk, which is an area of focus of mine, I'm always sombered by looking that the outcomes for advanced penile cancer have not improved in 15 to 20 years, just because we still don't even have a fundamental understanding of the efficacy of systemic chemotherapy in patients with bulky nodal disease. And I think, truthfully, that's really not acceptable in our current day and age, that we still have these fundamental questions which we can't answer. Last but certainly not least, these are my information resources. And I also like to highlight Rare Cancer Day, which we're involved with. We also have some efforts and initiatives with the WHO related to rare cancers, which we're very excited about, which Karia Mwala is leading on our behalf with the society. Thanks again for your attention. Happy to answer any questions you may have.
Outstanding overview, my friend, as always. Is there any question from the floor? I felt completely all your words, everything that you have mentioned, which is in our blood, basically. And we felt since the very beginning how the interest from people, from colleagues, from underrepresented countries has risen, like India, like Africa. We had, since the very beginning, a strong collaboration, for example, with Morocco, with Karia Mwala, who was my former ESMO fellow. So it was extraordinary to realize how collaboration between colleagues and between academic institutions may rise, particularly when focusing on underrepresented countries, which should be the focus, like disparities, like gender disparities, like ethnic disparities, race disparities, access to drugs, a lot of things to do. Is there any question? Umberto.
Thank you, Phil, for your presentation. I think this is amazing. I was wondering if you are going to each single country and healthcare and so on, because I feel that the first limitation now for the care of those patients is the fact that each hospital can treat a single patient for a year with this kind of disease. So to limit the treatment of the patient only to tertiary care center in each country can be, the way to improve patient outcomes, but also to accelerate and facilitate the fact that all those patients will be included in this kind of society, in this kind of analysis, in this case, in this kind of translational research program and so on. What do you think?
So that's a great question, Alberto. I'm glad you asked that because, I think that's a critical fundamental, I think, lack of, I would say, opportunity to improve patient care for penile. Let's just take the example of penile cancer. I always say that the Europeans have done a really exceptional job developing regionalization of care. And I always like to mention this. A few years ago, the AUA asked me, they wanted me to develop a debate as part of their crossfire session in penile cancer. So I said, let's have a debate about management of penile cancer, and we'll have LUGPA debate with an academic institution. And the unfortunate thing is it's so politically driven that many parts of the world, it's challenging, but it shouldn't be. The reality is those patients benefit from going to regionalized centers where they see high volume of institutions. You know, me and Andrea have talked about this. In an ideal world, I think our global society would like to try to give some level of consensus or try to enhance, I would say, the vision and mission related to that. I think the early, efforts that we're having is by having and engaging patient advocacy, our goal is to help patients identify where they should be treated. And I will tell you, the example is testicular cancer, for example. Testicular Cancer Society reached out to us to help develop those and define those across North America, but potentially globally. And I think that's where we don't want to be prescriptive where patients go, but if patients are seeking some level of facilitation, we want to work with the national organizations to help facilitate that for patients.
Silke, you have a question? Or Jeff?
It's me again. Phil, that was a wonderful presentation of an organization that's not only growing, but impressing everyone as it grows. One of the things that's come up, and I wanted the whole audience to hear this, is the definition of rare, because we think about it right now morphologically. Mm-hmm. These are rare cancers. Their histology is rare. It's a cancer subtype we don't see often. But then there's the rare in a cancer we do see often, like urothelial bladder cancer or prostate cancer that has a rare driver that's not usually found in that disease. NTRK fusion-driven bladder cancer. HER2 amplified prostate cancer. Those are rare tumors also. So we have to be able to be, how do we say, nimble on our feet to think about it in two different ways. It could be a histologically rare from the, I hate to use this term, old days, but it could be now genomically rare in the new days.
Silke?
Yes, I guess that, and then also in the more frequent cancers, there is also rare situations now. Mm-hmm. So not only maybe rare subforms because of a specific mutation, but rare situation like neuroendocrine dedifferentiation or, I mean, whatever, or like salvage therapy for testicular cancer, that's rare to begin with, and then, you know, the patients who relapse are even rarer, so I guess I totally agree with that. And then the other thing, so how are you collaborating with Eurocon, for example, or with MAGIC? Because I think we have actually a lot of these kind of vessels, and sometimes I feel, I mean, I was fighting a long time, Noel, maybe like remembering that we at least would do the European guidelines together, EAU and ESMO. And, you know, because of the societies, and I have to say EAU was fantastic with James and Doe, for some political reasons, it wouldn't work out. So sometimes also I think we, as PIs, investigators, whatever, should maybe be stricter in saying, actually, it would really make sense to have one guideline, maybe worldwide, or maybe at least in Europe. So just, there's also always that political thing, right?
Yeah, so we've kind of lived it as a society because I think one of the first questions the EU asked us through some discussions is, obviously there's the Urologic initiative which is taking place. So some of the conversations we've had with their secretary is, what's the mission of the society? And I'll be very truthful, we want to promote global initiatives to elevate the care of rare cancers like Urologic. But our focus is a little bit different, related to elevating knowledge awareness related to those clinical trials and patient advocacy. And if there's things that Urologic or other societies are doing, like innovative trials, I think that's where we can serve as a conduit and vice versa, related to if they're looking for a resource. I agree with you. I think it is a little bit of a space where it's hard to define what your role is at the end of the day. But I think if we do this successfully, I think we could ultimately elevate the care for our patients.
Very last question by Noel.
Yeah, Philip, just, you said you don't want to be prescriptive about this, but I'm afraid unless you are prescriptive, you won't make it work. In 2002, we sat down, a small group, and we wrote the National Cancer Plan for the UK. Mm-hmm. And what that said was that for rare cancers, penile and testis, you had to centralize it. And if you didn't centralize it, you wouldn't get paid. You were not allowed to treat penile cancer or testis cancer. And I went round as one of the two people who wrote this guideline and had a conversation with lots of urologists who said, well, why do you want to take away an operation that's so straightforward? To which I said, well, if you want to work out in 25 years what you're going to do to improve things, you'll be no further on. And so the guillotine came down, literally, on small units. So we're seeing 1 to 3 cases per year. So in our center, we look after 8 million for penile cancer. We look after 6.5 million for testis cancer. When we analyzed the pathology error on district hospitals diagnosing penile cancer, it was 1 in 5. It's now nowhere near that. And the same radiologically, our inguinal lymph node dissection rate came down by 30%, straight off. And so unless individual countries are prescriptive about this, you'll never sort this out, particularly with penile cancer.
So great. I'm glad you brought it up because I agree. The U.S. is a little bit of a challenging space to do this, as you well know. I will tell you what I predict will happen out of initiatives through impact is that the accrual to these trials is identifying that there is, in fact, centralization of care. I will tell you, when you look at impact in North America, there's about 4 centers who are putting about 90% of the patients. It's MD Anderson, it's my center, Emory a little bit, and others. So I think it's so politically driven, but I think the data will dissipate to identify that ultimately those patients should be cared of those institutions because they are the centers of expertise. And I think that's when we could take a little more of a data-driven approach related to, for example, penile cancer. I think testicular is a little more mature for that, but I think for penile, I think impact is going to be helpful for us to be successful with that.
Thank you, Phil. So it's time to close this fantastic session. Thanks again. And it's my huge pleasure to invite here Valentino Di Mattei, who will chair the last session, which will be fully dedicated to the patient advocate groups. So we will hear from the patient side what is going on regarding collaboration and potential expansions. Please, Valentino.
Okay, great. Good afternoon, everybody. I think we can now move on to the last topic, which has a really fantastic title, Patient Voices. Patient Voices, which already hints at what we're going to be talking about and from which angle. I would like to start our session with a quote from a very famous, very well-known psychoanalyst. His name is Michael Balint. I think many of you have already heard about him. His Balint's groups are very commonly used in hospital settings, and they are used to support doctors, nurses, and healthcare workers. And once during a meeting with other doctors, Balint addressed them and said, You often spend a lot of time talking about your patients, discussing your treatments, but you always have to remember that the first medicine for your patients is you. And if you listen to them, and the more you listen to them, the more your treatment and you will be effective. So that's why I'm really happy to start this session. And considering we are a bit late, I'm quickly going to introduce our speakers. We are very lucky and honored to have here 3 of the major associations operating in Italy and in Europe too. So I'm going to introduce them. I would like to, considering we have less than 1 hour, I think 30 minutes, I will let you talk one after the other, and then we'll take time at the end to discuss. I will ask you to tell us about your associations and what do you do for your patients. Thank you so much. Firstly, Anture is represented by Claudia Ungarelli and Tonia Cinquegrana. Over to you, Claudia.
Thank you, Valentina, for this kind introduction. Hi, everyone. My name is Claudia Ungarelli, and I'm here today as a patient advocate together with Tonia Cinquegrana on behalf of Anture, the Italian Kidney Cancer Association. We're very grateful because when we were invited here, we received the invitation and we thought we would just participate as audience, but instead we are also here in the role of speakers, so this is a great opportunity for us, especially on this important day. So thank you so much, Andrea, for the invitation. We thought it would be a good idea to use this moment to give everybody a brief introduction about who we are, our development, and our projects. But before we get to that, I would like to start with our why. Why should we, together, be advocating to engage our patients in all aspects of care? To answer this question, I would like to use a quote from a colleague of yours, Dr. Michael Jewett, who we had the pleasure to meet last month at the International Kidney Cancer Summit, not so much far away from Milan. As many of you know, Michael is part of the International Kidney Cancer Coalition board and professor of surgery at the Princess Margaret Cancer Center and University of Toronto. He gave the inaugural International Kidney Cancer Coalition clinical lecture last summer in July at the European Association of Urology, which was titled provocatively, and it reads, "Patient engagement is a potential blockbuster treatment that urologists should prescribe for their cancer patients." The intent being that, taking a look at the data, and this was a secondary endpoint of a large study with over 700 patients with metastatic disease in New York. Here, a randomized selection of approximately half of the patients had access to a reporting system of the side effects of their therapy and to an educational program on the toxicities of their therapy that allowed for early therapy changes. So if they had a side effect, they recognized it as such, and secondly, they had access to report it rather than waiting for the next scheduled appointment. The result of this study, interestingly, showed an overall survival advantage for patients with access to this monitoring and reporting system compared to those without. There is, as you can see from the curves, which I'm pretty sure you're very familiar with, there is at least a 10% survival advantage among those patients with access consistently over time. So it appears that this engagement strategy, this patient engagement, was the equivalent of a drug, a blockbuster effect therapy. Had this been the outcome of a clinical trial for a new drug, probably this would have been approved by the FDA or by the European Medical Association for use in the clinic. Here there are a couple more papers about this topic along these lines. So here are breast cancer patients, and they received a bi-weekly psychological support session that involved education, and you can see very clearly all survival metrics were improved by that strategy. And here there is a similar intensive program that involved not just psychotherapy, but also physical exercise and other informational sessions. This interesting data really struck with us and speaks to an important point. A, patients' engagement is beneficial, and consequently, we should all be advocating to engage our patients in all aspects of care. By engaging them, their lives get prolonged. So what clinicians can do to encourage and support patients' advocacy and engagement? Here there is a list of bullet points, and so to go briefly through it, they can develop strategy to encourage patients to participate in engagement activities, including support for advocacy groups, or as well as patient educational program, encourage patient-centered care by a multidisciplinary team, provide timely access for reporting clinical side effects, and endorse patient advocates and their mission, as well as listening to patient voices when designing guidelines and clinical trial. And I think we heard a lot of conversation today about that. So I want to go briefly to talk a little bit more about Anture. So it was October 2007 when, on an online website forum, some patients started looking for information about their disease and the therapies that were successful at the time. Does anyone use this drug beside me? Does anybody have similar collateral effect? These were the initial questions, and as you can imagine, the conversation became a hot topic and more people joined the online discussion. With the arrival of Facebook, two Facebook groups were created, which still exist today. These are a space where patients and caregivers and their family can tell about their ups and downs, their struggle, and hear as well the experiences of others and learn from other patients. And it was in May 2020, so we are quite newborn, that it was decided to form an association. This is how Anture was born, which is the synthesis of the common experiences of patients, caregiver, and their family. And now, on the sideline of this, I would like to give you a bit of more information about my personal experience. So my first close encounter with metastatic kidney cancer was on the other side of an oncologist's desk, next to my father as the patient. So when my dad was diagnosed as metastatic, given that the next scheduled appointment with the oncologist was like 2 weeks down the line, I desperately started looking for information online. As you know better than me, you should never do that because many statistics are just outdated and the picture just looked very, very dark. So randomly, I bumped on Facebook into Anture, and they helped me, giving me hope, as well as they gave me practical information on the next steps. So I became my dad's caregiver and advocate, and at that point, I offered help to Anture, whose mission is to help patients and their families, guarantee the best possible quality of life to them, access to modern treatments, and protection of patient rights. In order to achieve this goal, Anture supports studies, scientific research, and communication activities around the topic of kidney cancer. So the next thing I would like to talk about is a few projects. The next thing I would like to talk about is the challenges that patients bring to our attention. So when they contact us, they ask for tips about how to deal with second opinions, questions on side effects, questions on post-operative process, question about the post-surgery trajectories, question on the lines of therapy, how to participate in clinical trials, questions on where to go to get surgery, and information about complementary non-invasive treatment. And also, many patients contact us to have information about genomic testing, and we recognize that there is widespread disinformation about kidney cancer patients on this topic. And also they call us because they have this sense of abandonment and lack of empathy and participation from the doctors with regards to their journey. I must admit, it is very heartbreaking for us to watch all these people go through that. We were born during COVID, but despite being born during such challenging times, we managed to carry out some activity. So together with FAVO, the Italian Federation of Voluntary Association in Oncology, we produced a booklet on kidney cancer. We organized a bunch of events. We held webinars on the important link between nutrition and kidney cancer, together with Dr. Francesco Trevisani and Dr. Ariana Bettiga from Raffaele, who many of you probably know already. And we carry out public affairs activity targeting European and Italian institutions, such as writing letters, participating to institutional events at the Italian Ministry of Health, as well as the European Parliament. We have established a scientific committee that is currently a work in progress, and we work together with Elma Research and Ipsen to carry out a qualitative research project named The Quality of Life of Kidney Cancer Patients. I would like to just show you a very short trailer of the video, which collects the testimonies of patients with kidney cancer.
Ho sempre paura, sempre, costantemente. La serenità non c'è più.
Questo equilibrio tra una possibilità un po' cupa e la possibilità invece di lottare per evitare che questo accada, insomma, con tutte le mie forze.
Io per 3 anni non ho avuto più nessun problema e dico la verità, pensavo, chiusa lì, è finita, è stata una brutta ma bella esperienza, è finita lì, è andata. Ecco. Invece purtroppo non è stato così.
All'improvviso ho urinato sangue e ho avuto un giorno così, questo sintomo improvviso.
La terapia è stata una terapia sopportabile, ho avuto poi dei problemi più in là, però insomma diciamo che non è una chemio, non perdi i capelli, e quindi questo mi ha dato forza e mi ha dato anche un discorso veramente di dialogo, di aspettativa un po' più positiva, ecco.
È molto difficile comunicare con gli oncologi, per cui ti senti un po' solo, un po' abbandonato.
All right, so this was just a shorter version of the video. There is also a longer one. If you're interested, you can find it on our website. So, project in the pipeline. We're looking for a sponsor for the publication of a booklet on kidney cancer, especially regarding the link between nutrition and physical activity. We would like to launch a forum on our website for Q&A for patients and caregivers of kidney cancer, and have experts reply to those questions. We wish to organize an event on issues related to kidney cancer, focusing on therapies and genomic testing. This because, as I said before, we recognize that there is a lot of disinformation about among kidney cancer patients on this topic. And also, we want to start soon the organization of bi-weekly webinars on the link between kidney cancer, malnutrition, and physical activity. So we are hopeful and ambitious. We really hope to be able to carry out many more projects, and we are really grateful to be here today. We would like to solicit support from all of you. We think that there is an opportunity for clinicians to step up and take more of an advocacy role within their healthcare system, and somehow we as advocates, we need to bring you the voices of patients to come and walk this walk with us, because we're just so much stronger together. Dr. Jewett told us this anecdote from a clinician in Japan that I would like to retell you. Michael had asked a Japanese clinician, how did you get Nivo approved so quickly? And the Japanese clinician said that the doctors of the Japanese Association talked to the government, while at the same time, patients group in Japan had a letter writing campaign and got over 1 million signatures to approve nivolumab swiftly. So this is the power of advocacy, and this is to reiterate the message of why it is important that clinicians and clinical organizations to be partners with the patient advocates, because at the end of the day, we are all here for the same reason. So before wrapping up, I would like to thank Andrea for giving us this great opportunity and a platform to speak on behalf of kidney cancer patients. It's an honor to be here. We would like to thank Fabiana Laurenti, who is in the audience, who recently graduated from her master's degree in Sciences and Technique of Preventive and Adaptive Motor Activities, who shared with us, in memory of her mother, her thesis, focusing on the link between motor activity and kidney cancer, and who designed a motor protocol that was recently awarded for kidney cancer patients. And I wish to thank Dad and all the other patients who are the reason why we're here today. I would like to conclude our presentation using a quote from Nobel Prize Rita Levi-Montalcini: "Above all, don't fear difficult moments. The best come from them." May this be a good wish for us all. Thank you.
Thank you very much, Claudia. Okay, there's a question.
Outstanding talk, Claudia. Really outstanding and visionary talk. If I may suggest a potential room for improvement, my impression when treating renal cancer patients, mainly, or for the majority of cases, at least as a combination therapy with the oral drugs, is that we could improve a little bit regarding the compliance of treatment, the monitoring of the side effects at home, meaning that there could be an opportunity for you as association to strengthen your activities with people like research nurses, and we have here some people like that, working on this side, because they may be instrumental for you in closing the gap from clinicians and also from you and the patient bed and the patient home. So my impression is that one of the many ways of further improvement is related to this particular feature of renal cell cancer therapy. It is quite unique of renal cancer. Renal cancer is not felt as a burning need, for example, in bladder cancer. Maybe in prostate cancer, maybe similar, but in the renal cell cancer patients that are younger, so this point may be felt as more urgent. So this is just a comment and an opportunity for next work. Compliments.
Thank you, Andrea. There's another one here.
So I think this is great. I think it's wonderful to see initiatives like this for patient advocacy. I'm just wondering, I've done some work with the KCA and the kidney can in the U.S. I'm just wondering if there's not opportunities for this patient advocacy group, which clearly has an important voice nationally, to potentially partner with a KCA, for example. If ever there's interest, I think Brad Leibovich has taken that on. I think that would be a wonderful person to reach out to. And they were very vocal, and I think they're looking for a lot of global opportunities for partnerships. So that would be someone or a group to consider partnering with in the future.
Thank you.
Actually, just to expand on what Phil said and something along those lines. So to take from the bladder cancer world, there's the US, there's the UK, there's Canada. There's all these different advocacy groups, and then there's a unifying global body just called the World Bladder Cancer Association that acts as a conduit between the different groups. So I'm not that familiar with kidney cancer advocacy, but if there isn't a conduit, I mean, that's something that you could consider starting or creating a group, because rather than just partnering, because that sometimes gets hard with national, international interest, creating a conduit. So the World Bladder Cancer Association essentially serves as a conduit for the different bladder cancer advocacy groups across the globe and helps translate the US to UK, to Canada, to India, to different places. That's an opportunity. And the other thing is what you were talking about. I know that Apple is currently looking for compliance with pill monitoring with their watches, and they have a seed grant application out. If that's something for oral therapy for kidney that you're interested in, I'm sure they would like to see it from a patient group rather than a physician group.
Okay, thank you so much.
I may just make
Oh,
a very quick question. You know, it's so exciting. I cannot stay silent. I try to stay silent, but congratulations. And thank you for inspiring us for doing what we're doing. It's important. I think you mentioned before that patients are the reason we're all doing what we're doing. Two quick questions to help us. In my institution, University of Washington, Fred Hutchinson in Seattle, we're trying to implement a new strategy, a patient navigator. And that phenotype will be a nurse, a clinical nurse, who is trying to be the liaison, right, the mediator between our busy clinic and the patient, and help the patient come in the system, break the ice, sort of speaking, and help prioritize the patient's needs. What is the first need, the second need the patient has from this particular visit? So the first question, actually two related question is, what in your mind are the most important needs or priorities that the nurse navigator should ask the patient for? And secondly, do you see an opportunity for like a patient-driven, kind of support group to help other patients, like a peer-to-peer, patient-to-patient survivorship program? Again, mille grazie.
With regards to the patient's navigator priorities to ask to patients, what do you mean in terms of needs?
Give us some advice of what are the main questions we should ask the patient and in terms of what the needs are when they come to a medical system with cancer. And anything that comes to mind.
Probably psychological support. We see in a lot of patients that there is a sense of abandonment and is, at least for the experiences that we heard, is not very much integrated into the Italian healthcare system. Probably also to elaborate on what their diet and physical activity is, because we believe that a multidisciplinary approach has to be the key and not just a silos approach. And you have to repeat now the second question because I forgot.
Thank you. That's actually very, very helpful. The second question is, we try to, sometimes we have patients who are about to undergo cystectomy, right, or nephrectomy, and they are scared about it, right? And they said, how is life, after removing the bladder or the kidney? So we try sometimes to have another patient who has undergone that surgery, has kidney or bladder removal, to talk to that patient, try to match them. But usually we don't have enough
patients, you know, we try to develop an increasing list of those patients. Any suggestions of how to create that pool or list of patients who can actually coach, you know, new patients who are coming in, like survivors who can help the more new patients?
Many times there is lack of awareness with regards to potential activities that are out there. So I think it begins in my personal opinion, but it begins in the oncologist office to provide this information to patients. We would like to see more involvement from the side of the clinicians in saying, look, there is this patients advocacy group, and that way, if you start engaging patients, then they can also help out other patients, and so I think, thanks for your question.
Okay, thank you so much. You can have a seat here if you want, so we can, okay. Secondly, we have Palinuro Association with the President Edoardo Fiorini. Please, if you come with us. Okay. I know you have a very rich presentation, so I can't wait to listen to it.
Excuse me. First of all, thanks for staying. I suppose that in this moment of the day you have to be very tired. I need to sit, excuse me. I have a problem with vision. So, my name is Edoardo Fiorini, and exactly 10 years ago, it was November 2012, I started my 4 cycles of chemotherapy, neoadjuvant chemotherapy, before my radical cystectomy that I had with new blood that I had in the March 2013. Exactly 1 year later, Palinuro is born. We inspired by the American BCAN, the most important patient advocacy association involved in the bladder cancer all over the world. The main promoter in Italy was Andrea Necchi. Andrea is the name. Palinuro is an idea of Andrea. In the 2019, Palinuro was one of the founding members of the World Bladder Cancer Patient Coalition. Since our Palinuro is born from medical, from doctors, the cooperation between doctor and patient was a primary important items from the beginning. It was really a leitmotiv. A cooperation that sometimes seems to be a paper boat from sailing in a stormy sea because of the environment where we live. But also sometimes acts as a bridge in the communication between the patient and doctors. Communication that it is not always easy. Even if a relationship between a doctor and patient is one of the few human interactions with the same target, the patient health. The patient target are to heal, feel better in general, seize the best of the quality life. And for this reason, the patient fights the disease with all his strength. Also, the physician mission is to fight the disease, but in the struggle, the patient's emotional anxiety is sometimes disregarded. While on one end, some doctors are totally concentrated on their fight, on the other, patient risk of being considered only the container of their disease. The disease may sometimes react and fight back subtly, or it may surrender and let itself be beaten. Of course, there is no struggle with the healed person, but the relationship is based on a professional confidence and esteem, and last but not least, on a deep human complicity. But it is not always so easy, obviously. And therefore, owing to their fragility, the patient can be lived by the doctor as a troublemaker full of the defects. It can seem rude, irritating, annoying, complaining, and always claiming for certainties. Also, when no certainty can be done or can be given. And the factor time is very important because the time is not enough or is often very short. And the supporting the doctor in the management of this aspect is one of the goals of an advocacy association. Returning to the patient, the support of the hospital ward staff is essential, but is limited to the hospitalization. After the patient has come back home, downtime is the most difficult moments. Any sudden pain or disorder can cause anxiety. What is happening to me? Is it normal? In this moment, arrives Palinuro with its purposes to listen, to give comfort, to inform, to share and confront each other about common problems, to be a reference point, to defend the disease rights, to help to improve the quality of life, to be the voice of the patient among who decides, and finally to promote the patient engagement. But the patient wants to know. He needs to clear and easy information, and Palinuro wants to end his own experience on. We are the most convincing information, the living evidence that healing from this disease is possible, as we were our experience. In addition, we are the physical proof of the good job of the doctor, obviously. Meeting a Palinuro volunteer is for a patient an opportunity to solve their doubts, whether they are at the beginning of the tunnel or they are already as discharged from hospitals. Our mission is don't make the patient feel alone, but reminding him that he's not the only one. This is very important. Palinuro wants to help the person to manage his anxieties. And we do this with our publication, with our voice over IP. We have a good and rich of information on our website. We have a monthly newsletter. We are very active on the social medias. And above all, we act on the phone and through email, where we are available 24-hour days, every day, Christmas included. We meet and support each other with self-help groups. We have 4 self-help groups in WhatsApp, shared, concentrated in each moment on the disease, starting from not muscle invasive bladder cancer to arrive bladder, urostomy, and so on. We raise people awareness of the importance of the early diagnosis. In the month of May, we have launched a video created absolutely from our experience. In this video, you can see a person that see the sign that can save his life, and he became afraid, obviously. And the name of this video is Stop at the Red. Video, grazie.
Nel tumore della vescica, un segnale può salvarti la vita. Fermati al rosso.
Sì, pronto, scusatemi, sono Fabio. Ho una piccola emergenza, devo annullare la riunione. Sì, ok, grazie.
Thank you. Thank you. Is our feeling. We have designed the best tool to find the right hospital close to home. It's something like TripAdvisor for hotel and restaurant, but it's called Euro Hospital Advisor, with the patient opinions on the Euro department of the hospital where they are being treated. This is the most useful and complete database available online. And on this project, we have realized a second movie that now I show you. In this movie that we have launched only in the May awareness campaign, we see we are involved in the Fabio's wife, anxiety and worries. Video 2, grazie.
Tumore infiltrante della vescica. Sì, è la diagnosi. Secondo te si muore di questa cosa? Ma certo che me ne occupo io. Lo sai com'è Fabio. Non vuole neanche parlarne. Mi sento un po' persa. Ho bisogno di più informazioni. Cerca di capire, Fabio si deve operare. Io ho bisogno di avere un secondo parere. In quale ospedale? Associazione malattie vescica. Okay. Contattaci. Qua. Sì, grazie. Ora mi sento molto più serena, davvero.
Last week, we engaged the patient in our 5th national meeting, where patient met the doctors. It's a very important moment for us. This has been another occasion to reiterate the concept Stop at the Red. Furthermore, we are ready now. We start to have the right side to raise funds for independent research. Maybe this was one of the objectives of Andrea when invented this association. But we have been obliged to wait some years, but now we are practically ready to do this. And an important thing is that a patient association is useful, only if involved parties are aware of each other's existence. And only through a larger knowledge we will reach our first target. Our first target is to grow. This year, in 2022, we reached 250 subscribers, and for us, an excellent result, really. We are looking for new potential associates, obviously, through internet, but also in the places where they go to be treated, in the hospital. And so at the moment, Palinuro's dream is to have a volunteer in each Italian hospital. In 2019, we launched this project, Euro Hospital Angels, and despite the COVID, in 2 years, we are in 15 hospitals all over the Italy. We are accredited. We are in a work in progress with the other 10 hospitals that we realized we will reach during the next year. But obviously, putting a flag is not enough. We want to develop guidelines to integrate Palinuro volunteers into the department and hospital. And above all, we have to share with the doctor what to say to the patient in an ambiguous way. Otherwise, we can risk to disorientate the patient, obviously. Another point, since this evening there are here 2 colleagues of other important association, unity is strength. We would like to create an association network in hospitals, in the hospitals. And our project is innovative because we want, our dream is to realizing a project exactly here in this hospital, as San Raffaele Hospital, involving together with Palinuro and Ture, involved in the kidney cancer, Europa Uomo involved in prostate cancer. I hope to realize it. Our wish, obviously, is to stay side by side with the doctor and learn how to work together without invading their area of competence. Because from now, there is one promise from my side, we will be discreet, a discreet help and not an obstacle, obviously. Thank you. Excuse me for my English, obviously. Normally, I don't speak in English.
Any question from the floor, Andrea?
Eduardo, my heartfelt congratulations for everything that you did for patients with bladder cancer. I remember very well when we started, and we started from 0 also. And I remember very well, and it was
you and me.
And it was crazy to realize that just after discussing the diagnosis, treatment program, surgery, and so on, we just started a few minutes later working on filling the unmet needs in general in bladder cancer, on your side for the patient, on our side from the clinician side, and identifying the needs for the patient that were needed to be filled at that time. Yeah, and it's crazy to realize the achievement that you made in collaboration with the BCAN, with the World Bladder Cancer Group, and I think that the future is really bright for you and for your association. I wish you all the success that you merit.
Now, I understand. Normally, I don't speak English, and so because when I worked several years ago, I was used to speak English. Now, I have some problem, above all, to understand. But we, at an overall level, that means to association, worldwide association, I don't work directly for my problem of language, but I am sure that we have to work together, because in this moment we have to do exactly this. In my eyes, we are doing other things that are not. You have to take the right dimension of each different nation. You have to understand the different feeling, and we have to add our experience to other experience. And in this moment, I see, and excuse me if normally I say always that I feel. And so I have the feeling that we do some research, for example, on patient, but with what kind of result? A result that don't give me nothing on new. I want to discover new things, also in the activity or supporting the patient. On the advocacy, we have a lot of things to do, but we have to discover new system to do this. And for example, with the kind of cooperation that I'd like to do with Tonia and Maria Laura, I suppose that is a trial. We have to test something together. But the main important things when you try to do a networking is to be open, to leave the leadership outside of the door. And it is another kind to work. Only in this way the cooperation can give the important result in my eyes. This is my feeling, obviously.
Okay, thank you very much. In a few years, so many ideas, so many projects. Congratulations. And now, finally, is the voice of Europa Uomo with Maria Laura De Cristofaro. You are the only association that is more than, you are 10-year-old.
Yes,
The others are
20
younger.
years.
So
we were born to 20 years old.
20?
Yeah,
Oh.
yes, ago, yes.
Long time ago.
Of
so.
course, I'm not a patient. I'm a caregiver. And my father was a prostate cancer patient and also a founder many years ago of Europa Uomo. And we are an alliance among patient caregivers and clinicians in different fields, urology, oncology, and psychology, radiotherapy. And we work together as voluntary for a mission, a very big mission, because it's very difficult to talk about prostate cancer. Breast Cancer Association or other association as Palinuro inspire us. So what we do? We are part of a coalition, European coalition, and here in Italy, we have as priorities the awareness and the early detection, because early detection gives the opportunity to choose among different treatments. And to improve quality of life of the patient. And about that, I have some slides, all the slides. Here I have just few, because it's a very wide work. We have made a study about quality of life in Europe. And we support and represent patients, helping and giving voice to patient support groups around Europe. Here in Italy, we have two self-help groups, one in the north, based in Milan, but the patient and the caregivers meet online. So it's very useful. The lockdown was useful because now we have, this group is a large, quite large group, and we have another group in the south based in Catania. And we wanted to promote an alliance among public institutions and social actors, so research, health system, scientific society, patient association, and in general oncological volunteering, media. And we really we really believe that cooperation, also among different associations, is the key. In Italy, we are also building up an alliance among breast cancer patient associations that, as I said before, always inspire us, and other oncological volunteer associations as Palinuro that we thank, and we thank also Raffaele to have invited us and update the program. Now, I wanted to talk especially about this project. We do a lot of things, but we are especially proud of this. This is the first time that such research has been conducted by patients themselves. In 2019, Europa Uomo Europa commissioned Europe-wide research on the quality of life for men with prostate cancer. And it was based on an online survey exploring experience of treatment and life afterwards. The Europa Uomo Patient Report Outcome Study, EUPROMS, gathered 2,943 questionnaire responses from men who have had prostate cancer from 24 European countries. And the responses were compiled by the research company Cielo Health and analyzed by the Erasmus University Medical Center Department of Urology in Rotterdam. Early findings were first announced at the European Association of Urology meeting in Dublin in January 2020, and since then findings have been reported at many scientific meetings and in various publications. I want to show just some of this finding. The first one is this, about how does treatment affect quality of life. And these are the results. So patient sex lives are affected most after treatment. And we can go on to the other slide, the 18, about how treatment and pain, which treatments are linked with pain or discomfort. As you can see, men who have received the radiotherapy plus ADT and chemotherapy experience more discomfort than other treatment groups. I have to show, because we have no time, just a few slides. I'm sorry, but we can find, you can find all the slides among the documents of the Congress. Then this is the 27. Thank you. This shows how is sexual function after different treatments. And the slide shows how radiotherapy is related to worse quality of life than prostatectomy. The other one is 33, is about continence, and how is continence after different treatments. And here the slide shows that prostatectomy is related to worse quality of life than radiotherapy in this case. I'm going to show you the take-home messages, the latter three slides. This is about active surveillance that should be considered at the first treatment in order to ensure the best quality of life. The second take-home message is how early detection is key. And the latter one is one of our mission. We need cancer center with multidisciplinary teams. We have in Italy many hospitals like San Raffaele, for example, not in the south, not so many in the south, unfortunately. but we have to spread this experience, because it's really one of the key to have the best treatment for this kind of cancer. I wanted to say something about Europroms 2.0. We launched Europrom 2.0 in autumn in 2021, and the survey was again a success thanks to the efforts of all members of the board, the European board. And we expect full results by the end of this year. You can find also the link to all these study and research. And I want to finish talking about active surveillance, because Europa Uomo, Italy especially, supports and promotes the use of active surveillance treatment for men with low-risk prostate cancer. Properly implemented is an effective and safe means of avoiding overtreatment and ensuring optimal quality of life, as I have shown you with a slide, for as long as possible. Active surveillance is a treatment in itself and should be considered as valid as any other treatment in stages 1 and 2 of prostate cancer. Active surveillance should not be confused with the watchful waiting programs, which are used in the later stage of cancer. Recent years have seen considerable growth of knowledge on how to apply active surveillance safely. Recent research indicates that this treatment can be useful for up to 30% of patients, those with low or intermediate risk. For this reason, Cosimo Pieri, that is a patient and is a member of the European board, has promoted with Tania Estapé, and she's a member of the board in Spain, who are responsible for active surveillance project, are taking action on awareness of has this treatment among psychologists. There has been 4 webinars, and you can watch them. The first 3 webinars can be viewed in the active surveillance section of the website, European website. I left the link, and also the 4th webinar can be watched on European Europa Uomo Europa's website. I have just to talk about Europa Uomo Europa Guidelines Committee on Prostate Cancer. Eric Briels represents Europa Uomo on the Europa Uomo Guidelines Committee on Prostate Cancer. And the evidence-based guidelines are formulated in Europe, but are influentially globally and are used in countries such as Argentina and China. The prostate cancer guidelines are reviewed every year to reflect changes in science, and patient representatives work with other members, provide a patient perspective, and provide an honest opinion in discussion. So this is our job, especially in Europe, and we have a lot of job also together to do together. Thank you.
Thank you so much, Maria. Any question, comments? It's too late. Okay, we can move on. I think I thank you all for sharing your experiences and for giving us some fresh insights about your associations. I believe you represent a key network of support, very important both for patients but also for us. And your role will be more and more crucial, I believe. This morning we were saying, I think it was Petros who said that it could be very useful to introduce patient advocacy in every board for clinical trials, for example. And Andrea supports this idea. So I think there will be many new things to deal with for your associations. So I would like to take this moment to thank all the organizers, particularly Professor Andrea Necchi and Professor Francesco Montorsi, for organizing this meeting, for involving me, and especially for involving all the patient associations. Thank you so much. It's so important for every association to be involved in such a prestigious context. Thank you so much.
So my closure is very simple. Thank you. Thank you for being here. I think that it was a very inspiring journey for each one of us. Huge possibilities for collaboration, huge data, huge talks. Congratulations to everyone. Congratulations to esteemed friend and the international faculty. Extraordinary talks. Congratulations. And hope to see you soon next year for the second edition of the retreat. Of course, we can improve and we will improve. It's just the first attempt. And see you soon, November, December next year. Thank you.